Good morning, everyone. Welcome to day 2 of the Maternal and Child Health Conference, Healthy Infants and Families, Sustaining Communities Through Collaboration, Best Care Practices and Empathy. I'm excited to welcome you to day 2. My name is Leanna Lavoie, and I'm the Program Director for Tobacco Prevention and Substance Use Prevention Program at Maine CDC. And I'm going to hand it over to Mary Ann.
Good morning, everybody. Welcome back for those of you who joined us yesterday, and welcome to those of you who are just joining for today. Just want to remind you that you want to be able to take some self-care throughout the day, get up and move around a little bit if you need to. It's a long day. We had a long day yesterday. It was really exciting, and we have another very full agenda today full of fantastic speakers. So without any further ado, I'm going to introduce you all to Dr. Shaw, who is the director of the Maine CDC, which many of you probably already know. With that, Dr. Shaw, I'm going to let you kick off this morning's events.
Great. Thank you so much, Mary Ann, and good morning, everybody. Thank you so much for taking some time out of your busy week, your busy month, to spend time hearing about where we are with respect to maternal and child health, as well as the broader array of topics that we're going to be discussing today. From what I heard from my team, as well as saw in the media, day 1 was a success, and we're hoping that day 2 is just as enriching as yesterday's was. In that spirit, we're going to go ahead and kick things off. And I am so delighted to be with everybody, but particularly delighted this morning to be able to introduce our key speaker who's going to be starting off day 2. And that speaker is Ms. Mary Bonato. Mary's been kind enough to take some time out of her morning to join us. And Mary and I are going to have a brief conversation before she segues into a panel discussion with some colleagues as well. But it is really my great pleasure to kick off day 2 by being able to introduce Mary. For those of you who are not familiar with her and her work, Mary is the Civil Rights Project Director at GLAAD, which is the GLBTQ Legal Advocates and Defenders. And she's been an attorney there since 1990. Her litigation and policy work at GLAAD involves state, regional, and as you'll hear me mention in a second, national efforts to secure equality and equity under the law for LGBTQ individuals and those who are also living with, say, HIV. Her bedrock work has been focused on challenging discriminatory systems and policies that have historically and systematically disadvantaged LGBTQ people, people of color, and those who are living at the intersection of multiple disenfranchised identities. She graduated from Hamilton College with a double major in history and comparative literature, and then the Northeastern University School of Law. Many of you may already be familiar with her extensive history of advocacy and legal work in the service of those who have been marginalized, particularly those of the LGBTQ community. Her participation and work in Maine stretches back decades. But for those of us who follow a lot of the legal aspects of this work, one of Mary's achievements has been in 2015, when she successfully argued before the United States Supreme Court in the landmark pivotal case of Obergefell v. Hodges, which was the case that established the freedom to marry for same-sex couples nationwide. And it was Mary who argued that case before the Supreme Court. Closer to home here in Maine, she served on the Maine Juvenile Justice Reinvestment Task Force, the Maine DOE Task Force on implementing the anti-bullying law, and currently serves on the Chief Justice's Justice for Children Task Force, as well as on the Race Equity Committee. We are so pleased to have Mary join us today. So Mary, I'm going to turn things over to you for a conversation between the two of us before we move things over to your panel. Oh, and Mary, sorry, you're on mute.
Now not, every time. Good morning, Dr. Shaw. It's really a pleasure to be with you. Really a big pleasure, and very grateful to you, to the CDC, for really what an ambitious conference you put together here, and what a service for all of us. So thank you for that. And just thank you for everything that I know everybody has been doing before the pandemic and through this pandemic to keep us safe and healthy. I can't imagine the overtime. So very grateful for everything you all do. And I just have to say one more thing, which is, I think my first interaction with you particularly was around trying to lower the barriers for people to be able to amend their birth certificates to put in their correct gender marker, and including an X option, which is something that you were very thoughtful about. Your office put together a good proposal, and regulations were issued that are now actually codified. And it's just so important that people be able to go through life with official documents that actually match who they are, because the mismatch is nothing but trouble and a safety issue as well. So I know that's not all the work, but I just wanted to single that out and thank you for that.
Absolutely, Mary. And it's certainly been a pleasure and an honor to be able to bring that type of policy change to those who need to avail themselves of it here in Maine. It's something that we also happen to have done in Illinois. And when I came to Maine, we had just done something similar there. And so it was top of mind for me to replicate that. But it's an example, I think, of why sometimes things that we don't necessarily think of as either public health measures or measures that are in support of a particular community, why they're really important for overall health. To say, I mean, there's the very tactical, concrete implications of not being able to have government documents that match who you are. But that process creates something that I've been deeply concerned about, and I certainly know you have through your career, which is the way in which systems, in our case, government systems, create walls between who is in and who is out. And that creation of an other category, I think, has profound mental health implications, personal health implications, and thus public health implications. It's something that has concerned me in COVID, but it's the same thread that runs through something like birth certificates, as well as the way that we've created isolated communities.
That's just a fantastic point. And it is so important for people to have documents that align with who they are, because that whole issue of disrespect is cross-cutting in life, certainly in healthcare, and absolutely is a profound source of distress and just undermining who the person is not to have those things. So you were absolutely right about those systems. Appreciate that. And to that point, I wanted to ask you too, would you be able to comment on our having this conversation and this LGBTQI plus focused panel in a conference about maternal and child health and substance exposed infants?
Well, you're absolutely right, Mary. I mean, at first blush, someone might say, well, wait a minute, wouldn't something of this sort, this panel, this conversation that you and I are having, be better suited for another type of conference? But I don't think so, for a number of reasons. Certainly, when it comes to inclusion, we want that process to start younger. And so for children who are themselves struggling with their own gender identities, creating a place where providers, public health officials, those who are in the field can appreciate that challenge and be up to speed on how to help children and their parents navigate that's more critical in this conversation, in this space, than anywhere else. The other piece that I think is important is much of this conference is focused on the data, on what we know, and the inverse of that, what we don't know. And I think it's fair to say, although we are catching up with respect to the health data as it relates to individuals in LGBTQ communities, we're still not there. And being able to shine a light on what we don't know is a motivator for those in my agency, researchers on the ground, to go out and fill those data gaps. A conference of this sort put on by a state public health agency is as good a place of any to shine a light on what we do have, but also what we don't have. And then the third, though, is the spirit of a lot of the work, going back to what we noted a moment ago, the spirit of a lot of the work that is being discussed today at its base is about inclusion. And I can think of no better way to telegraph to those who are in marginal communities that we hear them and see them and want them as participants than to have the exact discussion we're having here today.
Well, Well stated. Thank you for that. And, for me, at least, where I come at this is, I've for over 30 years worked with many young LGBTQ individuals, with families, their families, but also the families that these people ultimately form. So I saw a place for this, but didn't really know where the CDC was coming from. So I appreciate that. And I do want to say that with respect to the materials that we provided for this panel, I tried to include many health-oriented resources, everything from standards of care to practice guides, a large portion of which are pediatric, but not only, because these young people are going to grow up and ideally form happy families themselves. So just wanted to commend you to those resources because there's a lot in there. And at this point, there's organizations in Maine, like, for example, the Maine chapter of the American Academy of Pediatrics, who are really taking a leadership issue here, along with your department and others. And it makes such a difference. I mean, I come at this from assuming that, like, if people know and have the information, they're going to want to be the caring professionals that they are. They're going to want to find a way to connect with the young people and really help promote their health. So I'm thrilled to have this panel and very grateful. So I have another question for you too, though, which is, how did you learn all of this? All of us, I think, are on something of a journey about when it is that our paths cross somebody who's LGBTQ, maybe our own child, unexpectedly to us, says that they're, how they are identifying and feeling and so on, and bringing that forward. But how did you learn? What's your journey? Because I think we all ultimately are on some sort of journey of trying to make sure that things that were previously outside are now present and visible. And, the data that we do have in Maine from the Maine Integrated Health Youth Survey suggests that, like, somewhere around 20% of young people in high school are identifying as LGBTQ or questioning, unsure. And, we have this opportunity. So how do you learn?
Gosh, I wish, or maybe I don't. Sometimes people are asked that question, and the response that's expected is, I read a series of articles that changed my thinking, or so I had a revelatory moment. In my case, though, the story was far more personal and perhaps thus just as powerful. One of my dearest friends from law school continues to be one of my dearest friends to this day. A gentleman named Jeremy Mallory. He was the editor-in-chief of our law review, clerked on the court, and he and I were in the same study group together since literally the first week of law school. And Jeremy and his partner and his husband were both very, very committed to all sorts of structural changes that you have built your entire career on. And through the course of 3 years in law school and friendship ever since then, Jeremy always helped me see the ways in which the case that we were reading, whether it was a property case or a contracts case, had a dimension to it that at its core was neglecting certain people, that was creating a group of people that were in and a group of people that were out. And Jeremy was really, for me, instrumental in demonstrating that the legal system, at least in our case, was in effect, I say this somewhat jokingly, but the legal system was as much about public health as was the health department, by the structures that it could create and the rules that it could put into place that could systematically disadvantage not just LGBTQ people, but also people of color, people who were marginalized. And no matter what the issue was that we were arguing about, whether it was bankruptcy law or Article 9 of the university, whatever the course we were taking was, he always helped me and my other colleagues in my study group see the things that we weren't seeing. And that was really instrumental for me in understanding how the rules that we create, the systems that we create as government agents and, as in your case, as litigators, how they can have these ripple impacts. And that if we're not careful to see them, we'll forget about that. So I never forgot the late night conversations that we had, again, no matter the subject. And that was really instrumental in me taking a much broader look. we disagreed more than we agreed on things, but his viewpoint on the way that the 14th Amendment operated, so on and so forth, I won't forget any of that. And on a personal note, Mary, I sent him a text 2 nights ago to let him know that you and I were going to be speaking, and suffice it to say, he was exceedingly jealous.
Well, thank you for sharing that story. And that's an incredible gift that you've both given each other, I think, to have those kinds of conversations, to be able to disagree and to sort things out. I'm wondering if you have any thoughts just about, given the breadth of this audience, and again, all people who I assume really care about others and want to do the right thing, want to support people to be healthy, to be whole. Do you have any thoughts about the kinds of things people can do?
I'll leave everyone with 2 observations there, particularly those who are within the LGBTQ, particularly that community, who are struggling. I think it's important to note that there are others around you now who are blazing pathways that 5 years ago, let alone 20 years ago, would have been unthinkable. Right now, the Assistant Secretary for Health of the United States of America, Dr. Rachel Levine, is a woman who herself identifies as trans. That is a monumental step forward. And I think for those who are wondering whether their otherness or the fact that others perceive them as being other, to be able to see someone of Dr. Levine's stature and grace occupy such a position, I think that's quite inspirational and hopeful. So for those of you out there who are struggling right now, know that there are people that are blazing a trail to help make things easier for you. The other is, I know this may sound cliche, but it's exceedingly true. There are people in places like our agency at the Maine CDC who see you and hear you and are working to make your life better. Maybe not necessarily today, and maybe not at an individual level, but we're hoping to get there, and we're trying to move toward a system where there aren't as many division lines between those who the government sees and those who the government neglects.
That is also important. Do you have anything also you just want to share about the directions the department is moving in this regard? I mean, we've already talked about identity documents, and I have to just do a quick plug. We publish every year an ID guide for people, and it's in your, oops, you can't see it. Okay, it's linked in your materials. Sorry. It's linked in your materials. It's called the Maine ID guide, and it actually includes how to change your gender markers, any particular qualifications that apply for young people versus adults. There are a few differences sometimes, and the forms, whether it's passport or driver's license or birth certificate. So really, I also will say that for years now, we have been partnering with other firms to get free lawyers for people to help them change their documents. And this guide, I think, is detailed enough for many people just to be able to do it on their own. But you can always call us. The information's in the document. Should you really need an attorney, and we will try to pair you with one. So, but anyway, beyond ID documents, crucial as they are, Dr. Shah, other initiatives underway that you think may have an impact on LGBTQ people?
Well, right now, I hate to say it, because of COVID, we have just been, nose to the ground, really focused on that, and thus we haven't had the ability to launch that many key new initiatives. Although we're certainly open to thinking about where we want to go next. I mean, fundamentally, our policy as the agency, as the department, as the administration, is that people in Maine, no matter their orientation, should get the support they need to live as they are, who they are, wherever they are. As you've noted, Mary, we've taken some steps administratively to make getting documents that reflect who you are easier, but we certainly have more work to do ahead of us. One thing that I think unites some of the themes that we've been talking about that I'd like to do much more on is to start thinking about stigma. The corollary of being cast out or viewed as othered, as others is the stigma that follows from that. And it's interesting because in some areas of public health, we don't think twice about the cost and the harm that stigma produces. For example, substance use and the opioid crisis. It's commonplace to say we should not stigmatize those who are grappling with substance use. But we don't necessarily carry that concern about stigmatization over into other fields. For example, in the way that we work with individuals who are in the LGBTQ communities. I think that is really critical. It's one reason I've tried to, in the time that we have to make appearances that aren't COVID focused, I've urged my team to talk with groups that don't necessarily come under the classical public health umbrella, but may be where folks who are grappling with these concerns, where they are going, where they're getting information about public health. So that's something that we'd like to do more of. Again, it's like turning the proverbial aircraft carrier. It takes a long time, but we're committed to it.
That is actually very exciting to hear that you would even be thinking about this amidst COVID, because it's true that stigma exists. It's sort of a miasma, a stain on people that, really colors all of their interactions with others. Some of us are able to navigate around that better for a variety of reasons, but many cannot.
The corollary of stigma for me is stigma unto itself is bad. There's no question about that because it creates this otherness. But there's also an emerging body of research on the very concrete health effects of stigma. Stigma is in and of itself a stressor. And for many folks, when they are under stress, they may pursue behaviors that are not in the optimum health. For me, for example, when I'm under a lot of stress, I reach for the closest pint of ice cream I can find. But having spoken with a lot of folks who deal with the stress of stigma, for them, it may be to open up a pack of cigarettes or something even more harmful. So the stigma and the stress that it generates have really defined negative consequences. And that could be one of the reasons. I don't want to profess expertise in this area, but that could be one of the reasons, for example, we continue to see higher rates of smoking among individuals who are in the LGBTQ community. So all of these things are tied together. And I think unless we get to some of these root causes, so why are individuals smoking in higher rates? Well, it could be because they don't have as much access to smoking cessation materials, but maybe that's a hypothesis, but I think we need to broaden our hypotheses a bit more and ask whether their stress levels are higher because of stigma.
Yeah, I appreciate this. I assume you've seen long ago the new report from the National Academies of Science, Engineering, and Medicine that lays out a lot of current research on a lot of topics. It also addresses law, but just to point to what you're saying here and to provide some support for that. It also notes there's a lot of things we don't know because we don't have the best data in the world, but these correlations certainly seem to be there. So appreciate that.
No question about it. And although I've spoken about some unfortunate consequences, it's also important to note that based on the data we do have, there are areas where members of the LGBTQ communities are excelling with respect to taking care of their health. A recent self-reported survey of members of those communities that I've spoken about with folks at Equality Maine noted that well over 90% of individuals who identify as part of those communities are fully vaccinated against COVID-19. So there are certain areas where the group cohesion maybe is generating more of an impetus to getting and taking care of one's health. We shouldn't shy away from good news, but we can also recognize that there's more work we need to do on other measures.
Yes, and speaking of good news, there's something that's been profoundly influential for me, and it's now in thinking about how to talk and with other people and break through some of that stigma and otherness. And it's something called the Family Acceptance Project, which again is linked in your materials. And it started out as an idea, but turns out now to have been validated in the research that when, parents love their kids, right? They want to do the best for their kids. And then there are kids who are coming out to their parents or sharing their questions and their concerns, and they can be met with something like, you're going to grow out of this. This is a phase, not here. I mean, all kinds of things, which turn out to be very damaging, even though the parent doesn't mean to be damaging. They're doing it because they love their child and think this is the best thing. And then, of course, there's responses to like, I don't know a lot about this, so tell me about it, and listening and trying to live with your discomfort and learning more and so on. And it turns out there's a profound difference in health outcomes for the children who receive and are supported, and accepted, even if the parent is struggling with it and living with their struggle, than just in people who are rejected. And I wondered if you could just speak more globally about the role of all these incredible people in the room, who we can't say, who of course want to be supportive, and like the role of support of any sort in health and things people can do to be supportive.
Well, it ties beautifully, Mary, with the first question you led with, which is why are we discussing the challenges facing the LGBTQ community at today's conference? And I think you laid out exactly why, because it is part and parcel of the health of young people, the health of moms, and the health of families. The thread that runs through that, again, I think is one of ways in which challenging situations can be turned around by something as simple as acceptance. And again, in some areas of public health, that's pretty commonplace. We think it's a mantra now to accept those who are grappling with, say, behavioral health, and not to blame them for their own bipolar disease or something of that nature. But the bedrock principle there is acceptance, to reckon with people on their terms in the way that they're perceiving the world. It's an emerging phenomenon now with respect to substance use. And now we've got to extend that to those who don't meet the mold that we think that they should have. In the case that you mentioned with respect to families, I think that's really critical. Families are under more stress than ever right now. I suspect partly because of COVID, but also because of some of the economic changes that came along with COVID. To recognize that, particularly in the context of young people who may be coming out to their parents, a message to parents to accept their children and work with them rather than assume that they should change. I think that's more important now than it ever has been.
Thank you for that. And I just also want to note, since I am a lawyer, and this is really not going to be a panel about law in any way, that, I just want to say how grateful I am to live in Maine, and for the, executive branch and the policymakers who have really made Maine, at least in the law, a much more supportive place in terms of non-discrimination laws that, certainly extend into the healthcare setting. But, banning conversion therapy because it just doesn't work. And if people are going to change, it's not because of any outside intervention. And, the gender markers and new PrEP bill to make PrEP more accessible to people and really put even more of a dent in the HIV epidemic. So, just really appreciate that, at least what's coming from the state, and certainly from you and the department and the Department of Human Services and the governor is very important for people to experience. So thank you.
Well, thank you, Mary, for all the just phenomenal work. The work that you've done will be read by generations of law students to come, and you make me quite proud to be part of the legal profession. So thank you for all the advocacy at literally the highest levels, and the composure and the thoughtfulness that you've approached it with.
Well, and thank you again, as I started out with, what you and your whole team is doing and was doing before the pandemic, and certainly through the pandemic, and what you will be doing going forward. Thank you.
Absolutely, Mary. Well, I will now officially turn things over to you to lead the way on the next panel. So all the best.
Thank you. Thank you very much. Good morning, everyone. So happy you can all be here. Very excited about this panel and this entire incredible conference. I am Mary Bonato. I just had a fabulous conversation with Dr. Shah, who is incredible, as we all know, and so grateful to the Maine CDC, Department of Health and Human Services, They live in Maine in York County, and we'll get to them in a second. I also, after that, we are going to hear from Liana Amayas, who's the Manager of Diversity, Equity, and Inclusion at the Department of Health and Human Services. Welcome. And then we are going to have a conversation among three people, Dr. Deborah Burchell, Jude Stevens, Dr. Jude Stevens, who's a nurse practitioner at Penn Bay, and Quinn Gormley, the Director of Maine Transnet. So with no further ado, what we're actually going to do is, Barbara, do you want to introduce this video that we're going to have?
Oh, sure. Thank you so much for having us. Lane and I are excited to be here and share our personal story. But yeah, before we jump in, we have a short video that will help sort of illustrate the transition that occurred for Lane and in our family. So it's just kind of a scene setter before we talk further.
Not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I've learned to be ashamed of all my scars. Run away, they say, no one will love you as you are. But I won't let them break me down to dust. I know that there's a place for us, for we are glorious. Sharpest words wanna cut me down. I'm gonna send the blood, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me. Look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen, I make no apologies. This is me.
Okay, thank you, Barbara, for putting that together. Lane, you're obviously featured in this and you're not alone. So I'd like to make sure that you both get a chance to talk today. And Barbara, I sort of wanted to kick it off with you if we could, please, in terms of, it's 2004, as I recall, you give birth to identical twins. You're on a journey. I mean, all parents are, but you are on a journey. And I'm wondering if you could tell us something about that, please.
Sure. Yeah. So had a 3-year-old boy at that point, and then had Rory and Lane, who were identical twin boys, and we felt like we were prepared because we understood boys at that point. We thought we did, and then it became clear that Rory and Lane had different interests. And this was pretty clear as soon as they could communicate or make any of their own choices. And so both of them were attracted to anything pink, sparkly, what we would consider traditionally feminine things. And so, that was fine. I didn't get too, I was just a little bit confused, but I was like, okay, well, we'll see how this rolls out. But then as soon as Lane could talk, she would say, I am a girl. And I really was like, oh, I don't know what to make of that. I mean, I knew enough not to really respond, but I didn't have any guidance. So I would go to the pediatrician and ask what is happening here? I'm not sure what to make of this. And our pediatrician was like, oh, this is just a phase. Don't pay any attention to it. The kids outgrow this. And so I was like, okay. And we continued on. And my now ex-husband was concerned about the kids, especially, and we both were, about them being teased in public. But so we created sort of a bubble of people that we knew were super accepting, and we let them express themselves however they wanted. But when they wanted to wear, dresses to kindergarten, I think, that was when my husband at the time was so worried that they would get teased that we sort of put the kibosh on that. But there was a lot of stress for us about how they were received by society, really. And I'm ashamed now sort of the way that I initially reacted. Like, I wouldn't buy them stuff. I would give them purple things, not pink things. We would give them puppets, not dolls, and so it just became clear, like you give your kid these gifts or trucks, at Christmas. And by the fourth Christmas, it's like, there's not something wrong with your kids. There's something wrong with you that you don't get, that they don't like this and don't want this. So finally it was like this epiphany of like, okay, I gotta figure out what's happening here to support these kids. And Rory and Lane were exactly the same, except Rory never said, I am a girl. Rory used to say, I wish I was a girl so I could play with girl things and nobody would laugh at me. So, and then Lane transitioned in at the end of 5th grade.
Through a video. Yeah.
And that was and it's been a positive experience.
It's been incredible. Yeah.
And just one quick question, Barbara, along the way, how did you learn? How did you find support? Did you find support?
Well, so this is, like 10 years ago, and the internet didn't have information at that point. I mean, it was just coming out. Facebook wasn't really happening. And so I fortunately, we had a neighbor who had a gender nonconforming boy who sort of took us under their wings, and they had done some research, and we got on this listserv where there was a shared community of what we called then pink boys. That was really critical. There was one nurse, Catherine Turk, whose son was gay, who had put together a pamphlet. And so we could share it with our families. And the fact that it came from an authority figure, like a medical community, when I sent that to my parents, who, are super supportive, but at the time they were like, well, we don't want to encourage this. Like, when they would continue to give the kids gifts or try to, engage in a way that they thought that boys should respond, and I was like, they don't like that. And my mother would be like, well, we don't want to encourage this behavior. And my ex-husband would say, well, we don't want to make it easy for them. Let's not put the path open for them, and Catherine Turk and her group were really clear about family acceptance and that there's nothing wrong with your child. And you have got to affirm who they are, or you're going to have deep psychological problems for your whole family down the road. And so when I would send that to our family, that piece of information way back then completely turned it for, at least for my family and for our friends.
Yeah, I mean,
and then the internet happened, and then then it was like we all the parents found each other, kind of thing.
Fantastic. And I'm hearing that even without a lot of information, that your instincts were to create a secure base for your child and to support them, support your kids, even though there's a lot you didn't know and that you didn't understand. And that is just such an important thing for parents to try to stretch to do. And I mentioned in the conversation with Dr. Shah, the Family Acceptance Project that's linked in the materials that talks about exactly that and how important family acceptance, or really family non-rejection is. To make sure your child knows they are loved and that they are going to have a good life and that you believe in them, even as you are living through and learning through your own discomfort or misinformation. So I say kudos to you. And I also just want to shout out to the Maine chapter of the American Academy of Pediatrics, which is trying to make sure that you don't have that same experience with a pediatrician again.
I would add that I really think it's so critical because the parents because I would get people just saying to my face, like, it's clear you wanted a girl, or, this is, you're in control here. Don't let your boys do this. Don't let them play with this. Don't, so knowing that the experts are saying that this is the correct way to respond to your children really helps parents be able to buck up and address the community, society, schools, politics, whatever it is where people are questioning, this path of acceptance.
Right, thank you. So Lane, you've been very patient. Please tell us what we need to know. Tell us what's helped you be the incredible person you are in the world. I don't mean to, put that big burden on you, but tell us what you all need to know. I mean, you're also here taking time out of school. Why is that? You could be doing a lot of other things.
Well, I mean, I think the first important thing to recognize is how fundamentally important it has been, as we've been talking about, to have a family that's been accepting and supporting of me. Like my mother, she has been incredible. Like she's the one who like helps me pick out my outfits every morning. She's been driving me up to all these doctor's appointments to, help me like understand like how I can be my best self and that kind of thing. Like she's like having that family support has been really just fundamental through this journey. Also something else has been just my school. Like I've been accepted and supported by my peers and my teachers, and they haven't misgendered me. Like they've been actively trying to make sure that they're using the correct pronouns on me, and they've been using visual cues. Like they've been putting safe space stickers up on their classrooms, and that's just been reminding me, that my teachers are my allies. So that's been amazing. And then I'd say lastly, my sports team. Like I love soccer so much, and it's just this amazing opportunity that I have to just like connect with my friends and just like have fun and just play soccer. It's an amazing sport, and I've learned so much through that sport. And just having acceptance on that team and knowing that everyone is there for me, and knowing that everyone like accepts me as being a girl on that team and just being their other teammate and not weaponizing me like a lot of these public figures have been doing with like proposing these bills. And then in terms of why I'm here today, I think it's really important that trans kids know that they are supported and safe wherever they go to the doctors. Like this is where our physical health is being evaluated. Like this is where the doctor plays a very fundamental role in your life, and you should feel safe and supported when you go there and accepted. So, and throughout my experience of advocacy, I've learned that, sharing my personal experience as being a trans person, like I've seen people change their opinions. I've seen people become more compassionate and understanding of what it means to be trans. And I've seen that with my own eyes. So I want to continue on that and help people actually understand that, we got to include trans people in everyday life. Like we got to be more inclusive. Like we got to not misgender us. Like we got to do better as a society. And I want to contribute to that change.
Well, Maine, you are, and thank you. And I want to say, I so appreciate your willingness to educate people and to engage, because there's really no choice when you're part of a minority, and I know that very well. And at the same time, there's a lot of grown-ups here, and everybody can also learn. Yeah. And there's lots of resources available to learn. That's part of why we put together these resources that are there, but certainly shouldn't limit your inquiry. So for the audience, but thank you. I want to turn to Mayas, if I may. Welcome. And listen, you're a public health person. You're diversity, equity, inclusion at DHHS, which I think is a fairly new position, and certainly a welcome one. How do you think about, LGBTQI plus inclusion from a public health perspective? What do we need to know?
First, I do want to just say thank you so much for having me, Mary, and for the folks who've organized this conference, and to allow me to be a part of this really impressive panel. And I would be remiss if I didn't also say thank you to you, Barbara and Lane, for sharing your story and being with us today. I think for when we talk about diversity, equity, and inclusion, we often get stuck on talking about the diversity that everybody contributes to the fabric of our society, and that is good. And we talk about how important it is to be inclusive and make sure everybody feels welcome, and that is also good. But we don't often get to that piece about the equity, right? And when we're talking in particular about health equity, what our responsibility is to really ensure that systems see everyone and systems respond to the needs of everyone. So really, when we talk about LGBTQ health and health equity, I heard you ask Dr. Shaw, why is this conversation at this conference? For me, it's really quite simple. And the reason is that LGBTQ people are parents, LGBTQ people are children, and they are just as deserving of respect, affirmation, and of quality care. And we know that if that is happening, health outcomes will be better. So for me, if you look at you look at the landscape right now, we can't not be having this conversation. And in any panel or conference or conversation about health and health equity, we can't not be addressing the needs of LGBTQ people and of other marginalized identities, and really be addressing health of all of our communities. When part of what I wanted to just talk about today is some of the attitudes that really create those systems that often fail to see people. And in my experience, some of what we have seen in Maine is often narratives that are not bad on their face, but really do contribute to the invisibility of particular communities. And that is this idea that maybe it doesn't matter in our practice, or it doesn't matter in our school, or it doesn't matter somewhere, because it's really, we're talking about a handful, right? So we have to worry about the whole, and we don't often worry about just parts, right? We often downplay the existence of people to justify the ways in which we fail to really take care of and pay attention to the unique needs of people. But if you look in Maine, that's just not true, right? And we know this from the way in which we collect health data. The Maine Integrated Youth Health Survey, which is done every couple of years in high schools across the state. I think the last one was done in 2019. We're actually preparing to do the next one now in 2021. But in 2019, 13.6% of all high school students in Maine identified as LGBTQ. 13.6% is a lot of kids. That's a lot of people that we need to learn how to see, and see in a meaningful way. And that's a lot of people whose health matters, right? And whose health care matters. And so we need to understand what they bring to the table when we're providing care. There were other things that we see when we look at the Maine Integrated Youth Survey, though, also are sort of further examples of why we need to be paying close attention to the unique needs of this community. We talk a lot in public health about social determinants of health, right? The conditions in which we live, work, and play, including community and social context, which includes things like discrimination, stigma, which you heard Dr. Shah talk about, and the stress that comes from that. And we understand that those contribute to the long-term health outcomes of individuals. You look at the Maine Integrated Youth Survey, you see that LGBT youth were twice as likely to feel unsafe in school. They were significantly more likely to be bullied, or to have offensive comments or hurled their way. They reported a significant difference in the way in which they receive support from adults and their likelihood of experiencing violence. For LGBT youth, the report of some of the questions are asked are like, do you feel like parents are helping you to succeed? Do you feel like your family provides love and support? Do you feel like you have the support of adults other than your parents? And do you feel like you matter in your community? For all of those questions, there was a statistical difference for LGBT youth. And that can't be ignored. That's the social determinants of health at play. So when we look then at health outcomes, and you've heard Dr. Shah talk about some of those, right? We look at tobacco use, or we look at substance use. You can't have a conversation about those things if we haven't paid attention to social determinants of health. Part of that puzzle with social determinants of health is also the health care and the care that people receive, right? In the work of health equity, we often talk about the national class standards, the culturally and linguistically appropriate care. And people often kind of get stuck on thinking that's about language or about, ethnic culture, and it's not. It's about all of the cultural references that we bring and the experiences that we bring to bear. And the sort of principal standard there is kind of this combination of respect and responsiveness. Now, I happen to think that in Maine, we do respect pretty well. It's part of this like New England thing. We do respect pretty well. We're pretty proper here in Maine. I'm not an original Mainer. I'm a New Yorker, where we are a little less perhaps respectful and proper. I'll admit that. But Maine does that part pretty well. But it's moving beyond that respect and moving to really, what does responsiveness mean? Well, responsiveness means we have to understand what conditions people live, work, and play in and bring to the table when they walk into our office as healthcare providers, right? We have to ask. We don't have, right? We have to ask and not assume. And then we have to really think about how we create a base of knowledge amongst ourselves and in our practices that will allow us to adequately respond to the needs of those communities that come before us, that will understand the unique questions that they may have and help us prepare to answer those in ways that are affirming of their dignity and of their right to receive the best possible care.
So let me interrupt 1 second just with a question to follow up on this, which is, do you have any off the cuff or other thoughts about how people can learn to ask those questions and to be that care provider who's tuned into what people are bringing into the office with them?
Yeah, that's a great question. I think one of the, Barbara talks about then the internet came, right? And the truth is there's so much information out there. There is so much information out there, and there are so many great people. We're going to hear from some of them doing really phenomenal work in our state to make sure that there are opportunities for education available. So I would say there is no shortage of places you can turn to these days to really be able to do the research. There are studies coming up all the time, and there's opportunities. So prioritizing that within your practice, right? Making sure have your practitioners done work around DEI in the last year, just as you're thinking about other CMEs and really gaining the knowledge base in, if you're a cardiologist, really, being able to keep up to date with cutting edge technology in cardiology. You should also ensure that your practice is keeping up to date with the research and the information coming out about LGBTQ people, about people of color, right? That this is a part of not just a moral responsibility or an ethical responsibility, but it's a professional responsibility because you cannot meet the needs of communities if you do not understand the questions and the history that they bring to bear. And then I will just say, we talked, Dr. Shaw talked a little bit about data and the importance of data in that we have to ask these questions, right? But we also have to recognize that the way we ask them is often one of the first cues we give to people about whether or not we are going to be an affirming place. If we understand the significant that about half of the youth in the Maine Healthy Survey experience discrimination in some form, right? That about half that identified as LGBTQ have experienced. That means that about half of the folks that are walking into your office have knowledge of what that looks like and feels like. And they are looking for cues to know that this office is not going to repeat that history and that trauma for them. And so there are ways in which we ask for information that can be affirming, right? First of all, we ask with the right terms. We ask and we explain why we're asking, right? That it is a part of the way in which we ensure and hold ourselves accountable, right? To provide quality care for all people. It's the way we hold ourselves accountable to make sure we're doing it well. And it's the way that we make sure that we are really prepared to answer the questions you may have that are unique to you. And so I think we need to be asking this question. We need to be keeping track of various social demographic identity markers in order to really assess how we're doing and create data-driven solutions, but we need to do it well. And we need to train the people who are doing it. That includes your doctors and your nurses, but it includes your front desk staff. It includes the folks who answer phones. We have to think about how we ask those questions, those first cues and introductions that we have to show folks that we are a space that really cares about their health and well-being.
Thank you so much, Liana. Really making public health real and tangible. Like it's the big systems and the social and cultural pieces, and also the office practice and patient care and learning. So thank you for wrapping all of that together. It's very helpful. I'm going to move us in a different direction now. And we're going to have a conversation. I hope it's okay. I'm on first name basis and not titles here. Among Deb, a family practice doctor, Jude, nurse practitioner, and Quinn, advocate at Maine Transnet to talk about what does it take to try to have a supportive practice for LGBTQ people. And we really want to focus on transgender and gender diverse people here. Everybody has issues for sure, but I think that's the area where there's the least amount of information. And so what we plan to do is sort of think about this at a super high level, like first principles, if you will, and then think about things like Liana was just saying about office practices, about routine care, and then about specifically about gender affirming care. And I think who is going to kick us off here is, well, any of you. It could be, this is a conversation among you, and I'll try to be like gatekeeper or whatever, referee if I need to. But would someone start us off? Deb, did you want to start us off? So you're unmuted.
Okay.
Thank you.
I'm Deborah Burchell. I'm a family physician in Somerville, Massachusetts. And I've been living full-time as a woman for 15 years. And I've been practicing transgender healthcare actively, trans healthcare for more than 15 years. I want to express to those of you who have some qualms about sticking your toe into the water of providing trans healthcare, that it's not all that challenging to be considered an excellent provider. You just have to be accepting, tolerant, set up office policies that create an inviting environment for all people, and take maybe a little bit of time to train your staff. We encounter in our lives, in the practice of medicine, people from all walks of life, all backgrounds, and I think if you invite trans folk into your practices with open arms, you're going to find it quite rewarding and not that complicated.
Thank you, Deb. Thank you. Jude, can I ask you to add any sort of big picture, first principles kinds of comments? And it sounds like people want you to introduce yourself, so please do.
Sure. Yeah. And I also just want to say my eyes are looking a little glossy because I'm still very touched by Barbara and Lane's sharing. So thank you. I'm feeling it here. I am Jude Stevens. I am a nurse practitioner. I am a primary care provider at Penn Bay Internal Medicine, which is part of Maine Health in Rockport, Maine. I am a relatively new Mainer, moved from Vermont about a year ago. I use they, them pronouns, and I also identify as a queer, trans, non-binary person. And I'm very happy to be part of this conversation, so thank you. So I would just say that as a primary care provider, what Liana said about the professional responsibility of providing care for trans folks, that really resonated with me. This isn't extra credit. This is really a professional responsibility for us to be on our game, to listen to our patients, to exercise curiosity, to ask questions, to train ourselves, to stay up on things. These are all the very basic components of providing good primary care that is already baked into what we learn to do as primary care providers, whether we're working with adults, as I do, pediatrics, family medicine, et cetera. And we have so many opportunities to capture information from patients to help us understand who they are. New patient intake paperwork, intake with staff, just visits with patients. And also I would really reiterate the point about this needing to be a whole clinic approach. It's not enough just for providers to be doing continuing medical education and understanding the guidelines. This has to include nurses, medical assistants, front desk staff, all the people who interact with patients.
Thank you, Jude. And Quinn, you're an advocate. You work with lots of people in lots of contexts, and you're also receiving healthcare yourself. So can you sort of add something to this conversation, in the general?
Absolutely. I have the pleasure of serving as director of the Maine Transgender Network. We're the sole community organization here in Maine specifically dedicated to meeting the needs of trans people. And in my role, I've had the privilege of working with hundreds of mental health and medical providers across the state and improving care. I would like to echo a couple of points of some of my other panelists about the sort of the whole office approach. And just to really make this really simple, it really doesn't matter how well-trained you are when you're working with a patient and how affirming you are when you're working with a patient if they got misgendered 3 times before they got to your office. Like, they are going to clam up and not want to talk to you at all because you are working from a deficit of trust. I don't know a trans person who either hasn't personally had a negative experience with a healthcare practitioner or who knows someone who's had a negative experience with a healthcare practitioner. And that is not your fault individually as practitioners, but it is something that you're responsible for responding to when you're trying to build a trustworthy relationship with patients. It's just know that there's that deficit of trust, and you might have to do some additional work in order to build trust and let a patient know that you're safe to get care from. I think I'd also add, when we talk about trans patients, there's a great deal of focus on sort of providing gender affirming care. And that's wonderful because gender affirming care is life-saving, vital, medically necessary care that we certainly need more and more providers, especially primary care providers, being comfortable with providing. At the same time, medical transition doesn't make up the bulk of a trans person's life. It's not most of our life in terms of time. It's not most of our life in terms of what's important. And so when you're working with a trans patient, I've noticed a tendency that frequently that's what providers want to narrow in on because that's what they know to ask about. But, if I'm going to see the doctor because, I've sprained my wrist or something, I'm not there to talk about my hormones. I'm there to talk about the fact that my wrist hurts and I would like to get, a splint or something for that, right? So I think as much as it's important to take the educational opportunities and the growth opportunity to look into gender affirming care and providing it, it's also important just to make sure that you're responding to a patient as a whole person in the same way that you would with other patients and responding to the needs that they have, come into your office with that day and make sure that they're getting that care.
Yeah, and I'm not a medical provider, as you all know, but I will say, for me, it's just really key that we all understand that in this state and everywhere we go, that there are people who are all different from us, and we're all human beings, and there is a common humanity that binds us. And part of my, even though I'm a lawyer, and I thought it was so important to bring this panel forward, is because you all provide such, you're such a lifeline for people, and getting support, being seen by a medical person, a substance use counselor, whatever it might be, is just so important for people to be seen. And when you're not seen, it just changes everything. And I hear that a lot also from young people who are, it's their whole world to be seen as who they are. And every adult is an authority figure, and to be told you're not who you are and not be affirmed and seen, it's just so hard. So that's the downside of it. The positive side is you have such a role to play in being able to hear people. So that's my first principle, is common humanity. Take the time to respect, to listen, to learn. So I want to just, since we have this.
Can I add one thing that to come a little bit full circle on what Quinn had said? Yes, take care of the medical problem at hand, but if you have the opportunity in a polite and respectful way to let the trans patient know that you are accepting of their identity, then down the road, when they do have a trans related issue, they they will be more comfortable in coming to you and asking you questions.
Thank you, Deb. I wanted to circle back with the first part of this, and it's already been alluded to a few times by a few folks because it is so important, which is the office practices. And I'm wondering if among all of you, Deb, I'll have you kick this off, like there's kind of a checklist. And again, the selected resources we provided contains links to places that will tell you, like, here's what you do about training, here's what you do about forms. But Deb, can you just start us off on that in terms of the things that are important? And Lane mentioned some of them too, about what Lane is seeing at school that makes Lane feel seen and respected at school, which I think translates to the medical setting too. So Deb, you want to kick us off on that?
Well, specifically, if one is fortunate enough to have an electronic medical record that is, updated on a regular basis like Epic, you will have the opportunity to ask those questions, specifically, what was your gender identity at birth, assigned at birth? What is your preferred gender identity now? But if you do not have that already baked into your software, in your regular new patient forms, if you have questions that are related to gender identity, sexual orientation, you're setting the tone for your entire practice that tells people you're welcoming of all people, no matter what their race, color, or creed is. Not just that doesn't just pertain to gender identity or sexual orientation per se. So I think that it's mandatory that if you don't have that already in your new patient registration material, you should work on that as soon as you leave the conference. And I think to just have one, you can have a very brief training for your office staff, where you have a mock patient come in who has gender identity or may appear that they they don't look like your typical binary gender. Have a walkthrough. You don't have to spend a lot of time. It can be a 15-minute training, but that will also set the tone for your staff. I'll let other people talk about what they do in their offices and what kind of signage they think might be appropriate.
Well, I think what we've been hearing is from all of your comments together, if I can just make sure I'm recapping this correctly, is one is like office visuals, representations of welcomeness, like that's one thing. So when you walk in the door, a second thing is making sure that your forms allow people to self-designate their gender, their gender identity, their sexual orientation, all of that. And to, as you're saying, Deb, it's all about the medical records, right? And or not all about it. It's very important to have your medical records. That be accessible to everyone and be correct. And then the third thing I'm hearing is it matters that everybody is on board. Everybody gets the information so that when you call, when you approach the front desk, everybody's getting it right. And I wondered on the misgendering piece in particular, because that's, I think, one of the most common things to happen. So Jude, would you be willing to sort of share why you think misgendering is important as a healthcare issue in the healthcare context?
Absolutely. And I would just add one other quick point about creating visibility in the clinic setting. One thing that I've done is I've got pride and trans flags, my badge stuff. I've got my pronoun sticker. So there's very simple stuff that you as providers and staff and that we can do to create visibility and normalize the use of pronouns. In terms of why it's important to capture information like pronouns, gender identity. I think it just goes back to really basic concepts about respect and curiosity and creating a safe space. And as speaking as a patient who has been on the other end of that deficit of trust, as Quinn described very eloquently, that really sets a rough tone for an interaction. And it's the reason why a lot of people don't come back for care. And it can be that simple.
Yeah, makes sense. And Quinn, I know you had a perspective about this too, about the clamming up piece, and maybe what providers miss. Can you just share some thinking on that? If they don't build the trust, what providers miss?
Yeah, absolutely. You know, I think, you know, I've had some glaring personal examples of wildly different experiences with healthcare providers in terms of who's done things well and who hasn't. I remember when I was 20, I was working in a boat shop at the time, and I injured my arm, and I went to the emergency room in town, and this is my hometown hospital. And I had already transitioned at that point, and I'm going through intake, and not all of my identity documents line up, and I'm getting misgendered left and right, and I'm having this argument with the medical assistant who's doing my intake over why my ID and my insurance card don't line up. And I'm in a great deal of pain, and I am deeply humiliated at this point. And I think one of the most embarrassing things about it is that this medical assistant was someone who I shared homeroom with for 12 solid years of education, who knew exactly what was going on, and yet could not find a way to navigate their discomfort around that in a way that prioritized an emergent healthcare need. And as a result, I ended up leaving the emergency room and going to a different hospital, 40 minutes down the road. And luckily, I was in a position where that was okay to do. But that's not always the case. And I talk to trans people every day who have these horrific experiences with healthcare providers in situations where they're not in a position to advocate for themselves. Conversely, I think about, I have a PCP I've been working with for a couple of years who, she has really prioritized serving trans patients. It's kind of what she focuses on now. And, she and her nurse and her medical assistant are all exceptionally well trained. They're fluent. Yeah, they have pronoun stickers and rainbow flags and stuff everywhere, and that's lovely. And she's really built a holistic approach to providing that care. And as a result, I talk to her in a way that I've never spoken to any provider, and I'm willing to trust her when she's pushing for me to get care and get tests. And we just a couple years ago found a significant issue with my thyroid that I'm happy I caught early. It would have had a huge ramifications on my life, and I wouldn't have been willing to get the tests for that from another provider who didn't have the knowledge of how to explain why that was important, and who notably, and I think this is really relevant in terms of important clinic practices, she knew what I could expect in terms of cultural competency from the people who did the test, because she had bothered to check. And so when she sets up referrals, she gives me a good idea about what I'm going to be getting on the other side of that. And I think that's really key. Is it's really exhausting to have one good provider who then refers you out to a bunch of people who it's roulette. You never know what you're going to get. And so I think referrals is another key piece of competency. And that's not to say that your referrals always have to be to someone who's a great gender affirming provider, because it's Maine and we have limited specialists, and not all of them are going to be great. But I think so long as you're giving your patients the best information you can about their healthcare and who they need to see, you're going to be in a better position to have that trust.
Thank you. And I
just add something. There may be no going back after you flub. You mispronoun somebody. I do it still occasionally, but it's not just a matter of the trans person, being, militant about, oh, you got it, it's right. There's a lot of shame. I feel a lot of shame. I felt a lot of shame. I feel less shame now. I hope with the help of people like Leanna, with the work that she's doing, that for the young people coming up, there will be a lot less shame. about who they are. But for now, if somebody, what they call clocks me and says, sir, I feel a twinge inside, it's painful. It's not just me being an asshole.
Thank you. And I just have one thing to say, which is, this is my assumption, is that you're born perfect. Hang on to that. And the rest of us maybe don't always get that. We've already been talking about office practices. We've been talking about office care. And I'll just tell you that one thing that I remember floored me was talking to somebody who'd had an interaction with a healthcare provider who turned them away when they had flu symptoms. And they said, I cannot deal with the trans flu. I had never heard of the trans flu. And so I wanted to just ask for a moment, since we have this panel, to briefly reflect on, since two of you are healthcare practitioners in primary care, Quinn, I know you have perspective, and actually anybody should feel free to answer this. Like, when is there a difference and when is it the same in terms of caring for a trans or gender diverse person? You don't all have to comment, but if somebody would start us off.
I don't think that there's, much difference in the grand scheme of things between taking care of a transgender individual or a cisgendered individual. If a person is on cross-gender hormones, there are some medical issues one might want to be aware of, but for the most part, they're not going to be playing much of a role in your assessment of the patient's wellness.
So, Jude, did you want to comment on this at all? How much somebody's has to do with their healthcare? Setting aside a gender affirming care even.
Yeah, we could spend a lot of time talking about social determinants of health and marginalization experienced within the trans community. That said, caring for trans patients, for me, we're doing the same thing that we're doing for other patients, which should include putting the pronouns in the chart, putting the gender identity in the chart, making sure that we are treating all patients with respect and listening. And also as providers, not using patients and trans people as our educators. That is not the time. That is not the platform for that. That's what we do on our own time, which really is not much different than staying up to date on guidelines and data and research, which is always changing and shifting. And also, when we're talking about gender affirming hormone therapy in particular, it's really not rocket science that requires referrals to endocrinology. I'm talking specifically about adult care. There may be some more nuance with pediatrics, but this is something that we can include as part of our learning curve and just under the umbrella of primary care, which offers an incredible opportunity for continuity of care, to learn who a person is and do that over time. I think Quinn brought up a really great example of building that trust over time with a primary care provider, and recognizing that as trans patients, we are more than our transness. We are whole people. We are not monoliths. And I think that primary care offers a lot of opportunity to capture that.
Thank you. I guess I also see it in my discrimination frame, just how I think as a lawyer of we just have people who are different, but they're all people and everybody has the flu. If you can treat the flu, you can treat the trans person with the flu, the trans person with diabetes. And there's lots of learning that goes on. You all have to keep up on a great many things, high blood pressure, diabetes treatment, whatever. And this is just another thing to me that you all do, which we all appreciate. Liana, Barbara, Lane, Quinn, one of you want to comment on this? Barbara, did you? You're on mute.
Thank you. Yes, I think it's really important to for medical and healthcare professionals to know, and I'm sure all of them do, that when we're talking about trans youth, it's a social transition. Like Lane wasn't on hormones or blockers until 2 years ago. So there was all those years in between where she had socially transitioned. She would have preferred to have socially transitioned when she was 3 or 4, but I thought we had dodged the bullet because she wasn't in distress, but then the distress happened and she talked about not wanting to live. And, so it hasn't been a completely easy path for us. It's been easier than for many people, but she was having that gender dysphoria and real problems with feeling happy with who she was. And so that's when it was like, oh gosh, everybody would rather have a child who's alive, we hope, and being who they want to be versus like trying to put them in a box and that doesn't fit for them. But, so for people treating younger people and helping parents in particular understand that like gender expression at that age is really important to who they are and their self-esteem, and helping the parents recognize that not trying to control your child or have them fit into society's box of what a boy or girl should be, not just for trans kids, but really it's really important for my son Rory too, to feel affirmed as being a boy who isn't, who is more sensitive, is more artistic, is all the things that make him so wonderful, but that he's not a typical boy. So and having a place where boys like that can be celebrated and affirmed. And so Elaine had a couple of points she wanted to make too.
Yeah, I mean, well, these are more about like what can happen like in the office and like going into the doctor's office to make me as a trans person feel more affirmed. So can I go into that? Okay, so first off, I talked about this a little bit at the beginning, like with schools, like sharing safe space stickers. I think we, like the other panelists have talked about this a little bit, but just having like stickers and just decorating your office to like show that like trans kids who are walking, like that's the first thing that we see, like showing us that space is like affirming and accepting of like LGBTQ plus identities. Like that's so important. Like whenever I go into a room that I see those types of stickers, I feel like this immense like sense of relief that I won't have to like, try to like justify my existence as someone or that kind of thing. Going off that, also in the waiting room, there are a bunch of magazines around, and I've been to doctors' offices where like the magazines have been sort of, I guess, reiterating like the binary world, like our binary world. Like they've been saying like sports for boys and that kind of thing, and then like dresses and like skirts and that kind of thing for girls. And it's just like going into those types of offices has like I've had to like going into those types of offices has reiterated like that girls are supposed to do this and boys are supposed to do this. And I sort of had to like debinarize my mind in a sense, like from that, and that like that's not fun. Also having like making sure that the receptionist is like accepting and supporting of these identities, because I've like at the airport, like sometimes I've had to go up to a person and they've looked at my because on my birth certificate it says like I'm biologically a boy, and they look at my appearance, which I present as a girl, and I've been nervous I'm going to get into a conversation about what it means to be trans, and they won't agree with my existence or that kind of thing. And I don't want to have to experience that kind of conversation with the receptionist in a doctor's office. So making sure that like I'm not nervous about experiencing that type of conversation, making sure that receptionists are accepting of LGBT identities, very important. Also, like introducing with pronouns and like normalizing the usage of pronouns, like that'll help you actually like know what your client's pronouns are and how you can like accurately address them. And it's just, we need to normalize the usage of pronouns because pronouns are good. And then making sure that like when I've been going to my gender clinic in Portland, I was pretty young when I started, like I think it was like 2 years ago when I started going on hormones like estrogen, and my medical provider was like, he was explaining to me very like clearly why I was taking estrogen and what would happen if I didn't take estrogen. And those types of explanations helped me understand what I was putting into my body and helped me actually understand like the medical transition much more thoroughly and, actually understand what I was putting into my body. And that's like, that's important for a kid to know what they're going through a medical transition. So that was really important. And then lastly, I'm just going into a doctor's office, like making sure that the medical provider that I'm talking to actually knows what being trans means, so that like, if I want to talk about like physical health issues that are related to my trans identity, like I want to make sure that whoever I'm talking to actually understands what it means to be trans, and I don't have to educate them on the spot, if that makes sense. Like I don't want to have to like have that type of conversation. Like that should be the expectation for the types of conversations.
Thank you. Well
Yeah.
said. A lot of important pieces there. So we're getting close to the time where we're going to open it up for Q&A. So I think in our remaining time, what I'd like to do is focus really more specifically on gender affirming care. And as some of you have mentioned, there's some different considerations for young people versus adults. And so this is something that I think everybody can probably weigh in on. So since we've started talking about young people, I'm wondering, Barbara and Lane, can you just say a minute about a little bit more to build on what Lane said about your experience? Because my understanding is, it's very much of a team approach, mental health and physical health. Why don't you just elaborate on that? And sort of Lane, you obviously had some steps of like a social transition, and then 2 years ago, medical with respect to hormones. That's all part of gender affirming care. So Barbara, you want to just lay this out a little bit for us? You're on mute.
I'm muted.
Okay.
There you go.
I think it's important for everybody to understand, which I'm sure with this audience that they do, that there's a huge mental health component of this, and that kids who are getting cross hormones or go on blockers, that doesn't happen with a request. You have to see a therapist who can really work with the kid to really make sure that this is the right path, that there aren't other things going on. And so Lane, Lane has seen some great therapists over the years, and that's been super helpful. And it's been and helpful for the family too. So I think that the mental health component is really a critical component, and it exists. And I think, most practices have that incorporated into their care. But I think that understanding, like the whole thing with insurance, like is really a minefield for parents and for kids too. Like not just the gender marker on the insurance cards, but just like what care is covered, what isn't. Like that all goes into the stress of being a family who might be struggling with this early on. But just emphasizing that the medical professionals have such an influence, and in schools too, like that critical piece of the nurses in schools and the trainers, all of it, because it all comes together with like, okay, what bathroom, what locker room, how do we change? Where does Lane change? How does that impact the other kids? And it took me a while, because I tended to, early on, I'd be like, well, we don't want anyone else to feel uncomfortable. And, and then I realized through some education that it was like one person's discomfort doesn't trump somebody else's civil rights. So if you're a parent and you're saying my child is not going to be in a locker room with somebody who was born biologically male, then your child is the one that can opt out of being in there, because the trans kid has a right to use the bathroom and has a right to use the locker room, and is the person who's most concerned about privacy. So understanding, bringing the healthcare professionals in the schools really up to date makes a big difference.
Thank you. And I also just wanted to throw out to everybody something that I know was a concept you were referring to for Lane, and then I know this is true for adults too, which is just the whole idea of social transition, which is, anyway, I'm not going to talk. Quinn, do you want to talk about that for just a minute, whether it's for young people or adults? Because I know you work with both.
Yeah, sure, absolutely. So social transition is I'd say actually probably the most visible to other people aspect of transition. It's publicly changing your name, your pronouns, the clothes you're wearing. sort of the coming out process, I think there's this great deal of sensationalism around medical transition when it's really fairly straightforward and boring medical care. But in our support groups, this is really our bread and butter programs. 80 to 90% of what we're talking about, it's not, oh, where do you get hormones? It's how do I navigate this relationship as part of my social transition? There's a lot more nuance and compromise that goes into transition that I think gets broadly acknowledged. There's a lot of deciding what fights you're going to fight. How do you deal with crummy authority figures? How do you deal with those core relationships in your life that goes into social transition? And I think increasingly, especially with adults, as we're moving towards an informed consent model of care sort of being the standard, and mental health is no longer necessarily in a gatekeeping role to accessing gender affirming care, that it's rather sort of in a supportive and soundboard role. That social transition is really where the support needs are. I think I'd also just add, I talk to a lot of parents of trans kids as well as a lot of trans youth, and I unfortunately, a lot of the youth I speak to, they don't have Lane's story, they don't have a supportive family, and I hear from parents and hear from providers that there's so much anxiety about doing harm, about this being a mistake, about just hoping that they can put this off until adulthood. And if there's any one thing I can say about providing care to trans kids is there is no such thing as a neutral decision around providing gender affirming care. You can be affirming and encouraging a little bit of more time to think. That's okay, and places like the gender clinic are set up to say when that's the right choice. But denying the care because you think they can just deal with it later on in life, that has permanent consequences. Puberty has permanent changes to the body that don't go away. And at MTN, we're working with youth every day who are in crisis because they're being denied care. And I've spoken to parents who've lost their children because they were so afraid of doing the wrong thing. And as it turns out, they did do the wrong thing. And they loved their kids. They loved their kid, but they were just so terrified. But gender affirming care is beautiful. It is the rare example of a joyful opportunity in medicine. And so, we don't need to push people down any specific road, but there is no good wait and see option either.
Thank you, Quinn. I will just say from my own experience working with people, you see the before and the after. You see the young person struggling, depressed, you just withdrawn, whatever, and sometimes really distressed. And you see the lifting, the freedom, the joy that just comes from finally being able to be moving in a direction of who you are. So Deb, Jude, quickly, we have a comment on hormones for adults because, Quinn has told us this is like the most common request that she receives in the state. How hard is this? Is this something that a primary care physician can do or nurse practitioner?
I think it's relatively easy. It's less complicated than taking care of diabetes. And I think the best analogy I might have, if people have any experience taking care of somebody in the hospital who had a heart attack, initially when you start taking care of people who've had a heart attack, you feel like you're going to have a heart attack. Oh my God. And then after a while, you see that it's fairly cookbook that, there are really only, there's a set of orders that you follow, and everything just from the medical piece, you just sail on through. And then you can focus on the human piece of taking care of the person with the heart attack. And so I think that's what most of us want to do. We have compassion for our trans patients. And once you learn this simple piece, there's one medication basically for trans men, which is, testosterone, and 3 medications for trans women, estrogen, spironolactone, and sometimes progesterone. There are some variations on this, but it's really not complicated. And then you can start to focus on the joy of connecting with somebody that's going to be so appreciative that you're their life preserver.
Thank you. Anyone else want to comment on that? Jude, Lynn?
I totally agree with what Deb has said about this. I think that gender affirming hormone therapy is well within the purview of primary care. There's 4 primary hormones to be familiar with as a provider. There are a plethora of resources that are available to us as providers. Some of my favorites include up-to-date Fenway Institute, UCSF guidelines. There's also a provider-to-provider peer consultation service called Transline. If you're feeling stuck and need to talk to a provider who's competent in hormone therapy. But I think it's a lot of fun. I think there's a lot of joy and a lot of gratification in it. And I would encourage more providers to consider learning more about it.
Yeah, absolutely. It really does make a difference. And in the end, like if you're in a position to help a person to be able to live their lives, to be supported as who they are, to feel healthy and be able, therefore, to be able to actually try to engage the job market, support themselves, be part of their communities. I feel like there's no harm in support, but there's an awful lot of harm in not supporting people. Right. I want to, yes, Lane, you absolutely get the last word and then we'll move to questions. Go for it.
I wanted to talk a little bit on my experience with how going on hormones has really positively impacted my life in the way that before going on hormones, I hadn't yet gone through puberty, but I was still experiencing large amounts of gender dysphoria. For those of the audience members who don't know, gender dysphoria is this condition that occurs when you're when the gender assigned at birth doesn't match your actual gender identity. And if I hadn't gone on estrogen, I would have gone through puberty and my mental health would have essentially spiraled and I would not be living the life that I am today. I would not be as happy. I would be struggling a lot. And I'm just so glad that we made that decision to, go on estrogen so I can, I'm living in a body where I feel like myself, where I feel like, where I'm happy, which makes me happy, which I finally feel connected to my body, not all the parts of my body, but most of it. And that is huge for my mental health. So I just wanted to share how much of a priority that should be for medical providers.
Yes, at the right time on an individualized basis, all of that. Absolutely. And so glad for you. All right. Thank you, panel. You were awesome. Appreciate this, each of you. And we're going to move to questions, and a number have come in through the chat. And the first one was a question of how do we support LGBTQ people as they become parents? Because people have an idea of mom equals female, dad equals male. And of course, there are many limiting ways in which, people live their lives and become parents. Does one of you want to lead us off on that? Quinn, Jude, Deb, Quinn, are you on?
Sure. I think broadly, when we're thinking about LGBTQ people becoming parents, is just, and we've known this for a while, it's just knowing that our expectations of what a family looks like needs to get bigger. Because there are so many different ways to be a family, and LGBTQ people can have biological children, they can adopt, we can be step parents, we can foster. These are all ways that we can, be families that have children in them. And, they're really rigid gender roles that I think we associate with parenthood that are not necessary to being good parents. All the data says they're not necessary to being good parents. And so I think just challenging yourself to say family can be bigger. I think with trans people in particular, particularly when we talk about having biological children, sometimes the way we get to having biological children looks a little unexpected, right? We can talk about, transgender women who are providing sperm for reproduction. We can talk about trans men who are giving birth. And these are increasingly common experiences. They're certainly not new at all by any measure. I've had the joy of being with several families with trans men who've given birth in the last couple of years, and it's been remarkably normal experiences. It's no different than when my own nephew was born. I think the only difference is, I'm not sure that the care providers that they see are always prepared for them, and they get really flustered about language and about terminology. And I've watched one father arguing about the fact that he's dad, not mom, in the middle of labor with a nurse. And that's not an appropriate time to have that conversation. It's really just not an appropriate conversation. We're going to be who we are to our kids. But just, family can come in a lot of surprising ways. And, it's a really beautiful part of life, and we shouldn't tarnish it.
I agree with very much with what Quinn has to say, and I sort of look at this transgender parenting as sort of like a living organism. An example that I in my practice, I had a lesbian couple, one of whom transitioned to as a trans man, and we took the female of the family and like supported her through, like, I thought I was lesbian, and now I'm with a man, and because we were nurturing to her, they just had a very fulfilling experience together as the partner transitioned to male. Now they're living 3 hours away on the Cape, and they're working with us to try to figure out how they can have artificial insemination and have a child. I think the biological mom is going to bear the child, but it wouldn't be much different if the trans man wanted to have the child. But it's this sort of exciting, loving, I would call it organism of experience that it's not a rigid, you do it this way for every trans person.
Thank you. We have a number of questions. I think we're going to take one more. I want to say that the questions are being recorded, and we will try to get back to you about these, okay? Because they're all important questions that have been asked. I'm going to pick one more question here right now, which is about resistance to the pronoun they, them, pronouns they, them. Even though I think they're words of the year under Merriam-Webster, but and if we could just talk about that, and for a second talk about non-binary people, and as again, part of the just spectrum of human existence that is fine and awesome and normal. Somebody want to kick us off on that? Jude, Quinn?
Sure, I'm happy to respond to this as our resident they, them. And gosh, it has been a learning curve in my life, with my family, with work settings, every new interaction. And I personally don't really care if people don't get it or don't like it, but it's about respect, essentially. And for me, as a non-binary trans person, when I'm she'd, in particular, that feels like nails on a chalkboard to me. It's uncomfortable. I don't like it. I think that we've widely debunked these arguments about being not grammatically correct. English language, again, is an evolving organism. We've used pronouns differently throughout history. It's been recognized by the dictionary publishers. I mean, we are at a moment where we just need to move forward with the options that we have available to us. And for many of us in the trans and non-binary community, they, them is what feels best. And I would just encourage people to feel empowered to to assert that.
Yeah, and I just want to say, like, I've had my own learning curves in life about a lot of things. I've been a GLAD for over 30 years. I've seen, like, in a way, generations of this community coming into its own and people's, increasing freedom to figure out who they are and to actually speak about it with real integrity and more precision. And it's so important. And I just wanted to say, like, what is the big deal? Okay, like, it doesn't sound right to you. Okay, but like, what is the big deal of just treating somebody as they are asking to be treated? So just want to put that out there. I think we have been given dispensation to do one more question. Thank you very much, folks, for that. And the question I want to pose is, there some questions about hormone replacement therapy or for young people, and like at what ages to administer medication, how to think about the effect on mood disorders and so on. And I know we cannot answer these questions in detail, but I would ask if somebody could point us in the right direction for the people who are asking these questions. How do they get more information about these things? And again, some of it's in your materials, but how do people get more information? Deb, Jude, Quinn, Barbara, Lane.
The gender clinics at Maine Med and Northern Light are both wonderful resources. I know in addition to providing care, they do a lot of consultation work as well. And so they're a really great place to reach out. There's also a wealth of information online. I would give the obvious caveat of make sure you're getting it from a medical provider and not necessarily the parenting blogs, which can be a bit misleading, I think. But yeah, it's a Google search away.
Yeah, and a +1 on the gender clinics. I mean, the one I know better is the one here in Portland at Maine Med, and phenomenal resources available. So that's true. And I know, well, I believe that they would be the first to say that if you're in private practice and you have a question about referring to them, just go ahead and refer. And if they don't feel like they need to see the individual, they'll send you back to your pediatrician, who's going to be a better pediatrician than Barbara and Lane ran into, more understanding, or your other primary care provider. Deb.
I certainly this wouldn't be the first aspect of transgender health hormone, cross-gender hormones that I would get involved in. I mean, I've only treated about 5 or 6 trans youth myself, but Boston Children's Hospital's GEMS program, I mean, they support children from around the world, and they have very caring primary care physicians and endocrinologists there that would be willing to guide you. I mean, I feel that before providing any medication, be it hormone blockers or cross-gender hormones to an adolescent, that I have to truly get the parents, both parents, to be involved. If there are 2 parents involved in the health in the life of the adolescent, and make sure that they understand the risks and benefits. And I usually have the patient and or parent tell me what do you know are the risks and benefits, and then I supplement with my knowledge. And I definitely have to have a therapist give the green light before I would provide cross-gender hormones or hormone blockers for an adolescent. It's only fair to everybody involved. Unfortunately, it's I would like to be able to give hormones immediately to satisfy everybody that walks in the door, but you really, for everybody's health and well-being, be it an adolescent or an adult, following a protocol and that you've set up is the only way to make sure everybody ends up being happy. If I can, add that there have been people that I have started, adults that I've started on cross-gender hormones, and it became clear that we needed to stop the cross-gender hormones. And because we set the stage beforehand, there was, everything went smoothly with stopping the hormones.
Yes.
Okay.
Everybody's an individual. I'm hearing that from you. And you stay with the individual and keep counseling them over time. It's not as though you prescribe hormones and walk away, you're checking in. Thank you. Thank you for that, Deb. The other thing I just wanted to say about care in an adolescent context that I've seen is how in the end, of course, it is the center of it all is the young person. And it's about how to support that young person and how to do it in the right ways at the right time to come up with the right plan. And that's why that, having just different kinds of perspectives, including the mental health perspective, is just so important. So people are being very thoughtful. And sometimes I hear these caricatures about doctors just whipping off, prescriptions for hormones and so on. And I think, on what planet do you live? Because this is not what is happening. Okay, so I think we're supposed to wrap up the questions now. Thank you very much for the extra time. And I guess I would just say that, a lot of what we've been hearing here and what you're seeing is we've got LGBTQI plus people in Maine in your practices, vibrant part of the population, more and more young people identifying that there is a very important public health frame in our systems that obviously are in dialogue with people's actual experiences, and everybody's wanting to work on that. And, treating people with dignity and respect and listening matters in life, and it matters in your various professions. I know everybody's busy, and thank you for everything you can do to be a real human being and a real professional and learn what people are bringing into the office besides their flu or their broken arm and what else is underneath all of that. I like the idea that this is not extra credit. This is part of what you do. And I know the medical providers on the call have been really clear, and Quinn has been clear. There's no reason that trans-related medical care, gender-affirming care just can't be part of primary practice. It really should be, especially because you all take the sort of whole person perspective. And the last thing I wanted to just point out, if I may, in conclusion, is one of your materials is a whole list of professional statements, organizations, the AMA and so on. I've personally been very moved, like in legal briefs, when the AMA says, we thought it was a mental illness to be gay. We learned we were wrong. We're rectifying that. And they say the same thing about trans people and gender diverse people now in briefs in cases we've had to file. And I think we have to just understand that we're all learning. And the point is to join in and to continue learning as a way of trying to really support people, have healthy people, have a strong and robust state. So thank you all so much for participating, and thank you to this total rockstar panel. It's great to have you. And have a good rest of the conference, everybody. Thank you so much.
Good morning, everyone, and welcome. I'm Dara Fruchter, Project Manager, Infant and Maternal Substance Use Prevention Coordination on both the maternal and child health and prevention teams at the Maine CDC.
Good morning. I'm Bobby Johnson, the Associate Director of Child Welfare Services, and I've had the opportunity to be part of supporting substance-exposed infants and their families for many years.
This session includes a presentation about the Maine Mom Initiative and its integrated care model, and an overview and update on Maine's plan of safe care, which includes a panel that will talk about the successful intersection of these two initiatives during a mom pilot last spring at Midcoast Parkview Health. We'll finish the session with a short film profiling a new mom who changed the trajectory of her life through the supported experience of creating a plan of safe care.
It's our pleasure to introduce Dr. Elaine O'Connor, DNP, Director of Perinatal Addiction Treatment at Maine Medical Center and Medical Advisor to the Maine Mom Initiative. Thank you, Elaine.
Thank you. Welcome, everyone. Great to see you this morning. I'm going to bring up some slides. Right here. I'm going to be talking to you today about the Maine Mom Initiative. Just a quick sort of 20-minute presentation. You heard yesterday from Liz Remillard, our program manager, about the project, and I'm just sort of going to tee it up. And then you're really going to hear the on-the-ground experience from Midcoast, which is amazing, and the work that really, the intersection between Maine Mom and the Plan of Safe Care, as Dara and Bobby mentioned, the two certainly go together. So what is the Maine Mom Initiative? So it is an integrated service model for pregnant and postpartum people living with opioid use disorder. So when we talk about integrated, we really mean providing substance use treatment and prenatal care, postpartum care, really all in the same setting. And this is a 5-year initiative awarded to the Office of Maine Care Services by CMMI through 2024. We went live in July of 2021, so just a couple months ago, and we're currently serving 25 patients with a goal to reach about 300 by the end of the year. But we are enrolling women every day, and it's a really exciting experience. The Maine Mom Initiative will enhance the care delivery system for pregnant and postpartum patients with substance use disorders. Again, the goal is to really increase care integration and improve outcomes and also reduce costs. So I can tell you sort of from an on-the-ground experience how much patients really appreciate this and how much it helps us provide better care. So I work in an integrated setting at Maine Medical Center, and oftentimes we'll be seeing a patient who has a question about their pregnancy, a question about fetal movement, or maybe needs some labs drawn, and that can be done at the same time when they're in for a visit with me. And then on the flip side, they might be in for their prenatal visits and then have some questions, might be second trimester, and they're experiencing more cravings or thoughts of using or something like that, and they need a medication adjustment. So the prenatal team can grab me and I can do that adjustment when they're there for that visit. So it really lets us provide the best care, the best wraparound care all at the same time. So Maine Mom Services includes group counseling, which we're sort of hoping to get to. COVID has kind of stymied some of those plans, but we're trying to work in the direction of group-based care, both from prenatal and substance use disorder perspective. We're integrating recovery coaching services, and I can't express how incredibly important that piece is. The stigma that pregnant patients with substance use disorders experience is really profound. And so the ability to work with someone with lived experience who they themselves had a substance use disorder during pregnancy really gives them an outlet to talk about their feelings, gives them support, gives them the motivation to really stay on track. And it really, the patients express over and over how nice it is to work with somebody who really understands me. And that's in quotes, those are the words that they use. And so it's really a great opportunity for patients. So patients in the Maine Mom model get their medication for addiction treatment right in the same setting, again, with their prenatal care. There's a real emphasis on screening for health-related social needs, which I'll talk a little bit more about, but making sure that mom has everything that she needs to really create the safest and healthiest environment for her baby at birth. There's referrals and coordination with other maternal, infant, and support services. So depending on other things that need to be done, there's connections that happen across the system, certainly working very closely with the Cradle Me system, public health nursing, Maine Families. So agencies that really can, again, help mom put her best foot forward as the pregnancy progresses, and so that she can be the mom that she really wants to be when the baby's born. There's frequent communication with other care providers to inform care planning. So again, a lot of multidisciplinary engagement, making sure that the counselor who's working with the patient during the course of the pregnancy is talking to the social worker who might be putting together the plan of safe care, and making sure that we're all on the same page, and that the mom really feels that she's supported in a wraparound way, getting the services that she needs, not overwhelmed by the number of things that she's trying to deal with, but just feeling like we're really her team. I think of us as really her team, as trying to support her as she moves forward. And then supportive conversations about family planning, contraceptive care. That's certainly a choice, but it's nice that that's available for them when they come in for their visits, again, regardless of whether it's for their substance use treatment or their prenatal care. So these are the Maine Mom partners. So it's important to note that in this first year of the model delivery, the care delivery partners that went in on the application with the state to get this grant are the only ones rolling it out in this first year. So you can see it's really across the state, which we're really proud of. So 16 different places. After, July 1st or July of next year, it will be a Maine Care covered service. So we're in the process of, writing what that will look like. So there will certainly be other Maine Mom programs, in 2022. This first year, it's just rolling out in these care delivery partners, and they're providing a lot of feedback, a lot of information, what works well, how do we collect data most efficiently? How do we sort of implement this in practice? And, because there's bumps in the road as you're trying to implement a new program. So they're providing that feedback, which is really helpful. So we have a new website that's really exciting. So you can go to themainmom.org. You can enter your zip code if you're looking for a treatment program near you. There's more information about what the Maine Mom program is. And then, again, connections to other support services. We're really excited that we're going to have a media campaign kicking off shortly. So you're going to hear more about the Maine Mom program, on the radio, Instagram, places like that. So we really want to get the word out. One of the things that we're seeing, I think, particularly with COVID, as women presenting much later in the course of their pregnancy, I think uncertain where to go and, concerned about a variety of different things. So we're really trying to get moms to come in as early as possible in the pregnancy with just the goal of supporting them. The more time we have to work with them, the more time we can get the resources that she needs in place. Just going to give you a couple quick slides about working with pregnant and postpartum patients with substance use disorders. I think that will help tee up the panel a little bit because, there's this intersection, of course, between making sure that the mom has what she needs to create a safe environment for that baby. So I just want to remind folks that most pregnancies, and it's really 80% plus in women with SUD, are unplanned. Oftentimes, particularly when they're in the throes of a substance use disorder, they may have very irregular periods, not necessarily able to access contraceptive care. So a lot are unplanned, and sometimes really they don't discover they're pregnant until they're fairly far into their pregnancy, again, because of the substance use disorder may create a lot of menstrual irregularities. Most often, mom is kind of scared and stunned, not sure what to do. This is sometimes the setting if you're working on a substance use treatment program, you do a pregnancy test. Oh my goodness, I'm pregnant. She oftentimes doesn't really know what she wants to do in that first visit. She's scared. How is this going to affect my baby? Kind of all those questions. So she really needs a lot of emotional support as she kind of decides, how she's going to progress. And how does Maine Mom answer that? So Maine Mom provides integrated mental health and peer support, again, which I mentioned. So again, a good supportive team around her. It supports patients during pregnancy and up to 1 year post-pregnancy, regardless of outcome. So this is really important. One of the things I hear a lot is from women, if I have a miscarriage, are you going to stop my medication? Of course not. We're going to continue you in treatment. If a woman decides to terminate her pregnancy, we're also going to continue her in treatment. And, hopefully we create a situation where, moms, the vast majority of moms go home with their baby after birth. But we, again, will continue those women in the Maine Mom program, even if the infant is placed outside the home. In some ways, those are the highest risk women. And so we want to make sure that they have the services that they need as they're trying to reunify with their child. And they get connection to contraception, lots of conversations during the course of the pregnancy and after. And again, contraception is a choice. I really try to talk to women about the fact that, long-acting reversible contraception, Implanon and IUDs are the standard of care for all women of childbearing age. So I want to make sure that they understand we're just treating them like any other woman of childbearing age. Intimate partner violence and adverse childhood experiences are extremely common. So oftentimes women are presenting, fearful, low self-esteem. They're in maybe an unpredictable, unstable relationship. That can lead to a lot of challenges. So not to mention chronic stress, which is associated with poorer pregnancy outcomes, but they may have food or housing or transportation insecurity, depending on what their situation is at home. And so we really try to work with women, again, to get them the services that they need. How does Maine Mom respond to that? So we screen for social determinants of health. Again, those things like housing and food and transportation and other issues. We screen for intimate partner violence, mental health disorders. So we're trying to identify those things all very early on, getting them the services they need either in the practice or referring to outside sources, like I already mentioned, particularly through the Cradle Me program. We're providing integrated mental health services so people can get substance use counseling in addition to mental health counseling. The peer support is huge here too. Just again, somebody who has lived experience, who understands mom. And then really trying to work toward education. When we are able to offer group visits, we're providing a group visit sort of set of topics to discuss. And a lot of that is around, healthy parenting. What does that look like? Because again, some women have had very traumatic relationships and they themselves have had difficulty with attachments and other things. So again, trying to help mom put her best foot forward as she moves through the course of the pregnancy. As I already mentioned, stigma is encountered everywhere. There's no group that is more stigmatized, in my opinion, than pregnant patients with substance use disorders. Even my non-pregnant patients with substance use disorders will, show stigma toward my pregnant patients. I can't imagine that they're doing that when they're pregnant. Those types of issues come up all the time. Women experience this everywhere. They experience it at the pharmacy. They experience it in public. They experience it at home, probably even when they encounter medical care in different places. So I think the peer support is probably the biggest piece here. Again, somebody who's able to talk to them with lived experience is super helpful. Pregnancy is a tremendous source of motivation to enter recovery, to really change their lives. It's one of the reasons I love working with pregnant women is they'll come to me and say, this is going to make my life different. I want to have a different life because I want to do what's right for my baby, particularly when she comes from a situation which may have been very traumatic. She sees this as her ticket to wellness and creating the life that she always wanted. So there's a tremendous source of motivation, but it comes at this sort of conflict when worried about, okay, well, I have a substance use disorder, is DHS going to, take my baby? That's the big one, sort of, am I going to lose custody of my infant because I have a substance use disorder? And one of the things I hear often is, am I going to lose my baby because I got into treatment? And that's really the message we want to reverse. We really want you to get into treatment, and stable women who are in treatment for their substance use disorders, assuming there aren't other issues present, definitely can be safe moms to go home with. And so we're really trying to get folks into treatment early. From the Maine mom perspective, what we really try to advocate for is open and honest conversation, education. I'm, straightforward from day one when I meet a pregnant patient that there is this notification to the Office of Child and Family Services about a substance exposed infant. Women really appreciate that level of honesty, that they sort of understand what's happening, that they feel like it's clear, it's transparent. And I want them to come in feeling like we have this very clear and open relationship. So we do a lot of education around what does that substance exposed infant notification look like? What is neonatal abstinence syndrome or neonatal opiate withdrawal? We do a lot of education around that. So when the baby's born and potentially withdrawing from the buprenorphine or methadone, whatever they've been on. We talk about Eat, Sleep, Console, which is the way in which we monitor these infants for their substance exposure. Peer support is hugely important. Again, you're going to hear that theme throughout. Counseling, and again, screening for social determinants of health and other things, and really trying to build this plan of safe care that you're going to hear more about, to create the safest environment and all the supportive services that she needs in place during the course of her pregnancy. A patient really needs treatment for their OUD among other substance use disorders. That was a question that came up yesterday. We're definitely seeing more what we call polysubstance use during pregnancy. But this Maine Mom provides access and education about medication for addiction treatment, which is absolutely the standard of care. Women come in and say, I want to get off everything, which you can certainly understand that motivation. But there's a physical dependence to the substance that can create a risk if you stop it cold turkey to the fetus. So we really want women to get into treatment, whether that's with buprenorphine. You've probably heard of that as either Subutex or Suboxone, Subutex being the mono product or just the buprenorphine, Suboxone being the combination product, which is buprenorphine and naloxone. Just a reminder that both can be used during pregnancy very safely. You don't have to make that transition to Subutex. We use Suboxone all the time. Methadone is another great option for women who prefer that for their treatment of their opiate use disorder. But access to MAT improves pregnancy outcomes very clearly. It makes pregnancies go to full term. You're not seeing this preterm delivery of infants. It definitely increases access to prenatal care. So they're coming in more, getting their services. And it reduces the risk of high risk behaviors. So if you have a situation where mom is actively using substances, she could be using those intravenously. So she's at risk for infectious disease through that. It also, again, reduces the risk of complications to fetuses. That was very interesting. Dr. Patrick talking about yesterday, these preterm infants that don't have a withdrawal syndrome, but all the complications from a substance use disorder in pregnancy that's untreated that can lead to an early delivery, that we really want that full-term infant that we can just monitor for withdrawal because we can do that very safely. Infectious disease is super common in my patients. It's about 50% of women with substance use disorders in Maine test positive for hepatitis C. And again, that's an education and support. So women are very concerned about that. What does that mean? So we talk a lot about, the risk of transmission to your infant is only about 5%. That it doesn't change your delivery. You can breastfeed provided your nipples are not cracked or bleeding. So these are all educational pieces. But there's a lot of concern. And I think the other piece is making sure that moms are referred to appropriate resources. For those of you that have been doing this a long time, the treatment for hepatitis C is so much simpler than it ever was. 10 years ago, we had to send people to lengthy treatment. They felt sick. It didn't always work. Now you send them to treatment for a short period of time. They take pills. It cures their hepatitis C the vast majority of the time. So making sure that they're connected to that treatment postpartum. We don't treat for hepatitis C during pregnancy or when they're breastfeeding, but again, getting them connected to a virology clinic or wherever they need to be. The other thing is making sure that a hepatitis C exposed infant is screened at 18 months of age for the hepatitis C virus. And again, those kids can be treated very, very young, and it's very successful. So if they are to contract hepatitis C, again, the chances are very low, but it certainly is present. We want to make sure we screen that, capture it, and get them treated as quick as possible. Mental health comorbidities are very common. And so again, we try to do a lot of routine screening. There's integrated medication and counseling options available. One thing that's really important to know is that pregnant women with substance use disorders are at much higher risk for postpartum mood disorders. So it may be a worsening of an underlying mood disorder. It might be a new onset development, but one of the greatest parts about Maine Mom is really that 12 months after delivery or after the pregnancy, where we can continue to care for them in that integrated setting. They're getting screened for worsening mental health disorders. We're making sure that they have the care that they need. They can get the contraception if they want it, and it's all wraparound because she needs really consistent supportive care. Historically, when women were in a treatment program during pregnancy, they were often transitioned to another program postpartum. There was risks around care transitions, fragmented care, and the passing off from one clinic to another. Sometimes medications didn't get filled, and that puts women at super high risk. We know that women who are postpartum are at higher risk for maternal morbidity from drug overdose. And again, that may be secondary to the worsening complications of mood disorders, fragmented care. So we know these women are potentially high risk. It's a significant cause of maternal morbidity postpartum as drug overdose. So we want to make sure we're tracking these women, we're caring for them, that all people who have a substance use disorder have access to Narcan. And that includes pregnant women. I hear a lot of people say, well, you shouldn't give it to pregnant women because it could cause withdrawal syndrome. But certainly if a pregnant woman is overdosing on opioids, we absolutely want to reverse that with Narcan because we want to save her life and her life of the fetus. She often lives with other members of her household or partners who have a substance use disorder. So one of the nice things, again, about Maine Mom is there's really a question like, do you live with anyone? Can we connect anyone in your home to the resources they need? It's common, I would say, probably, at least 3/4 of the patients that I see are living with someone else in their home who's affected by substance use disorders. And it's really hard for her to stay on track with her recovery if there's someone in the home that's actively using. So we try to connect those folks with resources as quick as possible. Also, a lot of concerns about pain management at delivery. We've written great guidance through the state work that I've done with the team under Gordon Smith. So there's a really nice evidence-based clinical guideline available. So that's the quick overview of Maine Mom. There's a couple questions up here that I can just look at. So one of the questions, does this include the MAT? Does the MAT include both methadone and Suboxone for this specific program? So yes, absolutely. People can be on either buprenorphine or methadone. And absolutely, if the mom's already on MAT, she can definitely apply to the program. She can absolutely be part of it. I transition people into care all the time. Who are either already on MAT, they become pregnant and they want to come to our program again because they can get all the services in one location. They only have to find one ride to get there. They only have to get childcare for one visit. They only have to take one day off from work, all the things that go into this. And so absolutely they can come to any Maine Mom program and we can initiate them because what they really need are the wraparound services. So to make sure that we're meeting all the social determinants of health and they're getting all the care that they need. So I've taken my window of time, and that is my last slide. There's some contact information here. Visit themainemom.org, and thanks for your time. And I'm going to pass it back to Bobby and Dara.
Thank you, Elaine.
Thanks, Elaine. Last year at this conference, Bobby and I introduced Maine's Plan of Safe Care, a document developed in 2020 in collaboration with the Office of Child and Family Services, the Maine CDC, including Public Health Nursing, the Office of Behavioral Health, and the Maine Mom Initiative. Last year, we explained why Maine and every other state in the country are required to develop plans of safe care for all substance-exposed infants, their families, and other caregivers. And we shared our phase 1 implementation plan for Maine's Plan of Safe Care, which included training and education leading up to January 1st, 2021, when we began creating plans of safe care for substance-exposed infants and their families at all 25 birthing hospitals in Maine.
Ashley Olin, OCFS's Plan of Safe Care nurse, will share information regarding data that child welfare agencies in every state are required to report to the federal government. For development of the plans of safe care, states collect this data. Since last December, Ashley, along with Dara and with the support of Dr. Adrian Carmack, the medical director at OCFS, have trained over 1,000 clinicians, nurses, nurse administrators, public health nurses, caseworkers, and a variety of other social service providers statewide. And since January 1st, 2021, when OCFS implemented Maine's Plan of Safe Care process, close to 80% of substance-exposed infants statewide have received a plan of safe care that was created at birth with parents and families. OCFS is working with other stakeholders to develop an online plan of safe care document that will be editable and beginning to make plans of safe care prenatally with prenatal providers, including women's health and pediatricians. The earlier we engage pregnant and parenting individuals to create a plan of safe care, the better the long-term outcomes for both the infant and their families. It's my pleasure to introduce Ashley Olin.
Thanks so much, Bobby and Dara. I am going to share my screen. And see if I can get that. Okay. All right. So I will be providing an update on Maine's Plan of Safe Care. Hopefully everybody can see that. And as mentioned, I am the Plan of Safe Care nurse for the Office of Child and Family Services. So what is a Plan of Safe Care? Many of us have been involved in the Plan of Safe Care over the last year, but for those of you who are new to this, this is a United States federal government requirement. Every state designs a plan of safe care for infants exposed and or affected by prenatal substance exposure, their mothers, families, and or caregivers. And this is outlined in CAPTA and CARA, which was updated in 2016. So as Dara mentioned, since January 1st, a plan of safe care is now created for any infant notified to OCFS as a substance exposed infant and or affected by and the surrounding family for the state in the state of Maine. A plan of safe care functions to ensure the supported and ongoing safety, well-being, and best possible long-term health and developmental outcomes for the infant, their mothers, and their families. It serves to identify needed services and resources and define actions needed to align these. The plan of safe care includes referrals to these services as well. So the state child welfare agencies are responsible for federal data reporting, but there's flexibility at the state level around who initiates this plan of safe care process. The data that we're required to report are the number of infants identified as being affected by substance abuse, withdrawal symptoms resulting from prenatal drug exposure or FASD, the number of infants for whom a plan of safe care has been made, and the number of infants for whom referrals were made for appropriate services for infants, including their caregivers. So in Maine, Title 22, 4011B defines the required actions to be taken when an infant is identified as substance exposed. And then Title 22, 4004B defines creating a plan of safe care for each substance exposed infant. As Bobby mentioned yesterday at the State of the State, the Office of Child and Family Services receives somewhere between 45 and 90 substance exposed infant notifications each month. A notification for a substance exposed infant to OCFS does not always equal an open investigation for that family. The goal of the plan of safe care is to remove barriers to support and create the plan of safe care with open-ended questions and the use of destigmatizing language, and create that with a stance of collaboration with a focus on the strengths of that family. As mentioned before, the development of the plan of safe care and its implementation has been an ongoing collaboration between the different groups within the Maine CDC, like WIC, Maine Families, Public Health Nursing, Child Development Services, and more. We've also worked with the Office of Child and Family Services that includes Family First, the Office of Behavioral Health, Maine Mom, extensively as we just heard about, and the DHHS's Commissioner's Office. Every state's plan of safe care is designed around their specific substance use laws. And here in Maine, we developed the plan of safe care primarily influenced by our state laws, but we also had to capture the federal data along and looking at how other states had implemented their plans of safe care, and those states are listed below. So this is one of our favorite slides when we talk about the plan of safe care, because it really is a collaboration around infants and families impacted by SUD. And this could be anything from housing to healthcare providers to schools, family visitation providers, churches, parent partners, all of the folks that might be here today at this conference. So there are some key elements when we discuss making a plan of safe care. So it's known to be best practice to create this plan of safe care prenatally. And we really are looking to do that in this phase 2 of our plan of safe care implementation. We also have, we're making sure that there's patient engagement, that it's built in collaboration, and it's independent of the OCFS notification. It's based in the family strengths, and it's accessible to the patient. So over the last year, we developed a plan on our implementation of the plan of safe care. Phase 1 was over this last year of 2021, and that was implementation at the birth by the hospital, clinical, or social services staff. We're excited to move to phase 2 now, going into 2022, around prenatal implementation by the Women's Health Office, Maine Mom Team, or the public health nurse, working with the family. And then as we move even further down the line, we're looking at phase 3 in 2023, where we'd hope and our goal is that a universal plan of safe care is created for all newborns in Maine, regardless of substance exposure. This is a brief overview of the timeline of our phase 1 and phase 2 implementation. As we mentioned, currently plans of safe care are being created at the birth of the infant for phase 1. And as we move upstream and widen the window of opportunity for pregnant mothers to be connected to the services through plans of safe care, we will still need some to be implemented at the birthing unit or updated by the staff there. As Dr. O'Connor mentioned, Maine Mom began enrolling over the summer of 2021, and now some prenatal plans of safe care will be started to be created in this process. Most mom sites will move to prenatal plans of safe care early in the year 2022. And this is an extensive collaboration between Plan of Safe Care and the Mom Program for joint implementation. In September 2021, the public health nurses across the state began using plans of safe care for all prenatal clients, regardless of substance use disorder. In the winter of 2021, we'll start to train prenatal providers, mom sites, and birthing hospitals for phase 2 of our implementation. And in 2022, our goal is that most plans of safe care will be started prenatally to increase that engagement, reduce stigma, and make a greater impact for families. And as I mentioned before, this will utilize families, women's health offices, public health nurses, and mom providers. And then in 2023, we'll move to plans of safe care for universally for all Maine families. So what has happened so far? As mentioned, we've implemented this at all 25 birthing hospitals across the state of Maine with significant training and outreach. Plans of safe care have been made by social workers, physicians, hospitals, caseworkers, and public health nurses. And we've had this training at many touch points with their family, with WIC, public health nurses, providers, residential recovery programs, healthcare care providers, and more. And we're going to talk extensively with the panel from Midcoast Hospital around our prenatal implementation, which was used to support our implementation of phase 2. So far, our data has been collected and put together through August, and 85% of all SEI notifications to the Office of Child and Family Services created a plan of safe care so far in 2021, which is over 400 plans of safe care. Most common referrals that are cited on their plans of safe care are needs to public health nursing, WIC, mental health counseling, parenting groups or classes, and child development services. Most commonly, the families are already currently receiving financial, housing, and transportation assistance, breastfeeding support, and MAT services. And we're going to continue to explore this data for learnings as we move forward in the process. So this is an example of one of our fillable forms of a plan of safe care, and we're really excited because we've taken the feedback and the work that we've done with many agencies across the state over the last year, and we've made improvements to the forms that we started with in January. So this is our example. Really, we want to focus on the current strengths and supports that the family are receiving and what they have. So needed assistance and goals is also included here, demographic information, and then connections to services like CDS are on the first page. The second page, or the back side of the form, has a list of many medical and social service resources, and really allows the person having a conversation and creating the plan of safe care together to dive deep into what this family may already have in place and what they may need. So if a mom's goal was to go back to school, that might help her have a conversation around what childcare needs she might need and what subsidies might be available for her to achieve that goal. We do have a plan of safe care website, which is under the Maine CDC Maternal Child Health section. It's titled Maine's Plan of Safe Care, and you may find there the updated forms that were just added and in September of 2021. So all of the needs you might have. We also have checklists for hospital staff, public health nurses, caseworkers that are working with the families, and we have fillable and printable forms. We also have a form for if the infant is going to go into the care of a resource family. We have forms for that family to fill out as well, so they understand what resources and referrals they may need to care for that infant. So we're really excited about the accessibility of all the plans of safe care. We do offer something that I really think is a huge tool, is we have bi-monthly office hours. Myself and Dara, we host these, and they're really for anyone supporting, implementing, or with questions around Maine's plan of safe care. And we're going to continue to offer this twice a month, the first and third Friday from 1 to 2 p.m. And we really have an opportunity to dive deep into the challenges and collaborate around plan of safe care implementation. And we're excited about what this will look like into phase 2. It's excellent because it's an opportunity for folks to talk with other colleagues. Maybe a public health nurse can connect with a women's health office, or a hospital is connecting with their local public health nurse. So it's a really great opportunity to have an open forum around plan of safe care. And so I invite you to join us. So as we move forward and leave the conference and you go back to your work, what topics and questions can you explore around plan of safe care? What we've noticed over the last year is the plan of safe care has really highlighted general gaps statewide. For example, need for care coordination, potential lack of follow through with services and closing the referral loops, fewer resources in certain geographical locations, and lack of consistency on reportable substances. So what can we do as a group to look forward into the future? So where in your process, prenatal, MAT, hospital, postpartum, or pediatrics, can you see the plan of safe care supporting your work with patients? Or who in your organization can assist with the implementation of plan of safe care and connect the family to resources? And what resources do you have and what resources do you need to connect to families? And with that, I will end, and we can answer a couple of questions and move into our panel. So I am going to, great, thank you so much. I would like at this time to introduce our panel of lovely colleagues at Midcoast Hospital. Thanks so much for coming together for this discussion today. I'm very excited implementing the plan of safe care prenatally at Midcoast Hospital and the collaboration and communication that you've had across the perinatal period. So joining me today is Maggie Jansen. She is an RN MPH, the mom program coordinator at Midcoast, and Nikki Benner, lead RN with the Midcoast Women's Health Office, Susan Ames, LCSW, the social worker at Midcoast Hospital, and Katie Alberico, the nurse and perinatal coordinator for the Midcoast Maternity Unit. So I would love to jump right in. Ladies, if you want to unmute yourselves, and we'll start at the beginning of the process. And we've met extensively over the last few months. And so I'm so excited for you all to share your knowledge with everyone today. So I'll start with Nikki. When a patient shares during their prenatal care that they have needs around substance use or social determinants of health, like housing or transportation, food, etc., what does that process look like for your team?
So usually we try to identify them right at the intake and start this plan of safe care as soon as we possibly can with them. Prior to having the plan of safe care in the office, it was very fragmented, and we knew that they had needs, and we knew, okay, yes, they need ARC to get on MAT, they need housing assistance, they need this service or that, and things were, it was hard because nobody knew who was doing what, or did they get this service, did they not, was there follow through or not. And now we have one group that's all together, all taking care of these patients as a team. And so we identify them right at the beginning and start their plan of safe care. Hopefully at that intake appointment, they're at least, the conversation is at least starting on who in this team of people within this practice, all of us kind of on this panel, who's all going to be involved, and essentially get their consent for us all to start this process with them and get their services started as soon as possible.
Great, excellent. And Maggie, can you talk about what those next steps might look like once this woman has been identified and a plan of safe care process has started?
Yeah, sure. So I'm the coordinator of the mom program at Midcoast, and I work out of the Addiction Resource Center, which you'll hear referred to as the ARC during our discussion. And we're the outpatient substance use treatment program here at Midcoast. And it made sense as we began to start talking about doing the prenatal plan of safe care at Midcoast. It made sense for those of us who are already involved in the mom program to also be involved in bringing this pilot to fruition. And so as we sat down and kind of talked about first steps, we first thought about, can Nikki at Women's Health or Katie or Sue at Maternity, can they take on the plan of safe care prenatally? Is that something they can do with their time and energy? And it was really quickly apparent that because they're pulled in so many different directions on a given day on their unit, that was going to be really difficult. So because I am kind of outside of the hospital and am able to kind of look at things from more of that coordination role, we decided that I'd be the one to kind of come and talk with a patient who needed a prenatal plan of safe care. So once Nikki flags somebody at Women's Health and has that initial conversation with that patient about, there's this person named Maggie, and she works at the Addiction Resource Center, and she's a nurse, and can she give you a call? That's kind of how the next step would go. I would give a call and set up a time to meet with this patient. And one thing that we found is that we at first were thinking, okay, well, I can come to Women's Health and meet with that patient after their, second prenatal visit or third prenatal visit, and that'll work real well. But what we found is that, life doesn't work that easily, and particularly in office settings, and particularly around times of COVID. It was just really tricky to make that time management work. And so it didn't work very well for me to try to plan to meet with them right around their prenatal visit. And so when we took a step back and reevaluated, I fell back on my experience as a visiting nurse. I've worked many years as a maternal child health visiting nurse, and I've always found the home environment as a great place to connect with patients. And so we kind of jumped on that and thought, well, why not offer that as a way to start that prenatal plan of safe care talk with patients. And we did it, and it's worked really well. And as I've made those visits, I've been in real constant communication with Nikki and with Sue and with Katie, so that they know what I'm doing, and so that when the patient comes into women's health or sees Katie on maternity, Katie and Nikki and Sue already know what we've done, and that patient really feels that, I think, and feels that team effort.
That's great. Thanks, Maggie. So within that communication, Susan and Katie, can you discuss what that next step is when mom gets closer to delivery? So she feels more educated and communicated with regarding the OCFS notification, the substance exposed infant process, and how that works within your team.
Yeah, I guess I'll go ahead, Sue. So what we currently do is schedule a visit on the maternity unit ahead of their delivery. Usually we try to aim for about 34 to 35 weeks, getting closer to delivery, so that the information is really applicable and they're really getting ready to prepare for the birth. So they come here and have generally already been introduced by Maggie. Nikki in the office sort of has already paved the way that they're going to have a visit and talk with myself on the unit and potentially Sue as well. So I specifically go over Eat, Sleep, Console with them and do admission and discharge planning and discuss what to expect for their, in this situation, nearly a week-long stay on the maternity unit with their baby. So we really dive into that. We've also had opportunities, just knowing that this group that we communicate so closely, that we've had a really great success story where a patient came to the maternity unit for a triage one evening, and the next day I had her chart on my desk saying this patient is going to need some help. And so we were able to rein her in because she hadn't gone to the office first. She had shown up on the maternity unit and was able to get connected with the mom program and have just a very wonderful outcome. So that's felt really great that there's a group that we can go to and then we can all be on the same page and collaborate.
Sue, what would you add? Anything to that?
Yeah, I don't know. Do I share my screen or am I all set? No.
You're good.
Okay. Yeah, like Katie said, I sometimes join her for the intake for a portion of it, just so the patient, mom gets to meet me. I get to introduce myself, talk a little bit about the notification that has to be made, provide some information, but it's just a chance to meet me before they're coming in for delivery, where I get more involved. And once they're here for delivery, probably the next day or so, I will meet with them, kind of pick up on the plan of safe care that Maggie's already started. So we get a copy of that and just finalize that, put in any more information, talk about other resources that haven't been discussed yet. I just do a general social work assessment just to talk about any other questions, needs, resources they might have. And then go into more detail about having to make the notification to Child Protective Services, give them some idea of what they might expect in that situation, try to answer any questions, try to ease their anxiety around that as best we can. And then when I'm done with all of that, I might see them again. It may be a one-time visit, but I then take the plan of safe care. I send it on to OCFS, and then copies of the plan of safe care go into mom's chart and the baby's chart, so it can follow them after they leave maternity, which is so important, because before we were all just doing our own individual things. So Katie and I could capture them while they were on maternity, and we could make referrals and we could provide information and connect them to resources. And then they were gone. And, we didn't know what happened after that. So the plan of safe care and this whole collaboration and the team effort is critical for making real connections to services and resources, and that there's follow through after they leave maternity.
Excellent. That's so great. The word I keep hearing is team, and how important that is. So team collaboration is super important to this process. Can you share, Nikki, a little bit about your team monthly meetings and how you develop those and how they have supported this work?
Yeah. Yep. So we meet we meet every 2 weeks to go over kind of where we're at with our patients, and because we all kind of touch them at different points. So we just meet and make sure we're all on the same page with everybody, but also meet and see where we're at with the program and the pilot, because it's a pilot. So there's been things that have worked and haven't worked. And so we've come a long way since January. And I think another great thing about the teams is that it allows us to, this is really meaningful work, right? So these moms and these families are, in the dark times of COVID, and we've all been going through so much, it really is, it makes us remember why we do what we do. And we get to just celebrate the victories of our moms going through and coming out on the other side as true success stories. And so we get to celebrate these wins as they get to each stage of their, as they're progressing through and have their babies. And so it just is nice to all meet and remember why we're doing this and tweak things as we go. And they're very, very important for this to continue to grow the way that it has in such a short amount of time. So
great. Thanks, Nikki. And I'm sure the mom can feel that too, that she knows that she has that team behind her, knowing that you all are on her side and working together. And the plan of safe care is really designed to be a collaborative conversation with the family or the mom about their strengths. And Maggie, can you speak a little bit to this focus on strengths, how that's been beneficial in supporting and connecting families? I know you have some specific examples that have really been amazing.
Yeah, happy to. I think the biggest thing about strengths is that I think so many of us as nurses and doctors and public health professionals, we're kind of trained to always look for what's wrong first, right? What we need to fix. And that's kind of where we often start our conversation. And what really struck me about the plan of safe care, in particular in the prenatal period, is that on the front page, the very first thing that you're going to ask your client that you're working on this with is, what are your strengths? And that was the whole new thing to me. And so one of my very first patients that I went out to visit with, I have a story to tell about that, because I went out to visit her. She was at home, and I was enrolling her in the mom program. And I was also explaining what the plan of safe care was and starting to get that underway. And so we came to the first section, which asks, what are your strengths? And I asked her, and she looked at me like I had 10 heads. And she said, I don't have any strengths. I just got out of jail and I'm living at home with my parents and I'm on probation. Like, I don't have any strengths. I don't know. We're going to need to move on. And I said, well, let's talk. Let's just talk and let me find out more about where you're at. And so we started to talk, and she mentioned that she had a car. And so I said, okay, well, that's a strength. You live in rural Maine and you've got a car, you're able to get yourself to and from. That's, a lot of people don't have that. So that's a strength right there. And she, kind of, she perked up a bit, and then turns out she was working over 40 hours a week as a deli manager and enjoying it and putting away money in a bank account to save for her own apartment. And so as we talked, I'm like, that's a strength right there. You've got a full-time job and you're saving money. And it turned out she had a great relationship with her probation officer, and he was vouching for her for the job and really supporting her. And so that was a strength. I mean, by the time we ended up talking, we had this whole list of strengths, and you could just see her energy shift. She went from just so defeated and kind of not wanting to be engaged in what we were doing to really energized. She had this like bright spark in her eye, and then we moved on. We moved on to what her needs were, and we went through the checklist, and it didn't feel daunting. It didn't feel overwhelming. It felt like, okay, well, these are the next steps. But knowing what her strengths were and letting her know what her strengths were was great, not only for her, but for me as the person who is helping her, because that's a new thing for providers, I think, in a lot of ways.
That's great. What an awesome experience that you were able to have with her, and really kind of change the direction of her prenatal care and her MAT care. So when we talk about the time in pregnancy, when we're creating a plan of safe care, Katie, when in pregnancy are you starting the plan of safe care and or updating it throughout your process that you've created here in your Midcoast team?
So, well, I think that's still where we're really working on trying to get ahead of the game here to improve that piece of it. So currently with our mom coordination, those patients now are getting their plan of safe care created by Maggie, and then we update it on the unit. But I am still, a good number of women using THC, for instance, needing a plan of safe care. At this point, we're creating them. It's either Sue or I, depending on who's available and who it makes sense to do that when she's actually delivering her baby. We do utilize the same idea of having an intake on the maternity unit ahead of time. The goal, again, 34 to 35 weeks. Often it ends up being maybe they're 38 weeks and they haven't delivered and they come over for a visit. And that's when we really, if they haven't already heard in the office, which most of them haven't really heard yet, that we are going to be doing this when they have their baby. And that helps them to understand that there's going to be a notification and to eliminate some of the anxiety that can come when that news, when they get that news. It's better to be able to plan ahead and be prepared for that so that they can feel more comfortable when they're here, instead of being taken aback by that when they've just delivered their baby. And also the urine toxicology that we do for their admission and meconium drug screening as well is still part of our practice. So knowing that those things are going to happen ahead of time is very helpful. And my hope is that we are able to, even ahead of that time, either I can figure out how to start the plan of safe care during their intake, or if we find a way to do it even earlier in the pregnancy, then we will be updating it instead of creating it at delivery.
Great, thanks, Katie. It really speaks to what Dr. O'Connor was saying about being honest and giving all the information up front so moms know what to expect as they move through their pregnancies and into postpartum. So I love that you're doing that. One other thing I'd like to talk about is the resources and referrals we know are the backbone of the plan of safe care and really the strengths of the plan of safe care and the mom program coordination that you've been doing. How are you able to use the mom program and the plan of safe care to identify and connect folks to resources now that you have this in place? Has this process made it easier to find and learn and support families with needs and resources? Anyone want to jump in on that? I know, Maggie, you do a lot of this, so.
Yeah, I'm happy to, but I also think, Sue, to start with, I'm a nurse and I don't have a background in case management and finding resources. So doing this felt a little daunting at the beginning. So I went and sat with Sue and at the hospital, and she just walked me through all the different kind of places where you can access information about the resources that are needed. So that was invaluable, and I would really, highly suggest finding yourself a Sue and having that connection, because there's a wheel already out there. You don't need to recreate it. People have already done it. So look for those people who've already done it. The other thing I'd say about the resources piece is that I'm learning along with the clients. And so you'll see in the film that's coming up, one of our clients, Laura, I met with her at the very early on in her pregnancy, and she needed a lot of resources. And so she and I kind of walked through the list together. And each visit I made with her, we sat and we made phone calls. And what I realized is that, you know, in the past, if somebody said, well, I need to apply for TANF or I need WIC, I would just write a phone number and hand it to them. But in this process, I've sat with the patients like Laura, and we've called, and I realize it's way more than just, you know, handing a phone number off. Yes, you can start a process with a phone call, but there's a lot more ongoing behind that phone call. And so I've learned that, and that's been invaluable to me. And I'm trying to spread the word to all the other nurses that I know out there, that it's just have patience, because the process is difficult. And it goes to show, I think, why starting the plan of safe care prenatally is so key. Because I know when I was a new parent postpartum, I mean, I could barely do my laundry or dishes for months. There's no way I could have also been searching actively for resources. So the idea of, you know, somebody getting all that done in the postpartum period seems really difficult to me. And what I found with the patients I've worked with now in the prenatal period is that they're so ready for change. They're so invigorated. They are excited. It's a great time to introduce all this. So it's a long-winded way of saying that, yes, there's great resources out there, and I've kind of enjoyed this process of learning all about them and how to access them.
That's great. Anything you'd like to add, Sue?
Yeah, I would just say once again that the plan of safe care and, you know, this team approach to providing, you know, connecting people to services and resources, you know, again, when Katie and I are working with folks previously, you know, we had them just for a brief period of time. So, you know, I don't have the ability to sit and, you know, work ongoing with them. You know, when they leave the hospital, my work, you know, is done with them. So the fact that somebody else, you know, upstream can pick up this plan of safe care, another social worker, another nurse, and, you know, continue to work on connecting them to services and resources is just critical to their success, because, you know, you can't get everything done in a few days on the unit or even 5 days on the unit. So, you know, that's just one of the great benefits to this whole plan of safe care.
Great. Thanks, Sue. Yeah, and I think one of the other pieces that I've noticed is, like Maggie was saying, as a nurse, sometimes we don't know what resources are available. It's a different role. And one of the things the Plan of Safe Care and this team approach has really connected the more medical folks to the social services and have a better understanding of what resources are available in the state, instead of feeling like there's nothing. There really is a lot of resources, but just how do we connect families to them? And working with our team approach, your team approach that you have here has really been able to do that. So one last question for you until we move into the questions from the folks in the audience. The Maine Mom program and the Plan of Safe Care are very integrated, and just wondering how that has benefited this process and the coordination of folks' MAT and that prenatal care. What has that been like? That care coordination.
I can go or Nikki, did you want to say something?
You can go if you want to.
Well, I was going to say that that one thing that I want to just put out there, and will say over and over again, is that if you have a woman sign up for the mom program, if you get them enrolled in the mom program, they, just by doing that, they check off 7 items on the plan of safe care right there. Like, there are 7 things that they have taken care of by enrolling. So it's just a great connection between the two. And it certainly has helped me as the coordinator of the mom program to enroll clients who also had to do a plan of safe care, knowing that by enrolling in what we had to offer at mom, they would cross off several to-dos on their plan of safe care.
Yeah.
Anything you want to add, Nikki, to that?
Yeah, I agree with that. Any of our drug addicted moms, I always try to get them to get involved in the mom group, even if they're been long standing patients who get their MAT from another provider. I'm always trying to get them to become part of the mom group because of what Maggie said. It's the networking, it's the wraparound care, it's everything that the mom group is, which is so much more than just getting a prescription from a provider that they've been getting forever. And we've had some that have done that, and they are very appreciative and grateful that we, push them into that. So she's right, it does check off a lot of boxes when you do that. And just to go back to the resources thing real quick that we have, as a nurse, like you said, I always felt like I didn't know what the resources were or had trouble accessing them. And so like as a group and as a team, we also are like, our plan is to put everything on like a drive that we all access. So like as they change, which they do all the time, we're all kind of going to go in and keep it updated so that like if you have a patient with like housing in this town, you know where to go, or so that's like another goal of our group. So
excellent.
Yeah.
Great. Thank you so much, Nikki. Anything else anyone would like to add to give advice or thoughts to other hospital systems or other women's health offices that are looking to do this? What is a big takeaway for you as other offices and labor and delivery units and pediatrics look to connect with the plan of safe care?
I think that a really big takeaway from our team is that we have a person representing from each of those areas is involved in this. So I think that is key. And I know that we're a community hospital. We're not a very large labor and delivery unit, but I feel very grateful for our unit that sort of serendipitously before mom was really rolling out, I had joined in this position to specifically try to coordinate with the higher needs patients that were coming from the office to deliver on the unit. And I would say that if anybody has any bandwidth to have something similar on their units, and not everybody has a designated social worker, and Sue is not a designated maternity social worker. She is extremely busy with the rest of the hospital, and we are very, very lucky that we can get her when we need her for our really high needs patients. But so I would say that that is key, that there's representation from we have a pediatrician, we have a midwife, we have a physician, and then all of us in our different areas. So
great. Thank you so much, Katie, and thank you to everyone. This has been extremely informative and super helpful for those listening about the amazing work that you've been doing collaborating. I am happy to bring back Bobby and Elaine and Dara and anyone else who would like to address some of the questions that we have in the chat. Let's see. I'm going to go right as far back as we can. So this is a great question for you, Elaine. What if a prenatal mom on MAT is at a hospital without Maine Mom? What can they do?
Yeah, so great question. As I mentioned, this first year, it's just in very specific care delivery partners. I think we're really trying to educate folks across the state. We have many people that are coming to our ECHO series and to the clinical office hours. So I think you're seeing Maine Mom type delivery services in other settings. And so I think it's really sort of available in many more locations than are sort of official sites right now. So I'd encourage them to talk, certainly could consider looking for a different practice this year if they wish to, but I think there are a lot of other places that are delivering these services in somewhat modified format right now, but there'll be a Maine Mom site really next year.
Great, thank you so much. And along those same lines, if a relapse occurs, is there a way that this is addressed as a team or at your practice?
Yeah, definitely. I mean, I think there's, yes, for sure. I mean, I think, I was working with a woman the other day that had a significant return to use, and she was really struggling. She was emotionally struggling, and, was able to really identify that it wasn't, ongoing, cravings every day, but really this one trigger. And so, I got her connected with our substance use counselor so she can kind of work on, how am I going to respond to triggers that might occur in the future? And then she really wanted to be connected to a peer support person. Again, that's somebody that she could call maybe in the moment when she's recognizing things aren't going very well. And so she can get the support services that she needed. So she didn't need much from me in terms of medication. She just really needed to be connected to the right resources on the team.
Great, thank you so much. And I'll ask Bobby to address this next one. Has there been a discussion at the state level about being able to support substance use prenatally so the family assessment can be done in the prenatal period? Having the first DHHS meeting in the hospital during the immediate postpartum is very stressful for the new family. So what can we do to help that?
Thank you, Ashley. That's a great question. And it is something that we've talked about multiple times. I had the opportunity to be part of some of this work in Bangor. And so part of it is about the mandate for child welfare services. And we don't have, a report's not considered, appropriate for assignment, but to child welfare services until we have a child that's been born. And that's based on law and statute. What we have done though, and I started to reference my experience in Bangor, was that I was able to be brought into a team that was working with a mom at one point. And I came to the table, I explained the process. We talked about, the risk factors, and we talked about all of the different things that she was considering doing. And I never received a report on that mom following that. I actually followed up with the hospital and I was like, did she deliver? Like, what happened? Because she was able to take steps that made the outcome really successful for her and her baby. And so I agree, there's a lot of value in that. And I think even if we can't have a report, there's ways that we can come to the table in a consultative role that can help benefit families.
Great, thank you so much, Bobby. That's an important thing to note, and that's kind of the direction that Liz Remillard, the program manager for Maine Mom, and I have been really looking at is how can we get moms educated earlier on around the substance exposed infant notification, and so there's more understanding about that, so we can get the plan of safe care in place, so there'll be less intervention later when the infant is born, and we're going to hear a really great story about how that worked really well in our recovery story coming up. And I was really excited to see someone mention in the chat referring to the Maine Mom services through the cradleme.org process. That's definitely a way you could do that. You can also use the Cradle Me forms prenatally to get a mom connected to a public health nurse so they can help create a plan of safe care with someone who has a lot of needs and needs to be connected to resources and referrals. So that is an excellent way to do that. So thank you for putting that into the chat. One other question I just want to address, and then we'll move on to our recovery story, was does the plan of safe care either become part of the medical record, entered digitally or scanned? This is really dependent on the practice and the hospital. Everybody has different regulations around this, and different hospitals are doing this different ways. So I encourage folks to talk to their hospital, their organization around how that will work. And the workflows are a little bit different clinically at each of the different sites that are implementing a plan of safe care or the mom program. So I'll add that in there. And I think that is all we have time for right now. But I really, really appreciate the folks from Midcoast joining us today, Maggie and Sue and Nikki and Katie. And thank you again to Bobby Johnson and Dr. O'Connor. This has just been a wonderful opportunity to talk about the great work that you all have been doing, the collaboration through the Maine Mom program and through Plan of Safe Care, and the changes of women's lives that you've been making. So thank you so, so much. And I'm going to hand it over to Dara so she can introduce the recovery story about a client that Maggie and this team had. So we're really excited to share that with you. So thanks so much.
Thank you so much, Ashley. And also, I just want to extend my thanks to everybody else as well. This was a fantastic conversation and a great panel. Excuse me. So in just a few minutes, as Ashley mentioned, we'll be sharing a short film profiling Maggie Jansen, who is present on our panel this morning, and Laura, one of Maggie's clients. Maggie first met Laura outside a garden shed where Laura was living without electricity, heat, plumbing, or running water. They spent 2 hours sitting at a picnic table outside that shed during their first visit. And Maggie truly extended a heartfelt stance of respect and non-judgment towards Laura. Laura had been sort of a, kind of tentative client. She wasn't sure whether she wanted to engage in this process. And because Maggie went to her home where she was living and sat and basically said, I want to know what's going on with you. I care. They were able to create a prenatal plan of safe care that afternoon. And since then, Laura has partnered prenatally with everyone who we met on the panel this morning. She's changed her life. She brought her newborn baby home, and she's now living in a 1-bedroom apartment, secure there for at least the next year. So please stay tuned. Maggie and Laura's film will come up in just a few moments. So thank you again.
I'm Maggie Jansen. I am an RN, and my job here at Midcoast is I'm the program coordinator of the MOM program at Midcoast.
I'm Laura, and this is Ryan, and we are participant clients. I found out I was pregnant, and I had been living in like this one-room shack, and I couldn't bring up a child in that, so I pretty much just decided that this wasn't a good place to raise a kid, and just tried to do everything I could to get out of there and to try to make sure that I had the right opportunities and right stuff to raise Ryan. I pretty much started to get into drugs when I was around 22. And I was into them for a really long time, and then I stopped. Before I came to ARC, I stopped on my own, but I still needed, that extra help to try to, keep it the way. Try to keep me more stable and more thinking clearly, and to actually talk with other moms that have been going through the same thing that I have. And so yeah, I've stopped probably when I was like 28, 29. So it's been good going from there. Right.
Laura, when she was at Women's Health, she disclosed to the nurse there that she was really in some need of some pretty big resources. And so the first day that Laura and I met, I actually brought out the plan of safe care, and we looked at it, and on one part of the plan of safe care, there's a checklist. And we went through that checklist and kind of came up with the various resources she was in need of. And then from there, Laura and I really worked as a team. She was so invested and really kept me on task a lot of times, particularly with housing, and we really worked closely on that together.
It means a lot to me to be a parent. It's just been a really long road to get where I am right now, and to be in this program has helped me tremendously. Yeah, he means the world to me.
I say it's an invisible disability. I think teachers and people that work with our kids, they need to know what they're dealing with. Parents, guardians, foster parents, look for their strengths. Christian is just, they said, him fantastic in art, music, gym. Oh my gosh. He did an art project where the teacher put a cake and a piece of it had been eaten and it had a candle flickering. It's like the teacher said, it was like he could reach in and piece out a piece of the cake and eat it. He could see the inside of the cake. And he said he is the only, everyone else couldn't do it. And this is something they do at the middle school and high school level, this type of drawing. So he was just blown away. And the other art teacher said, he's gifted in it. Reading, math, those are struggles for him. He's behind. Christian sings to himself all the time. He'll sing, he did his multiplication tables by singing to himself. He put it to a beat and he made a rap song about it. And when it came test time, he aced it. He made 100%. And I told this to his aide. If you could teach him to read by music and set it to some music and have some words like to music and stuff, you'd do really well. So she got with the music teacher, and when they were reading the story, she put it to a beat because she likes that type of stuff. And so Christian's level on reading shut up like, woo, wow. So you have to think outside the box with him.
I was diagnosed in 8th grade. So pretty much all my life I've been living with it. And then I go to the doctors or a specialist and she takes one look at me and she says, you got FASD and you're on the high functioning autism spectrum. I was like, all right, I guess that, answers a whole bunch of questions of why I've been acting the way I act. But I mean, it's nothing new when I heard that. I was just living.
I think it's important for people to see the reality of FASD, but I don't want people to get the impression that because of his disabilities that we should be controlling it more and that we are in control of him. And what they don't realize is they don't get the complexities, they don't get the inconsistencies. Like Josh is consistently inconsistent. Like you don't know what you're going to get from one moment to the next.
I remember the first day I lost my other job and I came home, my sister looked at me funny and I lost it. I ended up taking her to the ground and my mom was on me. And I think they did kick me out the house for the one night.
As a young kid, you don't really understand it. Like I was told that he had these things, but I didn't really understand how that impacted the way he behaves or like the way he works at school or at like a job.
When I was younger, I've had thoughts of like ending it or ending life. And I said to myself, the only reason why I'm still here is because of my sister. And my sister's going to need me.
He sees that things are easier for me than they were for him, and he wants me to take that and run with it. And I think it's really motivational.
Ever since I moved out, like my sister wanted to spend my birthday with me. And in hindsight, it didn't mean much, but as I think about it and all the obstacles we've overcome and what I just did to her, that meant a lot. Just take one day at a time. I mean, like I said, it's easier said than done. But my parents have gone through so much with me. Like speeding tickets and having to call them up and say, oh yeah, just got arrested, and having them be disappointed in me. But those are called bumps in the road, and we get over them and we move on to the next day and just don't ever give up.
I grew up at the intersections of two identities. First, as a gay transgender man, and second,
as someone who lives with an invisible disability called fetal alcohol syndrome. Because my birth mother drank while she was pregnant with me, it caused my brain to develop differently. When I was adopted as an infant, the doctors told my parents they didn't think I would walk or talk. Boy, did I prove them wrong.
One of the biggest things about FAS is it's an invisible disability, and that not only are there, well, there are physical characteristics, but when people look at me, they don't go, oh, he's obviously disabled.
I was given this gift of being like raising Sam, and like what a unique experience that was. And like, who gets to say as a sibling that they got to be a part of that?
When he has a decision to make, there's certainly the decision I would like him to make as an adult, but I have to be really careful to not influence that and really let it be his. Like, let's examine everything equally. It would be a hell of a lot easier in my life if I just told him what to do and he would do it.
Agreed.
But then you wouldn't learn for your future.
It's true. I've come into her room multiple times and I just say, Mom, something happened. I need you to tell me what to do. She's like, I'll give you advice. I'm not going to tell you what to do. I'm like, can't you just do it this one time?
I got a very unique upbringing. I am a nanny now, and I have been for 10 years. And I always say in all my interviews, I was born a mommy, but it like totally escalated when Sam came, into the family. And that's where I always say my love for like children and childcare started. The doctors told us he wasn't going to walk or talk. He's a 3rd-degree black belt. He's come crazy far. And I'm just so proud of him and us and everybody that had a part in it. I didn't do it. My mom didn't do it. He did it, right? But the therapists and the speech therapists and the food therapists and the physical therapist and we all did it, right? Like, it was this huge group of people that got him to where he is.
There are people who look in and call me things like protective, helicopter parent, all of those things. But look, this child is not suffering because of how involved I have been in his world. He is thriving because of how involved I have been in his world.
A few years ago, I heard some folks talking about FAS saying it was a trash can diagnosis because there are so many different things that get thrown into it and it affects everyone so differently. Well, I'm here to say that I'm not a trash can. If anything, I'm a recycling bin. Because I'm going to take these hardships I've faced with this invisible disability and turn it into something good for this world.
My goal, as long as I live and breathe, is to make people more aware of this. That they're born with a disability, but don't let that disability hinder them from being who they can potentially become.
We had no idea when he was 3 where we would be when he was 20. God, he's 20. That's the craziest thing, Like, we had no idea where he would be at.
I know there's people that look at my kid and they just think he's bad, like rotten to the core, and he's not. He's got a really good soul.
For someone to understand it, I think they will have to have a day with the person.
I want people to know him for who he is and not for what he has, because I feel like any person really should be known for who they are, not what they have.
Well, good afternoon. Welcome back from your lunch break. I hope everybody enjoyed getting a second shot at watching the video. I know I did. So I am really excited to be able to introduce our next presentation. So I am Marianne Heracall. I'm the Maternal and Child Health Program Director, and I oversee the Children with Special Healthcare Needs team as well, which you guys will get a chance to meet in just a moment here. We're going to be talking about newborn screening. And so with that, I am going to go ahead and share my screen. And our first presenter is going to be Jody Philippon. One moment while I get this up for you. And Jody is our newborn screening nurse for the newborn screening program. And Jody, while I get this going, you can go ahead and introduce yourself.
Thank you, Marianne. So as Marianne said, I am the newborn blood spot screening and follow-up nurse, a job I am absolutely passionate about. And I'm so excited to be here with you today to share a little bit of knowledge. And I also wanted to point out what a wonderfully put together conference this has been. I have thoroughly enjoyed all of the presentations and feel incredibly proud to be among such a wonderful group of professionals. Having said that, I'll start the presentation with talking about why we do what we do and what is newborn blood spot screening. Next slide, please. Next slide, please. So, what is newborn blood spot screening? Newborn blood spot screening is a testing process in which blood spots are obtained from an infant's heel via a single heel stick before the baby leaves the hospital. This is typically done within 24 to 48 hours. And it is very, very important because this sample of blood that is extracted from a baby's heel is applied to a special filter paper. That's what we call the blood spot filter paper. It has 4 circles that are used to detect markers. And these are an array of biological markers that detect a number of different disorders. In the state of Maine, we are very, very blessed and fortunate that our blood spot screening can detect up to 33 primary and 22 secondary conditions. Now, it's important to note that some of these conditions can be life-threatening. Many others can lead to lifelong disability and impairment. So it's critical that we catch this stuff early, hence the need to have the blood spot taken between 24 and 48 hours of life. Now, I do want to point out to you that the newborn blood spot screening is not diagnostic in and of itself. What it does do is it indicates a level of risk, and that is what indicates the next steps for this baby or babies who present with a biomarker or other result that is not in line with what is considered to be within normal limits. So essentially, and as I said earlier, I'm very passionate about this because it saves lives. This screening we have in place is so incredibly effective and so efficient at catching these things that babies who may have died now go on to live successful lives, and they have a wonderfully productive experience. It also prevents, as I said earlier, lifelong disability and impairment. And ultimately, our goal with the newborn blood spot screening program is to promote the most healthiest environment in which we can for our most vulnerable citizens, our newborns. Next slide, please. So having talked a little bit about the newborn blood spot screening process and how the specimen is collected, the next logical thing I thought would be to talk about, well, okay, we know the testing is out there, but how does this impact our babies in Maine, and what happens with that information? So I'm going to use in this particular slide 2020 as an example. In that year, approximately 11,000 babies were born in the state of Maine. Of those, over 99% had a newborn blood spot screening filter paper collected. Of those, there were 550 babies who were identified as having had an increased risk for developing one of the screened conditions. With further follow-up and testing, it was determined that 36 out of these 550 babies were actually diagnosed with one of the 55 conditions I spoke of earlier. Now, with that condition, the most common was congenital hypothyroidism, with 23 infants treated and diagnosed quickly. Now, most of us are probably familiar with congenital hypothyroidism, and you may know somebody who was treated or somebody who is currently taking thyroid medication. However, in an infant, it's a lot more dangerous. There's a lot more at stake. These babies who are not diagnosed and treated quickly, they can have intellectual disabilities, they can have developmental delays, and some can even pass away. So it's very important to note that yes, this condition was the most common, and it's also one that needs to be addressed quickly. Next slide, please. So let's take a little bit of time to look at the number of cases overall. I worked with a colleague, Amy Fair, who helped me put together this graph of information. And what you're seeing here shows a representation from 2017 to 2020. And it shows the number of cases per year that were diagnosed. And this isn't just the hypothyroidism, this is of all the cases that were confirmed. So as you can see, in 2017, we had 27 cases diagnosed. And this level, interestingly, stayed pretty consistent through the years of 2017, 18, and 19, with 2018 having 26 confirmed cases, 19 had 28. And then, interestingly enough, in 2020, we had 38 confirmed cases. We're not sure of the reason in this sudden spike or uptick. That is something that we continue to monitor and record. Interestingly, of that, we were talking about congenital hypothyroidism. There were 12 cases each in 2017, 18, 10 respectively in 2019, and in 2020, we had 23 cases. Again, we're not sure on the uptick on that. We are researching it. We're still trying to collect data. Next slide, please. So talking about the 2020 impact on infants continued. I wanted to try in this presentation to put it in real numbers, in real perspective, so that those of you who are listening today could have an understanding of what is actually involved and not just generic, here's what we do. So for an example, in 2020, we had 4 different babies who had been diagnosed with sickle cell disease and were placed on prophylactic therapy to include penicillin, and they were also referred and established with our specialty providers at hematology, also known as the Maine Cancer Children's Program. And all of this is very important because it minimizes devastation of the disease, it minimizes the risk of septicemia, and it promotes well-being. Now, of these babies, there were 4 in 1 year. And prior to that, this was not something the newborn screening program had seen. There might be 1 baby every few years, et cetera, but it was certainly not 4 babies. And what we think that is attributed to is a sudden influx of folks coming in from other parts of the world that may explain the uptick, but again, we don't know that definitively. Of that same year, we had 5 babies who were diagnosed with metabolic disorders that, again, could have resulted in lifelong impairment and disability had they not received timely treatment. And I want to take a minute to talk about those 5 because 5 may not seem like a lot, but 1 is way too many. So of the 5 babies, we had 3 who had what we call phenylketonuria, also known as PKU. This is a condition in which the phenylalanine levels in the blood accumulate. because this is an amino acid and they're not able to break this down properly. This can result in brain impairment, intellectual disabilities, growth restriction, and all kinds of other problems. So we were able to catch that. The other two conditions, interestingly, were galactosemia. Now, galactosemia has two different types. There is the classic form, and then there's the Duarte form. And the Duarte is it's more of a benign condition, whereas the classic galactosemia presents much more seriously with a much greater increase of health risk. With galactosemia, basically, it's a rare hereditary disorder in which the carbohydrate metabolism is affected. So essentially, the body can't break down galactose into glucose. So the galactose accumulates. So interestingly enough, those were the 5 cases that we dealt with, and some of the ways we were able to get babies treated timely. Next slide. This is another graph. I love to put things in visual perspective. It helps me to see things and better explain. So this is another perspective of the diagnosed conditions. Again, the range being from 2017 to 2020. And as you can see, the different conditions that were identified runs along the horizontal axis of the graph. The number of cases runs along the vertical portion of the graph. And you can see very clearly the CH, or congenital hypothyroidism. You could see where that spiked in 2020. There were some spikes, mild spikes from one year to the next. However, I was really surprised in that most of the conditions did not have a great deal of variation from that 4-year period. Next slide, please. Okay, so there has been an overall increase in both congenital hypothyroidism and cystic fibrosis across that 4-year period of 2017 to 2020. Again, we're not sure on the causation of that. We are doing research, and when that becomes available, we'll be happy to share that. I spoke of sickle cell disease quadrupling from 2017 to 2020. And this is a side note, and I just think it's interesting, but babies who are born at either a birthing center or a hospital are far more likely to have had a newborn screen completed and to have follow-up care should they have an out-of-range result needing a repeat filter paper. Next slide, please. So having said all of this, how do we protect our babies? How do we go about making sure our babies have the safest, most accurate, timely medical care we can give them, at least regarding the newborn blood spot screening piece? The first thing we need to do is education. We need to educate our stakeholders. That means we educate PCPs, primary care providers. We become educated by collaboration with our specialty providers, our genetics clinics, our laboratory that we use to screen our lab results, the medical community near and far, the general public. We want to educate people on why newborn screening is important and what it involves, and how does one go ahead and get this done. And we do that through a wonderfully drafted and completed brochure that we send out to all kinds of providers. It outlines the process, it lists the conditions. It's basically a great FAQ, frequently asked questions brochure. So that's one of the big things that is very, very important in what we do. The second thing is keep up to date on knowledge. We keep abreast of new developments in the way of screening, treatments, and interventions for conditions that impact newborns. So it's not just enough to educate the public and our stakeholders, but we ourselves at the Maine CDC and all of those of us who work for the Maine CDC take great strides to make sure that we're not just giving information, but we're giving accurate and up-to-date and accurate and up-to-date information. The third thing, and this is a little more difficult, and I'm going to speak about this in a little bit, is we add new conditions as appropriate. And then the last thing, and certainly not least, and this is where my role as a follow-up nurse comes in, is we provide expedient and accurate notification. When a baby has an out-of-range result, and I get called out by the lab that, a certain baby has maybe one result that's out of range, maybe 3 or 4 things that are out of range, whatever that may be, it's up to me to make sure I take that information, I act expediently, I contact the PCPs, I contact the NICUs, I contact the specialty providers, whomever is involved in this chain of care, and make sure they have accurate information and they know what to do with it. So once that's done, my follow-up piece comes in with just that. You follow up. Did this get done? Did a repeat get done? Was this baby diagnosed? Was this baby seen timely? And that's all very, very important, because having a newborn blood spot screening program without having any follow-up would be fruitless, and it would defeat the whole purpose of why we do what we do. So next slide, please. So I spoke earlier about adding new conditions to the panel. So before we can even consider adding a condition, and I just want to back up for just a second. I have heard people say to me, well, why can't this condition be added? And well, if you're going to add this, why don't you add this, this, and this? And why does it take so long? I have been present when parents have provided heartbreaking testimony of how their newborn died because there was a genetic disorder that wasn't picked up on the screening, how their baby, is impacted because their screening wasn't picked up or it wasn't offered on the screening. And my answer to that is always, it's a process. And it's not a quick and easy process. So the first thing we have to talk about is the criteria. In order for a condition to even be considered, you need to show that the screening is needed to identify all newborns who might need treatment. You need to show that not only can we screen for this condition, but we have a way to treat it. We don't want to just screen for something that we can't do anything about. We have to show that without this screening, there's a significant risk of illness, death, or disability if it's not screened and treated early. We have to show that the treatment is most beneficial in that newborn period. We have to show that there's access to treatment, counseling, and resources. Again, can't just put on a condition without having the wherewithal to support these families and having treatment options available. We have to show that the benefits to babies and society far outweigh the cost of screening and treatment. So that's all of that criteria has to be met before anything else happens. So in Maine in particular, we have a two-pronged approach to this process continued. So assuming everything is met in the criteria process, then the next thing we do is we take advice and consultation from the Federal Advisory Committee, Department of Health and Human Services Advisory Committee on Heritable Disorders in Newborn Children. So essentially, we get our information from the feds. What are they recommending? What are they showing to be treatments, and what are they, we consult with them so that we're not just going off on our own independently. We do get guidance from the federal government regarding all of the 6 things that I spoke of earlier. And the second pronged approach to this is, in Maine, we have a Maine State Advisory Committee. This is called the Joint Advisory Committee, or JAC. We meet biannually. We meet with all of our stakeholders to include specialty providers in the way of endocrinologist, pulmonologist, immunologist, hematology, and the like. We also have family members who sit on this. We have genetic specialists. We have a geneticist who sits on the committee. And what we do is we meet and we talk about what are the recommendations from the Federal Advisory Committee. What direction do we want to go? What resources do we have to bring to the table to bring this thing to fruition? So we do that. And then once that is approved, then the work just gets started. Next slide, please. So once we've done the pieces I just spoke about, this is where we get into the down and dirty and we really dig our heels in and get stuff done. Number one, we have to have a work group of experts. We can't just on a wing and a prayer throw this together. We have to have a working group of experts where there's a lot of collaboration, a lot of discussion that is held. We have to have a system of responding to these situations, these conditions. Again, we can't just have a condition and not know how we're going to address them. We need to identify those providers in the state of Maine who can provide care for these children who may come up with this condition, that condition, whatever the proposed condition we are working with. We have to show that Maine has the ability to treat these babies. Again, we educate. I spoke of that earlier. We educate primary care providers because many of these disorders, they're not seen all the time. They might be seen 1 in every 11,000 births. It might be even, there might be even a higher ratio. So we have to educate our providers on that. We have to establish follow-up recommendations and define the screening criteria. So that's where I come in. If we're going to add a new condition, I have to know what to tell people. We have to know what guidance and direction we need them to go in to promote the health and well-being of this baby. We need to provide resources to people, questions and answers, brochures, frequently asked question sheets, things like this, so they can be educated again on what is this condition? What does it look like? What needs to be done? What are the testing that is needed? And then finally, and I shouldn't say finally because it is a comprehensive process, but we have to have all of this approved by our legislature. So if we don't have legislature approval, we cannot move forward. So it's, as you can see, it's quite an intense, involved process, one of which I'm very proud to have been among in the last 3 years. So once we get the conditions added, what happens next? Well, we save babies. I mean, that is our bottom line with any of this. We save our babies. We continue to monitor. We're not done because we've added a condition. Our work is just beginning. We look for signs of where can we improve? What did we learn from this? What do we need to change? What are some updates? Because the medical field, it's constant change, constant updates. And then we keep continuing to promote awareness to our public. Next slide, please. So the new conditions we have 4 of them that were added on April 1st of this year. The first condition is X-linked adrenoleukodystrophy, otherwise known as XALD. This is a condition that affects the white matter of the brain, the nervous system, and adrenal cortex. It has a myriad of symptoms across many organ systems. This mainly affects males. Females can be carriers, and occasionally a female can have the condition, but it is very rare. Treatment for this particular disorder includes a hematopoietic stem cell transplant, gene therapies, and symptom management. The next condition is mucopolysaccharidosis type 1, MPS 1, that is known as. This again is an inherited progressive disorder. It's again multisystematic. It has a wide range of severity. Symptoms of this include things like frequent urinary tract infections, frequent upper respiratory infections, skeletal abnormalities may also manifest with this. Treatment again is symptom management, enzyme replacement therapy, gene therapies, and the stem cell transplant. The third condition is spinal muscular atrophy. SMA also is what this is known as. And this is the most common. This occurs in approximately 1 in 11,000 births. In this particular condition, a critical gene is missing, and that provides a very necessary protein involved in nerve function that controls muscle activity. This is very progressive and often can be fatal. So the treatment here is a gene therapy. And last is, but certainly not least, is Pompe disease, otherwise known as Pompe. This has an early and late onset presentation. It does have varying progression. Symptoms include generalized muscle weakness, cardiac hypertrophy, respiratory issues, and failure to thrive. Again, the treatments are pretty consistent across the board. And in this case, it's no different. They're looking at enzyme replacement therapies for these children. Now, interestingly to note, we've had one confirmed case of late onset Pompe and one of XALD since April 1st. Next slide, please. So together, we make a difference. By together, I mean our legislatures, our elected officials, our medical community, our direct care providers, our PCPs, our specialists, and those of us who work in the newborn screening program. So together, we make a difference. I appreciate your time today. Any questions, my understanding is will be handled via the chat, and I'll be happy to answer those to the best of my ability. And again, I thank you so much for having me today.
Thank you, Jody. For those of you who have not really been introduced to the blood spot program at the CDC, I think Jody did a fantastic job giving you a really high level overview of that. And as Jody said, you guys are feel free to ask questions in the chat. We had one that I was able to easily answer, but for anything a little more complicated, I'll do all the questions at the end. But go ahead and throw them in the chat for us, and we'd be happy to answer them for you. So next up, we have Ann Banger from the Newborn Hearing Program. Ann?
Okay, the first thing to do is unmute and then start talking. Thanks, Marianne. I really appreciate the opportunity to give a brief overview of the Maine Newborn Hearing Program, sometimes referred to as MNHP or Maine's EDDI program. Next slide, please. Some important facts about hearing loss. Hearing loss occurs more frequently than any other birth disorder, more than twice as often as cleft lip and palate, and almost 3 times as often as Down syndrome. Hearing loss occurs in approximately 3 out of every 1,000 births. The vast majority of those babies are born to hearing families, which was the case for my family. My son was born with bilateral profound sensory neural hearing loss that wasn't identified until he was 18 months old. Undetected hearing loss can have serious negative consequences, including delayed development in language, learning, and speech. Access to language is critical to an infant's social, emotional, and cognitive development. So for these reasons, every state and territory in the United States established early hearing detection and intervention programs, or EDDI for short. The Maine Newborn Hearing Program is Maine's EDDI program. EDDI refers to the practice of identifying infants who are deaf or hard of hearing to ensure that appropriate services are made available to them and their family. The Maine Newborn Hearing Program was established by law in 2000. Next slide, please. The main goals of all EDDI programs, including Maine's EDDI program, are commonly referred to as 1, 3, 6. screen for hearing loss by 1 month of age, diagnose hearing loss with an audiology evaluation by 3 months of age, and enroll those diagnosed with hearing loss in early intervention by 6 months of age. In addition to 136, the program works to identify infants at risk for hearing loss by identifying and providing guidance on hearing loss risk factor and appropriate testing guidelines. We also want to ensure that those identified as deaf or hard of hearing have a medical home, which means they have primary care that's patient-centered, comprehensive, team-based, coordinated, and accessible. The Maine Newborn Hearing Program maintains a tracking and surveillance database to improve follow-up outcomes and monitor program quality, reducing loss to follow-up after failure to pass the newborn hearing screen. All babies that are born in Maine and receive a birth certificate have a unique record in this database. All newborn hearing screen data and audiology reports are submitted electronically to the database by the 25 birth hospitals and Maine audiologists, and then linked up to the child's unique record. Next slide, please. So now I'm going to talk about the newborn hearing screening process in Maine. Here's a picture of a baby getting their newborn hearing screen in a Maine birth hospital. All hospitals in Maine use auditory brainstem response, or ABR screening. It's an objective measure that doesn't require a behavioral response from the infant. Baby sleeps, only takes a few minutes. Both ears are tested at the same time. Clicks are played through soft earphones on the baby's ears, and the hearing nerve and brain responses are measured by the testing apparatus. The newborn hearing screen is typically completed prior to discharge at birth. The results of the newborn hearing screen fall into 3 categories. First one is pass, which means baby's hearing was normal at the time of screening and no further testing is necessary, but you always need to monitor baby's hearing. This is just a snapshot in time. A refer result is when one or both ears receive a refer result. It doesn't mean the child has hearing loss. It just means that they will be referred on for audiology testing, the 3-month goal. This appointment will be scheduled preferably before they leave the hospital. The third result is pass with risk factors. They pass the hearing screen, but have risk factors for hearing loss. So they should follow the risk factor audiology testing guidelines for their risk factors. Next slide, please. Second goal, 3 months, the 3 goal. Those babies that I mentioned before that referred on their newborn hearing screen or didn't pass their newborn hearing screen need further testing to check their hearing. The birth hospital, a screening facility, will schedule what's called a full audiological diagnostic evaluation. That's a big mouthful for baby with a category A audiologist. They also notify the Maine Newborn Hearing Program and the baby's primary care provider. So the primary care provider and the program can track the process and support the family. This testing doesn't hurt, baby sleeps, but the appointment does take a couple of hours, and it may take multiple appointments to get the complete results. Again, the goal is to complete this process by 3 months of age. Next slide, please. The final step in the process is the 6th goal. For those that are diagnosed as deaf or hard of hearing, it's to refer to and enroll in early intervention by 6 months of age. The Maine Newborn Hearing Program refers to EI, or early intervention, as soon as we receive a deaf or hard of hearing diagnosis from the audiologist. And audiologists submit their reports typically on the day that the testing was done or within a week of the testing to our database. In Maine, referrals to EI can happen from birth to 3 years old. We can even refer those with suspected hearing loss. The Maine EI program is Child Development Services, or commonly known as CDS. When they receive a referral on a child that's deaf or hard of hearing, they immediately involve the Maine Educational Center for the Deaf and Hard of Hearing, or MECDHH, their Early Childhood and Family Services, or ECFS, Early Intervention Specialists for Deaf and Hard of Hearing children. They're included in the team to work with this child and this family as soon as the diagnosis is made. Next slide, please. So this is some interesting data. It includes newborn hearing screen data and what we call follow-up, or the audiology testing piece of it. As you can see from this table, about 98% of babies born in Maine have a newborn hearing screen. We're never going to have a 100% screening rate because we count children that pass away, children that are transferred to hospitals out of state. So there are many, or they're medically unable to be screened. Families also sometimes refuse. Approximately 2%, the third line down, those are the number of babies on this. Approximately 2% of the babies that are screened every year refer on the newborn hearing screen and are scheduled to go on for that additional diagnostic training, or that 3-month goal. Of those 2% that are referred on for additional testing, you can see on the line, 1, 2, 3, fourth line down, the completed audiology testing. Those are the number of babies that went on and completed that audiology diagnostic process, the 3-month goal. It varies from year to year. Unfortunately, it's not all the babies that were referred. On this, the percentages in 2017, about 78% of those that were referred did complete the testing, 69% in 2018, and 76% in 2019. They completed the diagnostic testing and were either had normal hearing or were diagnosed as deaf or hard of hearing. So that means that a large percentage of those babies did not have the testing, and that's the 5th line down, the no audiology testing. The bottom line, diagnosed with hearing loss, is the number of babies in those 3 years that were diagnosed as deaf or hard of hearing. We continue to work on ways to increase the number of babies that complete the audiology testing. So that's really important, and we do track every single baby. Next slide, please. So how can you help? Ask for the results of the newborn hearing screening. Was it a pass? Was it a refer? Do they have risk factors? If they were a refer, or they have risk factors, did they go on for audiology testing? If they were scheduled, look for the report, not just a note that yes, they were scheduled. Look for the report, and what does the report say? What are the recommendations? Monitor the child's hearing and speech as they grow. You can find in one of our brochures, there are milestones that you can use to check your child's hearing and speech as they grow. And bring any concern to your child's primary care provider, or I don't have that on here, call me. Call the newborn hearing program or email the newborn hearing program. The phone number at the end is my direct line, and I'm more than happy to talk to anybody. These guys would tell you I'll talk your ears off about it. Next slide, please. So this is resources. The top one is our homepage. The second one down, Hearing in Infants and Young Children, is a booklet that's given to all families. when the baby is born. And in there are tips for monitoring your baby's hearing and speech as they grow. The third one down, risk factors for hearing loss and testing recommendations. That's what has a list of risk factors for hearing loss, and also when what the protocol is for audiology testing for those. The next one down is the category A audiology facility listing. I had mentioned those when I talked about audiology diagnostic testing. Those are the facilities that can perform the appropriate diagnostic audiology testing on infants to 6 months. And the last one on there is something I haven't mentioned yet. This is cytomegalovirus, or CMV. It's a common virus that infects people of all ages. Over half of adults by age 40 have been infected with CMV. Most people infected with CMV show no signs or symptoms. About 1 out of every 200 babies is born with congenital CMV. And about 1 in 5 of those babies born with congenital CMV will have long-term health problems such as hearing loss. CMV is a whole nother topic. On the website, there are flyers with information about prevention and a lot more information about CMV. Next slide, please. So for me, that was extremely brief because I could go on for forever about this. So here's my contact information. And if you have any questions, throw them in the chat, or you can give me a call or shoot me an email. Thanks.
Great. Thank you, Anne. Cute pictures of those babies. I love it. So our next speaker is Anna Sear. She is our Maine birth defects coordinator. And before Anna starts, I do want to reiterate, I am following the chat and I see that there are some questions in here. So we'll get to those at the end. So Anna, I will turn it over to you.
Thanks, Marianne, for the introduction. Before I begin, I just want to extend gratitude as well to the planning committee and all those that were involved in making this wonderful conference happen. It's been both informative and very uplifting, so thank you. As Marianne said, my name is Anna Sear and I'm the Maternal and Child Health Coordinator at the Maine CDC. Part of my position is to oversee the Maine Birth Defects Program, which was established by Maine statute in 1999. In that role, I work with hospitals and other healthcare providers who diagnose birth defects. A birth defect, sometimes also known as a congenital anomaly, is a structural or functional abnormality that is present at birth. Some examples of common birth defects are heart defects, neural tube defects, which affect the spine and the brain, cleft lip and/or palate, and Down syndrome. The sooner these conditions and others are diagnosed, the sooner providers can assess the full impact on the child and the family and connect the family to specialty services. Part of our mission is to ensure that families are connected to resources. So whenever appropriate, we refer families to child development services. The state of Maine funds cleft lip and palate clinical services in the state that provide comprehensive wraparound services to families of children with cleft lip and palate. Our program also collaborates with public health nursing and various other organizations that assist families of children and youth with special health needs. Another partner is Pamela Martin, the healthcare coordinator on this panel today, who assists families with navigating these services. I think I forgot to tell you to change slides, Marianne, a while back. We should be on the third one. Thank you. A big part of coordinating the Maine Birth Defects Program is surveillance. The Maine Birth Defects Program collects data for 56 reportable birth defects, which is considered best practice by the National Birth Defects Prevention Network, NBDPN. NBDPN works at a national and international level to track birth defects. So providers submit birth defects case reports using an online form that sends the information right to a secure confidential database. Then we have medical records abstractors review those records to either confirm or rule out a case and collect data to support confirmed cases. Maine's fortunate. Our surveillance is both passive and active, and not all states are able to provide data with that level of accuracy. This data is used to monitor trends related to the prevalence of selected birth defects in Maine, and also to inform education and prevention strategies to decrease the incidence of birth defects. Next slide, please. The Maine Birth Defects Program works with an epidemiologist, without whom I could not do this job, to collect data for reporting purposes. We report our data to the National Birth Defects Prevention Network and report on the program as a whole to the Maine legislature annually. Those reports are available on our website. Thanks for having me. I'm happy to answer any questions at the end.
Great. Thank you, Anna. And I can see that we do have some questions in the chat around what supports are available. And so I'm happy to introduce our next speaker, who is Pam Martin. Pam is our care coordinator for our program. So Pam.
Thank you, Marianne. And thank you all for being here. As Marianne said, my name is Pam Martin. I am the healthcare coordinator for children with special healthcare needs. Next slide, Marianne. Some of the ways of which I help families is to navigate the healthcare systems, whether it be for insurance needs, prior authorizations, finding a provider, etc. I also assist families with insurance appeals, completing applications. I see this especially helpful when a parent has become overwhelmed or unsure of how to fill something out. I get referrals, I make referrals for families. I find resources such as assistance programs to help them pay for necessities that they have been unsuccessful in finding resources for, or their insurance doesn't pay for it. I also connect families to supports from other parents or families with children who have same or similar diagnoses. And I do this through the Maine Parent Federation, which we're going to talk about a little bit later. And then, of course, I'm here as an advocate for every family. Next slide, Marianne. So you ask, who can get care coordination services? We serve those kiddos up through the age of 21 who have chronic medical conditions, behavioral and emotional conditions. I find myself working mostly with hospital care providers, licensed clinical social workers, case managers, but anybody can call. Parents can call, kids themselves can call if they're, struggling to, navigate the system and just need some guidance. So literally anybody can call. I would never turn anybody away. Next slide, Marianne. And you ask, well, what is the cost for this service? It's free, absolutely no charge whatsoever. It's not income-based, it's not insurance-based. There are literally no eligibility requirements for this. We don't ask families to fill out forms to join the program. The only time I would ever ask a family to fill out a form is an authorization to release information, and that would be if I needed to get information and to comply with the HIPAA laws. To be connected to me, you can call the 1-800 number below, and then at the end of the slides, I will have my contact information listed as well. So, next slide, Marianne. So earlier I mentioned the Maine Parent Federation. The Maine Parent Federation, again, is at no cost to families. They train family support navigators. These navigators are experienced parents who have children with different diagnoses. So what would happen is a family would call Maine Parent Federation. They would go through a brief intake, and then they would be connected to another parent who has a child with the same or similar diagnoses. These trained family support navigators can attend meetings, be a listening ear, be a resource, a guide, etc. And I've incorporated the Maine Parent Federation contact information below. You can also reach out for me. I do have some RAC cards for them that I would be happy to send you if you wanted to refer, have some on hand to refer patients to as well. Another partner is EPSDT, and that stands for Early and Periodic Screening, Diagnostic, and Treatment. This is a federally mandated service for Medicaid eligible children up through the age of 21. Now, for EPSDT, there are certain requirements. First and foremost, it has to be medically necessary. It cannot be experimental. It cannot be covered by any other Maine Care regulation, or it must exceed in frequency or duration by another regulation. For billing purposes, once it was approved for billing purposes, there would also need to be a prior authorization in place, or additional information would be required to bill against. Next slide, Marianne. If you work in a practice, a hospital, you know of a child with cleft, cystic fibrosis, or has a diagnosis of inborn error of metabolism, and they are not connected with a specialty clinic, please reach out to me. We work with a number of specialty clinics very closely, and I'd be happy to set them up depending on where they reside. We have some in Bangor, we have some in Portland. We also have an assistance program for those with a diagnosis of inborn error of metabolism, and if you'd like some further information on that, I ask that you contact me directly. Next slide, Marianne. Here I've listed some resources that I find particularly helpful. These can also be found on the CSHN website. And Marianne, we could probably pop that in the chat for them. So on the left-hand side, you would see a number of different tabs. One of them is resources, and you can find all of these here if there's something that you're particularly interested in. And last but not least, next slide, is my contact information. You have questions, need assistance, have a family that needs assistance, please don't hesitate to reach out to me. Thank you.
Great. Thank you so much, Pam. We do have a couple of questions in the chat, and I think, Pam, most of them go to you. So I'm going to I'm scrolling through them. So Pam, what social supports and resources, in addition to medical treatments, are offered to parents for these and other rare conditions, such as social work, early intervention, peer support, for children with special health care needs? And I know you talked about a few of those, and this question came before your presentation, just so you know.
Sure. So the most frequented is the Maine Parent Federation. And then, so I would basically look at every family on a case-by-case basis and figure out what that support need is. And then we would take it from there. But typically, I think it makes families feel better or quite supported, no matter which area of need they're in. We refer to the Maine Parent Federation just so that they have that other parent to lean on, ask questions, somebody that understands their situation and somebody that's been in their shoes. Does that?
Great. Anne, did you have something you'd like to add to that?
Yeah, if I can just add that there are also some organizations specific to deaf and hard of hearing children and family. There is the Maine Hands and Voices organization, and you can, if you type in Maine Hands and Voices, you will get their website. That's a parent organization. And there is also a Guide by Your Side program, which is run through Maine Hands and Voices, which we, the Maine Newborn Hearing Program, can make referrals for families to that program. What they do is they have 5 or 6 what are called parent guides. They're parents of deaf and hard of hearing children, and they are matched with the families to work with them, help them with advocating and whatever they may need. So there are also some organizations specific to deaf and hard of hearing.
Great. And we will drop those in the chat. My chat is on my iPad and it's hard to type on it at the moment. So I will put those in there once I switch back to my regular computer. So
Marianne,
yeah, go ahead, Pam.
I wanted to add something to the Maine Parent Federation.
Sure.
They also have support groups and trainings, not just for the parents, but also for teens and chats, etc. So those are some really good resources to look into for individuals.
And those resources are free as well, correct?
Yeah. Yes, they are. Everything is, it's all free through Maine Parent Federation.
Yep, perfect. Go ahead, Pam. Anne.
And the organizations and the resources that I mentioned are also free and do also have various support groups, because there's also the Maine Educational Center for the Deaf and Hard of Hearing, or MECDHH, that run a number of different groups and programs for various age levels, also free.
Yes. I'm going to move us on to the next question in the chat. So Pam, this one's for you as well. It says, Pamela, are there enough social workers, PTs, nurses on CDS teams to meet the needs of Maine? If not, what's being done about this? You may not know the full answer to that since we're not from CDS, but we'll try our best to answer that.
I can't answer specifically for CDS. I can tell you overall, no, there is not enough social workers, PT, OT. I can honestly tell you all, in the last 2 months, the majority of my calls have been folks trying to get PT, OT, among others, but PT, OT services. And so I can confidently say, no, there is not enough.
Thank you for that. And if anybody is on from CDS and you'd like to respond, you can drop your response in the chat. From where I'm sitting, I can't tell who's on. So we do have another question for you in here, Pam. These are all about care coordination, right? So the question is, educational supports, can they call you as well? I'm assuming this means folks who provide educational supports.
They can call me. I am not the guru as far as Department of Ed. I do refer on to Department of Ed. I also refer to the Maine Parent Federation for that. Carrie Woodcock is exceptional. She is well-versed in IEPs and the educational system. And I look to her. She is the guru as well as Department of Ed.
I would agree with that. I'm struggling a little bit here with the chat, so we're going to see if there's anything else in here for us. Come on. I apologize. Is there anything else that any of the four of you would like to add while I'm trying to get the chat to come back up? And I don't see any other questions in the chat box for us. So we do have more time if people have questions or suggestions for us. Oh, here's another question. Oh, it's someone from CDS. So Rachel says CDS does have OT, PT, SPL, LCSW nutritionist, an MECDHH consultant. Let's see, Part C in Rockland. Referrals can be made by anyone into their program. And I can tell you that the Children's Special Health Care Needs program, we make a lot of referrals into CDS. So if a kiddo gets diagnosed with one of the disorders that Jody was talking about, or hearing, or any of the other reportable birth defects, we automatically make the referrals to CDS. And I know that there are multiple other programs who do the same. And so CDS oftentimes gets multiple referrals on the same kiddo, which for me, that tells me that our system is working. You know, we don't want anybody to fall through the cracks. Rachel also says that we do not provide direct one-on-one services, but we provide coaching and early intervention services. Rachel, is there a good contact over at CDS that people could reach out to if they had questions? If so, would you mind dropping that in the chat for us? And Eileen from the Maine Lend program says that the Maine Lend is a resource for parents struggling finding appropriate services, and she dropped her contact in the chat as well. Okay, great, Emily. So can you just drop Jamie's email in the chat for folks who don't have access to that, please? So there's a lot going on for sure around children with special health care needs, as well as our newborn screening. And I hope that this was informative for folks. We do have a bit more time if anybody has any other questions that they want to throw into the chat for us. Rachel, thank you for dropping her contact info in for us, and Emily as well. All right. Well, if there are no other questions, thank you so much for the team from the Children with Special Health Care Needs at the Maine CDC. You guys did an amazing job. And Ginger from WIC says, feel free to refer any pregnant breastfeeding women or who have children under the age of 5 to WIC. WIC is so much more than just, getting food. They have so many services available for families that they're just an incredible resource. And so I would highly recommend folks going to the website Ginger dropped in the chat and check out the resources they have available. They're just incredible over there at WIC. So, all right. With that, I think we'll end a little bit early, and I would assume that means that we'll take a bit of a break and wait for our next presentation. Thank you so much, everyone, and feel free to reach out to us if you have any questions.
My daughter, she's 7 and she's in 2nd grade and she's amazing. I did a lot of self-medicating with Suboxone during like the first year and a half of her life, but it was self-medicating, not from a doctor. It was buying it off the street. And then she started spending more time with her dad, so all of a sudden I have all this free time ahead of me and for myself, and I'm like, what do I do? So I call the friends that I thought were my friends and the people that I just knew, and it just kind of progressed from there again, and that's when I started smoking crack and doing heroin regularly, and that was a couple years of a horrible time. And really, my dad has been my biggest supporter my entire life. And I asked him for money and he told me no. And that was really hard for me. And I told him I was going to go prostitute myself for money. And he didn't like me giving him that guilt trip. And we didn't talk for almost 3 weeks. And, so I was doing my thing. I was hanging out with my son's father at the time. There was one night I came really close to overdosing. I still think it's a miracle that I'm here today. And I got up that next morning and was very disoriented. And my father had sent me, for the first time without talking to him in 3 weeks, just sent me an obituary from a mom in Vermont who had overdosed, and it was a really raw and real obituary, and it really hit home. And that's when I just sent him, I need help. I need you to bring me to the hospital. And within that week we were there. We had to get things in place for my daughter and stuff like that. And when I went in there, I had every substance in my system. And when they asked me what my drug of choice was, I was like, do I have to pick one? I like them all, and now I look back, I'm like, that's so silly. And, that was even my mindset. It was always just getting my next fix to the next fix, and that's just no way to live. The first summer of my recovery, my daughter and I did all kinds of stuff together because it was right before her brother was born. And I was like, man, I've been depriving my poor daughter of this. This is not what our summer looked like last summer. We were in the car and driving. And yeah, so it's been, like I said, it's been one hell of a ride. And one thing that with my recovery is that I've learned that most of my addiction comes from self-medicating for mental illness that I didn't realize I had. I didn't realize I was extremely ADHD, because that's what I said. I feel normal. When I do these, I feel normal. And, getting that treated and taken care of has really been the best thing I could have done for myself. The first thing I would tell anybody is it's totally worth it. But when you're not feeling that about yourself, it's really hard to understand those concepts. I've always struggled with the self-esteem and that feeling, even in high school and stuff like that. Goals, I wasn't worried about goals. I was worried about today and let's have fun today. And so I would tell somebody, that they are worth it. And, the only way they would ever see it is if they just stuck with it and tried. I have more confidence and self-esteem than I've ever had in my whole life today. And I'm setting goals and I'm making them. I'm hopeful for the future. I almost feel like a senior in high school that's got my whole future ahead of me. It's crazy at 36, it's definitely worth it. I'm Kristen. I'm a single mom, and I've started my recovery in October of 2018.
Good afternoon, everybody. My name is Deka Dalak. I am the Family Engagement and Cultural Responsiveness Specialist for the Maine Department of Education. We have a great presentation here today, this afternoon, and I'm here to present or introduce our two presenters. Our first presenter is Dr. Nina Soundloud, MD, CM, FAAP. Dr. Soundloud has a bachelor's degree at McGill University, doctors of medicine at McGill University, masters of surgery. She has a postdoctoral trainings in intern in pediatrics, the Montreal Children's Hospital in Montreal, Quebec, resident in the Pediatrics Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire, clinical fellow in Behavioral and Development Pediatrics Children's Hospital in Boston. Instructor In pediatrics, Dartmouth Medical School of Fellow, Department of Pediatrics, Hartford University, instructor in pediatrics in Hartford Medical School, assistant professor of pediatrics in Northeastern Ohio University of College of Medicine, assistant professor of pediatrics of psychiatry, and pediatrics at Geisel School of Medicine at Dartmouth. Dr. Sam Loud has a hospital and healthcare organization's clinical responsibilities in rotation director, developmental and behavioral residency. She attended an attending physician, behavioral and developmental disorders program. Children's Hospital in Dartmouth Hitchcock, attending physician, Akron Children's Hospital, director, Down syndrome program, clinical director, fellowship program, assistant in medicine, active staff, Children's Hospital in Boston, pediatrics intensive care unit, contract physician, Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire. Professional societies is Society of Developmental and Behavioral Pediatrics, American Academy of Pediatrics, and Canadian Pediatric Society. Dr. Nina Loud also has a lot of publications that she wrote or co-wrote. Welcome, Dr. Nina Sam Loud.
Thank you.
Our next presenter is Jennifer Mivert, MA, LCPC, is a licensed clinical professional counselor in Maine with over 20 years of experience working with children and families in a variety of mental health settings, including psychiatric institutions, mental health agencies, and private practice. In her role at the University of Maine Center of Community Inclusion and Disability Studies, Maine's University Center of Excellence in Developmental Disabilities, CCIDS, UCEDD. She provides mental health consultation to early childhood and out-of-school time professionals throughout Maine. Jennifer is also a faculty member in the partnership between CCIDS and the University of New Hampshire LEND program. In that role, she coordinates clinical experiences and placements for trainees, as well as she provides faculty mentoring. In addition, she is the lead in Maine for the Project Scope grant for the grant in LEND program received in 2020. She was a LEND trainee from 2012 to 2013. Some of Jennifer's areas of expertise include social emotional development, attachment, temperament, sensory processing regulations, early childhood mental health disorders and treatments, trauma-informed care and systems, and culturally and linguistically sensitive and responsive for leadership. Welcome, both of you.
Thank you, Decca. I think we're going to jump right in and get started if that's okay with everyone. Those were great introductions and we're happy to be here with you today. So we're going to be speaking on substance exposed infants, trauma and developmental outcomes. And we have a few objectives to share with you. Next slide, Nina. Thanks. So we're going to discuss developmental milestones and red flags in social emotional development for children experiencing NAS or similar exposures. We're going to discuss some longer term developmental outcomes for and identifying one strategy to support these children in their development. And we're going to identify some resources as well as potential barriers for identification to referral for children with NAS or similar exposures. And we've set aside a big chunk of time at the end of our presentation to be able to have discussion. So we'd encourage you to post your questions or comments in the chat. We'll be monitoring that. And then after we finish the presentation, we'll read through your comments and questions and have some kind of form of a discussion that way. So we really want to engage you and have you participate in this experience with us. So I'm going to turn it over to Nina, and she's going to start us off.
Thanks, Jen. So we're going to have a bit of a whirlwind discussion, a little bit about some of kind of what we know and don't know about the longer term effects of neonatal abstinence syndrome on development. And some of this comes from theories of development where we talk about teratology, which is the idea that
This meeting is being recorded.
that the central nervous system is vulnerable to injury that happens in utero. And it might be that you don't see those differences right away, but you might see them beyond that sort of fetal, neonatal, or infancy stage. So the most frequent manifestations of injury to the developing central nervous system don't occur right away after birth, but are not sort of those kinds of abnormalities that you might see on an MRI or something that you would do for imaging, but are more what we would call functional abnormalities or abnormalities in the way the system works. And you might see them later in childhood or adolescence or even adulthood. And some of this comes from a term called the Barker hypothesis, which is just a good Jeopardy term for everyone to think about. And the Barker hypothesis comes from work on looking at more chronic illnesses and chronic conditions like diabetes and obesity and heart disease that we discover in adulthood, but now realize that a lot of the starts of those difficulties occur even before children are born, with sort of in utero nutrition or nutrition in early childhood. And so even though it seems very common for us to have an understanding now that things that you're exposed to in utero or in early infancy can have an impact later in life, that actually is a relatively newer concept from the past sort of 30 or 40 years. Oops, sorry. Well, it was working. So we'll go through sort of each of the different parts of development that we think about. And the first thing that we think about with kids very early are kind of development of motor skills. And so there have been a lot of studies looking at the impacts of in utero exposure to a variety of substances on kind of cognitive and motor development later on. The challenge with all of this research is that it's very rare that we'll see children who are exposed very much just to one substance, or that we have a good knowledge of exactly what the exposure was and the timing of that exposure. And so it just makes it important to think about the results when we're assessing them and having a knowledge that understands that kids are also often exposed to a variety of other things like poor nutrition, in utero alcohol exposure, in utero cigarette smoking, that also can have an impact on development. So some of the studies have tried to separate that out, but it's always in the back of our minds. We should be thinking about what else could be contributing to some of these differences. And so studies have shown pretty consistent differences in terms of early motor development, where children who had in utero exposure to different opioids had more difficulties with their motor development, and looking at a variety of different substances that we think of as kind of safer substances can have those impacts as well. It doesn't mean that it's not still a good choice for a woman who is pregnant to be using methadone or buprenorphine rather than more illicit substances, but it just means that we need to continue to pay attention to the development of those kids. And so in studies that looked at these kids, when kids exposed to methadone in utero at 3 years of age, they were found to have delays in their motor skills. And even at 5 or 6 years, a lot of those differences continue to be present. So when we think about risk factors, then we always are trying to think of what are things that we can do to make those risk factors a little less significant. And that would be by supporting them right from the beginning of the development with things like, how are we going to help kids learn to sit and be able to interact with their environment? So the reason that we think about the importance of motor skill development is not just that it's important to be able to do those skills, but being able to sit allows you to access toys and other things in your environment that are important for your development. So some ideas for supported seating are things like putting a child in a laundry basket or an inner tube. It's not that you have to have fancy specialized seats to be able to support children when they're sitting, encouraging them to play with things that are in front of them so that they have to maintain their balance, holding toys up in the air out of their seats so it forces them to sort of catch themselves from side to side, and things that allow them to sort of engage their trunk muscles rather than always helping them sit will help them with their development as well. We start to worry when kids are not sitting on their own by 9 months of age, or if they're rocketing backwards. So that's like throwing yourself backwards when you're sitting. If you're holding a child and standing and they're not willing to put any weight on their feet, or if there's real stiffness in the legs. So you can think of when you change a child's diaper, how you sometimes will play with their legs and they're easy to move. But if they feel like you're having to push against resistance, that's something that's more concerning. When we think about sort of fine motor skills or how you're using your hands, any type of asymmetry is concerning when children are young. So if you hear the parent of a 3-month-old or a 6-month-old say, oh, my child's already right-handed, that's not a positive sign because we don't expect kids to develop handedness until between 2 and 3 years of age. And if there is really a predominance of using one hand over the other, then sometimes that indicates some difficulties with the use of the other hand. Or if their hand is kept in a fist, like is in this picture, consistently. So the first couple of weeks after a baby's born, they'll keep their hands in fists, but then their hands gradually open. And by 2 months of age, you expect the hands to be open most of the time. So if that hand is continued to be fisted, it can indicate some underlying neurological disorders. And it doesn't allow them to do things like reach and grab things if their hand is in a fist. So when we think about how we want to support those fine motor skills, we want to make sure that kids are continuing to use both of their hands. So we encourage bilateral hand use by giving them things that they need to use 2 hands for. And a lot of this can have sort of more than one role. So if we give them like a beach ball and you practice playing back and, handing it back and forth. Looking at books is another great way of sort of both encouraging interaction, early language development, and motor skill development because you're practicing turning pages of books, and babies love turning pages of those little board books. Offering things that make noise when you tap them together, like blocks or symbols. You want to look at the posture when the child's seated because if all their energy has to go into staying seated, it's going to be hard for them to use their hand. And so if they have something to lean against, it can make it a little easier for them to use one hand or the other. Speech and language development has been one of those things that's been really hard to assess because the studies have been really inconsistent when looking at the kind of progress that kids have made. This is a very big study that looked at children from birth all the way up to 10 years of age and actually tried to compare kids with neonatal absence syndrome to another high risk control group rather than just a control group that's sort of typically developing kids just around the corner in the neighborhood. They're looking at kids who have other kinds of in utero risk factors like exposure to tobacco or alcohol, decreased prenatal care, poor nutrition during birth. And then interesting pattern emerged where at 1 year, children with neonatal absence syndrome and children without neonatal absence syndrome had similar amounts of language delays and a pretty significant amount of language delay. And that continued when at a 5-year follow-up where they continue to have a significant amount of language delay, but that both groups were pretty similar. However, at the 10-year follow-up, the pattern changed a little bit where about a quarter of the children with neonatal absence syndrome continued to have language delay, whereas only about 12% of those children without neonatal absence syndrome had that delay. And so what's important is to really pay attention to language development over time and to continue doing that kind of surveillance or checking on development in informal ways throughout early and middle childhood because sometimes we think that those difficulties are just going to go away, but they really persist. And what's important about thinking about language is that the impacts it can have on all other parts of learning. And so even though this seems a little counterintuitive in that the differences change over time, it's important to remember the groups that you're comparing can really have a big impact because we know that other exposures can also have really significant impacts on development, particularly alcohol exposure, which I think people know in their minds can have an effect on development, but actually the studies are really clear that that's the thing that has the biggest impact on development in terms of long-term ongoing developmental difficulties. So when we think about sort of things that we should worry about in early language development, if babies between sort of birth and 3 months olds don't smile or interact with others right from the very beginning, babies are very interested in faces. And so if they're not interested in engaging with the face of their caregivers, that's important. Between 4 and 7 months old, babies should start to babble. And by babble, we mean consonant vowel combinations like mama, mama, ma, da, 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 da. That doesn't mean they're using those words specifically, but they should be playing with different sounds. Between 7 and 12 months, they should be making more sounds. So if we're not hearing an expansion of the number of consonant sounds they're using, they should be starting to use gestures like waving and pointing. We worry if between 15 and 18 months, they're not saying more than 10 words. And by 2 to 3, we expect children to put 2 words together. By 2 and by 3, they should be starting to use simple phrases. We also are looking at how they're playing and talking with other children and engaging in back and forth activities. So at home, families can work on kind of expansion. Help your child talk in longer sentence and adding new words to the sentence. If the child says down, you could say, do you want to get down or would you like to go down, please? To help them sort of expand on the sentence that they're saying. And extension is using your child, using new words and helping them talk about their experiences and by kind of expanding the vocabulary and really praising children in terms of their attempts at communication. Smile at them and show excitement when they're using words to communicate with you because the best way to sort of engage is what we call serve and return. The child serves something to you in terms of a bit of language, and you return it with language back. Is the thing that we know encourages development the most. I know for me in practice, people are always asking me what kinds of toys they should sort of think about for their kids. And the first thing I always say is toys without batteries, because we really want the child to be making the sounds that the toy would make. So I don't want the car to go beep, beep, beep. I want the child to go vroom or make the beeping sounds. And if you really like the toy, you just don't have to put the batteries in. So I have a cupboard full of toys here that ask for batteries and I don't use any. You want toys that allow kids to use their imagination. So open-ended toys that allow them to kind of make up the story. Some of those back to basic toys are also really nice, like Legos and blocks and cars, farm toys, things that they can sort of build upon. So you can use Legos and make a garage for the truck. And toys that relate to meaningful experiences. So that allow like feeding and bathing and dressing. It's really important to think about this developmental level of the child, though. You want to kind of match the child where they're at. And so if they're a child who's a little bit delayed developmentally, you should be getting them toys for younger kids. And toys that encourage social interaction are really great. So taking turns and playing in the kitchen, making sure that you don't get stuck in gender roles. It's great for girls to have construction toys and boys love playing in the kitchen and with baby dolls. And we don't have to think that toys sort of fit in one role or another. And really, in this day where we're really trying to get kids more physically active, toys that allow them to play outside can be really great as well. And so in 2019, there was really a huge systematic review looking at 26 different studies, and it definitely looks like prenatal opioid exposure is negatively associated with neurocognitive and physical development from pretty early on all the way through adolescence. And so it's important for us to know this, to pay attention to this. This doesn't mean that things are fated to go in a negative direction. We use this information to make sure that we're providing children and their families the supports they need to encourage development. So what about social and emotional development? The direct relationships of prenatal exposure on on later infant and toddler development in terms of social emotional skills is a little less clear. And that's once again a little bit because of some of those confounding factors that we also know can have a big impact on social emotional development, as well as on environmental factors like poverty and caregiver mental health. And so we want to make sure that we're paying attention to all those things that can have an impact on social and emotional skills. So I'm going to send it back to Jen to talk a little bit more about that kind of social emotional development and the other kinds of things that impact that development.
Thanks, Nina. So some of you may be familiar with this definition from SAMHSA on trauma. And what I want to emphasize relative to the definition is how this definition has impacted service delivery. So there are three main components to this definition, and they emphasize the events, the experience, and the effects of trauma on all of us. And what that has done it's shifted our orientation as service providers from a question that sounds a whole lot like what's wrong with you to a question that sounds a whole lot more like what has happened to you or what's happening to you right now. So if you can just kind of settle into the difference between those two questions and think about how that might impact how you approach working with children and families, and what that might mean moving forward in service delivery. Next slide, please, Nina. So let's dig a little bit deeper into how trauma and behavior are connected. And in listening to what Nina shared a few minutes ago, it made me think about something that I hadn't prepared to talk about. So I'll only take a couple of minutes, I promise. But there's a whole field of intervention called sensory motor psychotherapy, where the psychotherapist works with the individual around their movement and posture relative to their life experiences, in particular around any traumatic experience they've had. And so when Nina was talking about assessing children's postures, and in particular, the slide that she had with the fist, oh gosh, I don't want to put a fist up. That looked a lot more ominous than I was meaning it to. But it made me think about some of the ways that intervention offers people opportunities to learn and grow and heal. One of the exciting parts of trauma-informed care systems is that we're beginning to look a lot more at post-traumatic growth. So in this particular intervention, the therapist works with the individual to reflect on and assess their posture, their gestures, their movements. And when Nina was talking about prolonged fisting beyond what we might expect for kids, it made me think about what kinds of gestures aren't happening in the relationship with caregivers, and how that would impact their continued social emotional learning and development. So a gesture that is a hand reaching out with an open palm reflects safety and trust and vulnerability. And for children who experience trauma in an intense and prolonged way, they're often closing their bodies in, including approaching the world with fists instead of open palms that are trusting and safety oriented and vulnerable and asking for care from caregivers. So that was just a little connection that I wanted to make, in addition to this list of behaviors that we often see from children who have had traumatic life experiences, however that occurs on that continuum. And that's a result of under and over activation of the nervous system, in particular that vagus nerve circulation that goes on in the body, which we could spend a lot of time talking about, but we don't have that kind of time today. So if you have specific questions about how trauma and the nervous system and behavior go together, we'd be happy to speak about that at the end, but I want to keep moving forward. So we'll go to the next slide. So in addition to how we want to be assessing and interacting with the infants and children in our care, infants and children don't exist in a vacuum, right? They always exist in the context of a relationship. And as Nina said earlier, it's often the case that caregivers have had lived experience relative to traumatic experiences as well. So when we think of infants and children nested in their families and nested in their caregiving systems, we're often interacting with adults who have had a traumatic exposure or traumatic life experience. And so here are some of the recommendations about how to support someone who's experienced trauma. Next slide, please. Nina, do you want to speak to this?
Sure. So even though I discussed the fact that it's a little hard for us to do a direct line from early exposures to long-term neurodevelopmental effects, studies have shown that there does seem to be an association. So that's not a causation, but an association between NAS early on and neurodevelopmental challenges between 4.5 and 8.5 years of age. And so kids who had early NAS are twice as likely to be diagnosed with disorders of conduct, ADHD, adjustment disorders with anxiety or depression, or kind of combination of those problems, or challenging behaviors, and intellectual disabilities. And then when they're younger, they're 1.5 times more likely to be diagnosed with developmental delays, anxiety, emotional disturbances, as well as autism spectrum disorder, compared with children who don't have those early exposures. And so, so that is like throwing everything out there in terms of the kinds of things that we can see. And that's just because of how complicated it is to do these kinds of long-term studies. So Jen is going to talk to you a little bit about the resilience factor.
At least we get to have a conversation, right, Nina? So I want us to understand that whenever we're talking about trauma, we're also talking about resilience. And whenever we're talking about resilience, we're also talking about trauma. They're always in a ratio relationship with one another. So it's easy to kind of get into one channel or the other, but I think it's important, in particular as service providers, to be holding both of these in our minds as we're engaging with children and families and the services we provide. So the great counterbalance, if we think of it kind of like a scale to traumatic experience, is our capacity for resilience. And again, our friends at SAMHSA are super great with definitions. I'd encourage you to check out SAMHSA's Trauma-Informed Care section of their website if you haven't done that already. Loads of incredible information. And in terms of resilience factors, in terms of protective factors and the things that support resilience in our life, it kind of breaks down to 3 types. So there's the individual protective factors, things like a sense of self-worth, good self-regulation. So if we think about that in terms of the attachment relationship, and all my early childhood people who are out here in virtual land know that self-regulation always starts in the context of relationship of co-regulation. And then if we kind of connect those dots that we were just talking about in terms of children always being nested in a context of relationship, if the adults that the children are being cared for have challenges in terms of their capacity around self-regulation, that can get translated into that co-regulation dynamic with an infant and a child, and then we kind of get this snowball effect. And we can get the snowball effect of the other direction. So adults who have addressed challenges in their life and worked on their own capacity around self-regulation can facilitate that skill building process in their children and children that are around them. When I think about like the childcare community and out of school time professionals who care for children as well. So that's kind of some of the individual protective factors that we talk about. Then we talk about family factors. So living in a safe environment, having trusting relationships, again, that gets us thinking about attachment experiences, and then pro-social values and ethics. And then we get even a little bit bigger. So we start kind of with the individual, and then we go into the family, and then we get a little bit bigger in terms of community factors that contribute to the protective factors and our skills and abilities around resilience, which include a sense of belonging. Do we feel like we belong in the places that we are? Social networks with peers, and a sense of self-efficacy and agency, meaning we feel like we have an impact on the environment around us, whatever that environment is. Next slide, please, Nina. So here's that kind of scale of trauma and resilience in a picture. I'm a visual learner, other people are. Sometimes it's nice to have picture references. So as we think about this balance of resilience and trauma in the lives of the children and families that we serve, but also maybe in the context of us, because in this situation and some others as well, we're talking about us, our own experience. Sometimes we get into this frame of reference where we're sort of like talking about other people, those people over there who fill in the blank. When we're talking about trauma and resilience, we're really talking about everybody. There really isn't anyone who isn't touched in some way by trauma. So in thinking about your own life experiences, just reflecting for a moment on how much or how often as a child you felt these kinds of things in order, and the outcome being that your resilience was bolstered and your skills that support those protective factors were enhanced through these kinds of experiences. So the big takeaway in this is that there are lots of things that go into the mix, right? It's like, I'm gonna date myself here, but it's sort of like the Prego spaghetti sauce commercial on TV, like it's in there. There's so many things that are in there. But what it really comes down to is consistent, predictable caregiving and solid daily routines help to mitigate the risk factors. And when we think of especially vulnerable populations of children and their families, we want to think about where those things are happening in any sort of way and where we might be able to engage with that child and their family to support, promote that and sustain it, and maybe even restore that depending on our role in places where a lot of damage has happened. Next slide, Nina. So again, visual learner, just had to throw in another picture, but this is kind of like the big picture around the relationship between resilience and trauma. So like we were talking about in terms of like there are those three particular types of protective factors that we often refer to. This is kind of all of those in a picture together. So again, it's a bigger piece, it's a broader context. It's not any one particular thing. It's a lot of things going together to support improvement in the life of children and families. Next slide. And I'll hand it back to Nina.
So when we think about So Jen did a great job of giving you like the big picture thoughts of the kinds of supports that families who have had these experiences need. And then I'm going to sort of pull it into what are some of the specific ways that those supports are kind of provided to families. And so for those youngest kids, we think about supports coming from early intervention. So that's present in every state, services of kids who are 0 to 3. In many states, although not all of them, those services, those children who've had early in utero exposures to opioids automatically are eligible to receive these early intervention supports. And so we should be thinking as families are leaving the hospital with their newborns, how are we going to get them connected to these kinds of supports? And it can start off slow and then expand depending on kind of what the children need. And the goals of most early intervention programs are to help the parents learn strategies to provide good developmental stimulation for their children at home. It's not for the therapists to come in and do hours and hours of therapy. It's really to work together with the family so that they can be the guides for their children's development at home. In kids who are sort of having more difficulty, sometimes we have to sort of step things up a little bit and bring in some play therapy. And the idea of play therapy is using a language and approach that children can understand by using symbolic play to release emotions and display some of these ideas of things that are sort of challenging for them that they don't always have the language for. And if we think about how children learn through play. And so we want to use the thing that comes naturally to them as a way of kind of working towards those things that have become a little more challenging for them. And we use different kinds of categories of toys. So sometimes we'll use real life toys like doll houses and matchbox cars and kitchens as a way of kind of accessing that early symbolic way of how do we manage with things going on in our real life around us. Sometimes we'll use toys that are a little more aggressive to allow kids to scream and yell and get at those sort of deeper emotions and help with that self-regulation. So plastic armors and superhero action figures and things like Nerf guns. But we also want to make sure that we're giving kids opportunities to express themselves creatively because different kids let their emotions out in different ways. So things like building blocks and clay and crayons allow children to express their emotions in a bit of a different way. When we think about the kinds of services or the kinds of supports that the most small babies need, we talk about practices to support babies right from birth. And a lot of hospitals are starting to really bring a lot of these theories into action that we know that babies do best if they're right near their mothers in a very calm and comfortable environment. So we want children to breastfeed and we want them to have regular skin to skin contact with their mothers and engaging in a lot of hugging and sharing close moments together where they can be made to feel sort of even and comforted. We want to make sure though while we're doing this that there are safe sleep practices going on. And so modeling that by putting babies into their cribs or bassinets on their backs, making sure there's not a lot of things in the crib with them like toys and blankets or pillows. We want to provide frequent on-demand feeding. And we know breast is best, but that doesn't mean that that there's a problem with using formula if it can be done in a comfortable, together, close fashion. And we want to make sure that we never make families feel bad about the choices that they make and the decisions that they have. And different decisions work well for different families. And so we can say breast is best and at the same time support families when that isn't the right decision for them. We know that that many of these babies are easily overstimulated. So we want a low stimulation environment. So kind of dark and quiet and making sure that we swaddle the baby in a safe way, but in a way that doesn't allow them to keep sort of jerking their arms away around that sort of wakes them up and makes them shudder and become poorly regulated. And then we want, yep.
Before you jump to that next
Sure.
slide, I just want to think about this slide in the context of the slide around trauma and behavior and the kind of behaviors that we see children engage in terms of that nervous system under an activation. and the process of co-regulation that children are engaging with their caregivers. And so when we think again about all this mix of things going together, we can see how this list of practices really can provide some of that counterbalance to those kinds of behaviors that we saw in the other list around agitation or under responsivity. And I've found it fascinating for years and years that for the first 3 months of life, the heart rate of the infant mirrors the heart rate of the mom. And so that just emphasizes to me those kinds of connections, both physiologically and emotionally and psychologically. So when we put all these things together, it can be just such a beautiful symphony of interaction between caregiver and infant. So I just wanted to add that in. Thanks.
No, and I think that's a really beautiful way of thinking about it. I think we don't want to think of this as a list of to-dos as much as a way of like helping everybody feel more comfortable. And here are some ways to make that happen. It's not a checklist that everybody needs to follow, because it's going to be a little bit different for different families. And some families might feel like a dark, quiet environment is too dark and quiet, that it makes them feel nervous and scared. And so then we need to sort of adjust things to make it work. It's not a one size fits all, but it's really important to sort of work on figuring out how to help the mom and the dad and the baby kind of feel comfortable together. So the best way to manage behavioral concerns is to avoid behavioral concerns. And so we know that there are lots of things that we can do right from the very beginning that are going to help set us up for a more positive engagement and interaction, so that we're not going to have to sort of turn around and manage a lot of challenging behaviors. And the things that help all children develop well, but is particularly true for children who sometimes have who are more at risk of developing difficulties with self-regulation and emotional regulation, are sort of a high level of structure with consistent and predictable daily routines and expectations. And so if the day is always that we have breakfast and then we brush our teeth and then we put on our clothing and then we go outside and play and then we come in and have a snack, continuing with that predictability is really helpful. If sometimes we do it one way and sometimes we do it another way, the kids don't know what to expect. That increases anxiety and agitation. But if every day is pretty much the same, that doesn't mean like at 10:12 we have to come in and have our snack. It means that we're following a certain sort of structure and pattern to the day. That really helps kids feel more regulated and more even. If we give a lot of positive praise for positive behaviors, and that's not like good job and yay for you, but it's, I love the way you put your shoes under the table when we came in. I love the way that you gave your brother a toy rather than grabbing it back. And so really trying to be specific and proactive. I love when you use gentle hands. Thank you for having a calm body. And you really want to focus on positive, 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 positive. And then every once in a while, no, it's not safe to pull on that plug. But a lot of families, if you really have them sort of pay attention to the balance, it's the other way. It's 5 negatives to 1 positive. And when you have parents sit and count it, they're usually astounded at just what it's like in terms of that positive to negative. And the best way to do this is to right from the very beginning to start rolling it into your way of being a parent. It's hard to unlearn one way and learn something new compared to always doing it this way. And so you really want to be aware of how you're relating to the kids and trying to really be positive and specific, and being aware and responsive to sensory needs, which is what Jen was really talking about. And it's really important to look at sort of your own way and children's ways. As much as we hope that they're always going to match, they don't always match. And so you might be a parent who likes things sort of quiet and calm, and you might have a child who's rah, 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 rah. And that's a little hard, and you have to figure out how to sort of balance the two, and figure out how to make your needs and their needs both get met. And certainly we see the opposite. We can have parents who are boisterous and vivacious and kids who are a little quiet and easygoing. And sort of figuring out how to recognize those differences is the first step. What are my needs and what are my child's needs? And then figuring out how to make them match so that you're not constantly at odds with each other. And there is a way to make it work, even if you're not temperamentally totally on the same wavelength. You want to start right from the beginning, having some good strategies to soothe toddler. They're called terrible twos for a reason. This is something that we see commonly. And so figuring out some strategies that help children regulate their emotions. This is a time when kids have big feelings and not lots of language. And so the things, those come together and cause challenges. And so we want to say, what are things that we can do to help give the child the language to express those big emotions? And when is it time to sort of distract or redirect them? Can we give them a big hug to help them regulate if they're feeling kind of stressed and overwhelmed? Or are they a child that wants to sort of push away? Making sure that we provide transitional objects to help children when they're young. So transitional objects are those objects that help children kind of relax, a special teddy bear or a special blanket. And thinking about how do we use those objects so that they become that role. It sometimes happens naturally. This is the special blanket that grandma gave him and he always carried around, but sometimes we have to sort of plant it in there. When we're doing our bedtime routine, we always carry this stuffed animal or this blanket, and we can teach it to become that transitional object and help the child soothe. But most of these things work better before we see the ramp up. Once the child's in the middle of a screaming, yelling tantrum, it's not the right time to say, oh, let's go get your teddy bear, or let me give you a big hug when we're sort of flailing around. Sometimes we have to kind of wait and kind of see that through, and then we can go back and kind of put those things back into place. So I discussed we need both rewards and consequences for positive, negative behaviors, and they need to be very consistent. So it can't be that sometimes you have to take your muddy shoes off when you come into the house, and sometimes you wash your hands before your meal, but not all the time. That's really confusing to kids. You want to make sure that if you are giving a consequence for a negative behavior, that it occurs right after the behavior happens. If the babysitter tells the parent that he really was misbehaving today after nap time, and then the parent picks the child up at 5, that's not the time to respond to that behavior. It really needs to be right after it occurs, and it has to be developmentally appropriate. And so we can't give 2-year-olds 5, 6, 7 sentence explanations for why their behavior was not appropriate. They're not going to understand what you mean. And we can't send a 2-year-old to the room by themselves with no one around, because that also is not developmentally appropriate for them. So we really always have to think about where the child is developmentally and making sure that both our expectations are appropriate, but also the consequences for their actions are appropriate. So that is our whirlwind. I'm hoping that Jen's been working on the chat and that we have some questions, and we were hoping to try and make this as close to a conversation as possible, because we know we're getting towards the end of your long 2 days of conferencing, and we thought this would be a good time to try to catch up on some questions and thoughts.
Thanks, Nina. Yeah, there's been a little bit of chatter in the chat, and I'm going to work backwards because short-term memory for us folks over 50 can be a little tricky at times. So I've been having a little side conversation with Dee in the chat, and she was asking if the techniques that you were just referring to could work with a 4-year-old. And I said, absolutely, Dee, but I also wanted to say they can work with anybody of any age, like really anybody of any age. So I don't know if you want to elaborate on that at all, Nina?
Yeah, I think these are sort of what we call sort of basic principles of behavioral management. And they really, it's always easier to start right from the second that child is walking to be able to start to implement some of those strategies, but it's never too late to put those into place. And we know that the more structure and consistency that you provide at any age, the easier it's going to be for children, but also slowing things down, making a real conscious effort to put more praise in really can have a impressively positive effect on children's behavior. And so there's a lot of parenting programs that are actually specifically geared towards sort of positive parenting. And the idea of that is really catching a child being good, so that they know exactly what are the behaviors we want to increase. Because if we pay a lot of attention to the negative behaviors, then they only learn what they shouldn't be doing and not what we want to see. And so we really want to think about how do we encourage those positive behaviors by being really mindful about sort of showing the children when they are good. And that has the other sort of added bonus of helping them feel good about themselves, because it's nice for a child to get the feeling of, oh, I'm like, this is what mom wants and it feels really good. I'm enjoying this interaction and I'm enjoying this engagement. I want to do this more to have this feeling more. And so so that it both sort of teaches them the behaviors that you're looking for, but also gives them that positive sense of, oh, this is what happens when I'm acting this way. It means I have the chance to have this great relationship.
Yeah, the only thing that I would add to that, Nina, is I often, in my conversations with caregivers, the little short phrase that energy flows where attention goes. So if you're putting all your attention, as you were saying, on negativity in whatever form it's taking, you're gonna load up a big energy flow in that direction. And so if you're doing that 5-to-1 ratio that you shared in the slide, which I agree with you, can be a real challenge for people, especially if they've been on a different path for a while. It's a great reminder that counting 5-to-1 to help make that shift. And then the more that very specific praise and gratitude and appreciation, even 2-year-olds really need some gratitude and appreciation for the things that they're doing in life that are beneficial to themselves and everybody else. So once you're kind of headed down that stream of positive and appreciative and gratitude, then all of that energy is going to flow that way, and it's going to have that reciprocal relationship with your attention as well. So I think just doing that 5-to-1 ratio would be a big boon to anybody's relationship for sure. Just a couple more comments in the chat. One thing I love, Nina, and I know we talk about this a lot in the work that we do on the Echo Scope project, is collaborating with other professionals and service providers in different areas of expertise. And I just want to give a big shout out to Madonna at Fetal Alcohol of Maine. And in the chat, if folks haven't noticed that, she's listed a number of studies referring to a lot of the research that you were referring to, Nina, with the intersection of opioid use and alcohol use and multi-substance use. So I would encourage folks to check out that information in the chat. And lots of folks have asked about if the slides will be shared, and they will be. So you'll have that information, and as well, the recording will be posted at a later date. And we have one question that just came in as well, and I'm just gonna read it straight out because I haven't even looked at it yet. So the question is, what are your ideas for working with a 6 to 10-year-old for therapy? I have many kids born exposed, plus I'm thinking DV is referring to domestic violence and other trauma and adopted. I do cognitive behavioral, play therapy, attachment work, and do the 5-to-1 ratio. Any recommendations on books? That's a big question.
That is a big question, but it sounds like she is already doing all the right things that we have talked about in terms of, combining different approaches to meet the different needs of both the children where they're at as well as their families. I can't think of books off the top of my head. How about you, Jen? I could try to think of some and send them after.
Yeah, being put on the spot, like, oh, this is a quiz. I always like, have test anxiety. One that does come to mind are any of the books in Dr. Ross Green's series. His work with, now he's changed his name over the years, not his personal name, but his approach name. And I think it is now called Collaborative Proactive, CPS, Collaborative Proactive Strategies. The overarching website, oh gosh.
Now he talks a lot about like humankind. Oh, like raising, I think the most recent one might be raising human beings.
Oh, wow. Okay.
And it's a lot about, it's a really nice approach in terms of thinking about that everybody wants to do good. And if you're not doing good, it's because you don't have the skills to do good. And I think it's a great way of framing it, as he talks a lot about sort of problems as being a skills deficit rather than, I'm a bad kid, which I think is a lot how a lot of kids start to think of themselves. And if we think of something as a skills deficit, then it means that it's something that we can learn.
Right. And our friends in the chat, Nina, this is great. We actually are having a conversation, what I was hopeful for. But Robert corrected me. Thanks, Robert. Collaborative problem solving. That's what it is. And Shelley put The Explosive Child. That was one of his earlier books. Great book. And Deb Hoffman saying that she agrees with Shelby about also catching the parent doing something right and praising them. No apology needed about the long question. Totally fine. That's what we're here for. The other person I would recommend, an other set of resources, is Dr. Dan Siegel, and he's done tremendous work on attachment, and his book, Parenting from the Inside Out, speaks to a question that came up around, where was it? Shelby made a comment where she says, Nina, nearly all the parents I've ever worked with have themselves experienced complex childhood trauma and have never been treated. Teaching parents these skills for themselves is paramount to their ability to teach their children. So I think the work that Dr. Dan Siegel's done around attachment and mindfulness practices, and that the dynamic in that caregiving relationship and the reciprocity and all of that, that's right up that alley. And I think it was Shelby that asked for recommendations. Any others you're thinking of the top of your head, Nina?
No, there's a trauma-informed network that has a lot of great online resource, and I can't remember the specific network, but I think if you Google trauma-informed network and children, it will connect you to whatever that network is, and it has really beautiful handouts for families, which helps with what Shelby was mentioning in terms of that sort of unrecognized trauma in the parents, and helping them understand what happened to them and how that's impacting them as parents, because I think that's true. I think we can't ignore, if we think that parents feeling comfortable and secure in their ability to parent has them better understanding, how they were parented, and them feeling comfortable and moving to better understand themselves is going to make them much better parents.
Yeah, I think you're referring to the Child Traumatic Stress Network.
Yes.
You were thinking, Nina. Yep. And Rachel, thanks, Rachel, for dropping the link in the chat. I think we're out of time. But thanks all for your fabulous comments and questions, and thanks for your time and attention today.
Hi, everyone. Thank you for joining this last panel style presentation. My name is Denise Trafton, and I have the pleasure of hosting this panel style presentation for you. And I'm going to take just a second and share my screen to get us going. Flip that around. Hopefully you're seeing, ask my team, the PowerPoint. You're seeing that here. Thank you. Okay. So this conference has been full of amazing presentations, information, and some pretty powerful stories as well. And I think I can speak on behalf of everyone on this panel that we are grateful to be able to provide just a small part of the larger focus of this year's conference. So we all want healthy infants and families, and we know it takes collaboration. It takes us all learning best practices. And from my perspective, personally, probably the most important component is that word at the end, in empathy. Empathy to understand that families come in a variety of shapes, sizes, makeup, and they bring their own experiences as well. So as people who are working to support families to be as strong as possible, we need to make sure we are looking at the fuller picture, or the greater picture, if you will. Over the years, we've learned so much about the mother-child dyad, which is extremely important. But we were excited to hear this year, or learn that there was a little more energy around learning about what we're doing across the state to support those other caregivers and other family members, other members of the family as well. Which is why our panel presentation will focus on the programming, supports, and approach offered by Maine's network of prevention councils. We work collectively and collaboratively to strengthen all families and include all members of the family, because we know if we support the family as a unit, and we have a stronger family unit, the outcomes for children and families, infants and children and families, are much better. So I have a few panelists that I'm going to introduce in just a little bit. But again, my name is Denise Trafton, and I am the Prevention Support Specialist at Maine Children's Trust. And I just want to provide a little bit of grounding and context before we get too far into this, and let you know a little bit about the role of a local prevention council and how we support families in the community. So right off from the start, you're probably wondering, what is a prevention council? What exactly do they do? And how do I find them? So prevention councils actually exist in statute in our state to provide county level services that are focused on primary prevention of child abuse and neglect. So yesterday there was a presentation where Christine Theriault talked about the full continuum of prevention services. So our focus is primary prevention, way upstream, or way at the beginning of that continuum. Council services are free and include training for professionals as well as programs for parents. Council programming is supported by Maine's Department of Health and Human Services, and it's the Maine Children's Trust that provides the coordination, the training, technical support, and the oversight of the network of councils. As I mentioned before, council programming is available to all families. Councils offer a variety of evidence-based parenting education curricula. We offer support groups, play groups. Councils connect families to area resources, local resources, and on occasion can provide concrete supports to meet family needs. An example of that might be diapers, or we are also part of the Cribs for Kids distribution. In addition, some of the councils have more specialized programs that are designed for specific parenting situations, such as people who are fathers, families in co-parenting or blended family situations, and families in recovery. And these are some of the programs that our panel will speak about in just a moment. Another piece that I want to make sure that I highlight is that during the pandemic, all of the councils have been able to pivot very quickly and are offering services virtually. So that's who we are, and that's what we do. Now, how to find us. The easiest way is really to visit the Maine Children's Trust website, and you can see the website at the bottom. This is just a screenshot, so it's not the live website. You can see at the top the two primary prevention efforts that are coordinated by Maine Children's Trust, the Maine Families Home Visiting Programs, and the prevention councils. If you were to click on local resources, it takes you to a map of the state of Maine, broken down per county. And this is a way to really find your local prevention council. So you can just click on your county, and what you will see is a current list of classes and professional trainings that the council is offering. Usually the registration link is right there, so it's really user-friendly, along with the contact information for the council as well. This page is really helpful for parents and for professionals because the councils really offer something for everyone. So parents can search based on the age of their child, maybe some of those more specialized circumstances, or down here under additional activities is where you'll find our play groups, support groups, our professional trainings. So yesterday, Jen Heyman mentioned mandated reporter training and infant safe sleep and training on abusive head trauma. The prevention councils offer that to professionals. And again, all for free. So it's really a super user-friendly website to utilize. So now, without further ado, I'd like to introduce our panel members. So first we have Mindy Carell. Mindy is from the Prevention Council of Lincoln County, or Healthy Kids. Mindy will be sharing more about the Inside Out Dads curriculum and their council's collaboration with the local jail to support incarcerated fathers. Dawn Flagg is from the Prevention Council of Knox, Waldo, and Saginaw-Hawkes County under the Maine Mid-Coast Maine Community Action Program. And John Martin is her co-facilitator. And just to say a little bit about John, this is fascinating to me. John has offered over 25 Nurturing Father classes. So that's a testament to John as well. He is the center supervisor for the Webster Center, which is a local Head Start agency overseen by the Southern Kennebec Child Development Corporation. It's a mouthful. So John does this co-facilitating over and above his other duties as well. So that's just a special shout out to you, John. Dawn Flagg will also be sharing a little bit about our co-parenting programs, but John and Dawn together will talk more about the Nurturing Fathers program. And then Wendy Pace from the Prevention Council of Penobscot and Piscataquis will be talking more about our nurturing program for families in recovery. So I'm going to turn it over to Mindy.
Hi, thanks, Dawn. My name is Mindy Carell. I've been with Healthy Kids here for a little bit over 4 years now. We offer many programs through our agency alone, just for parents and caregivers. So, but what I'm going to talk to you about today is what Denise had said is our Inside Out Dad program that we do at the Two Bridges Regional Jail in Wiscasset. So when I started with Healthy Kids, we were just doing a couple of small programs at the jail. We were doing some active parenting, some of the shaking baby syndrome, and a couple of the nurturing classes. And then the jail started getting like fuller and fuller. So they asked, you know, can you guys come in and do a program for us? So we started doing a 6-week program. Inmates loved it. So they asked us to come back. So we started doing weekly programs with them throughout the last 3 years that I've been there. But so some of the classes that we do it on is like on alcohol and drug use disorder. Some of the classes are on like domestic violence and anger. And some of the other classes are like on nurturing, but every class that we provide there, we want to make sure that we really show them that parenting can be done while being incarcerated. So that's kind of, we adopted this Inside Out Dad last year. It was new and we did it over Zoom. So we didn't have a lot of people come, but the couple of guys that did come, they really enjoyed the program. So the Inside Out Dad is a evidence-based program for incarcerated fathers from the National Fatherhood Initiative. So this program helps fathers turn their lives around by helping them to create and like reconcile. This program helps fathers bond with their children while incarcerated, which is really, really important for rehabilitation. So it's showing, I mean, it shows that like the more involvement parents have while they're incarcerated, the less likely they're going to offend again. So the program really digs into like, what's it like to be a man? How to handle your emotions and how do you show emotions, and how to connect with your family and reconcile your past mistakes. So one of the activities that we do for showing emotions is we have them take a piece of paper and rip it into 3 parts. And then we have them write down an emotion that's really, really hard for them to handle, you know, jealousy, sadness, anger, whatever. And then after they've written them down, we have them stand up and they start walking around the classroom freely. Then we have them drop a piece of paper on the ground that has their emotion on it and they have to stand on it. So they're kind of covering up this emotion and they have to start walking around without lifting their foot up. So now they're walking around and they're dragging 1 foot behind them. And then we have them drop another piece of paper. So now they have both of their emotions under their feet and they're starting to walk around and they're dragging their feet. So this really getting hard for them to walk around the room. And then we have them take the 3rd emotion and put it on the ground and they all kind of like look at me like, how are we supposed to step on this? So, you know, I really like this activity because it helps like them show that emotions are real. We all have emotions, you know, and if we just bury them and cover them up, we're not going to be able to really heal from these emotions that we have. So, you know, this little activity also helps them see, well, your children have emotions also. You know, we don't want to bury those emotions. You know, we want our kids to be able to show them and to show really like whatever we do really impacts our children, you know. So I'll never forget this one time I had a dad that was incarcerated on drug charges. And his words, he goes, I'm not damaging my daughter because I wait until she goes to bed at night and I go outside to use. And I said, oh, okay. He goes, most of the time my wife likes to lock the door on me, so I have to sleep on the porch. I said, okay. I said, well, so you're not impacting your daughter because you're not using in front of her, right? And you do it outside? He goes, yep. I said, okay. So what do you think that your 12-year-old daughter thinks about before she goes to bed? He didn't really have an answer. I said, well, maybe do you think it could be, you know, is dad going to make it inside tonight? Is dad going to be warm enough outside? You know, is dad going to get bitten by bugs? You know, is dad going to sleep on the porch? And he just kind of stopped and he looked at me and he hung his head and he goes, oh man, what have I done? You know, and those aha moments are really important for rehabilitation. You know, that's what this course is really about. It covers like family dysfunction, criminal attitudes, and what are their values and what are their beliefs? they can start looking at their life in a different perspective. So at the end of these program, the men are able to really see their actions, and they want to make amends really by the ones that they hurt along the way. It really helps them makes them think a little bit differently. So when I say to them, maybe being incarcerated isn't the worst thing, a lot of the times the guys look at me and they go, well, if it wasn't because of this, I probably would have overdosed. Or, if it wasn't because of this, I wouldn't have connected back with my family that I lost a long time ago. Like, so to really start getting them to change the way that they think, and, that's really what these programs are about that we use, for the men. So, it really helps them to start realizing that their kids do need them. Even if they're incarcerated, they need to start focusing on learning on how to be in their children's life. And, and they really start focusing on, okay, so what can I do? I had one dad say, okay, I've got to go now. I'm going to go call my kids. But I remember this one gentleman, and he started doing this Inside Out Dad towards the end. And then I started a support group for the gentleman right afterwards. And he came to the support group, and he was really big, because he decided that being a father and a grandfather now, he came up to me after class one day, and he said, well, I know I'm going to die in prison, but by taking these classes and having the support, I'm able to take the younger inmates under my wing, and really show them that they need to, and that's what he said, wake up before they wind up being like me, 60 years old and going to die in prison because of my past mistakes. They finally caught up with me. So spending times in the jails with the inmates is really important for families. One of the other programs that we do over at Two Bridges, and I've done with Dawn, is Nurturing Fathers, and she's going to tell you a little bit about that program.
Thank you, Mindy. Hello, everyone. It's so nice to be here. So Inside Out Dads, as Mindy just described, is a program that is specifically designed for fathers who are incarcerated. And I'm going to talk with you a little bit about Nurturing Fathers. That particular program has been offered in the correctional settings. As Mindy mentioned, she and I have co-facilitated that at Two Bridges. And this program is also offered in the community. I think one of the first things I want to just note is in the name may be Nurturing Fathers, but actually the program is much broader than the name suggests. It's actually designed for anyone who is in a fathering role. So that may be dads, it could be grandfathers, it could be uncles, partners, friends, etc. So we have a lot of parenting enrichment programs that are available to any parent or caregiver. So why Nurturing Fathers? And that particular question made me really think about someone, John, that you and I had in our group. A dad actually asked us that question. He said, why is there a program specifically for dads? Is it because society views us as needing more work than mothers need in order to be good parents? And that took me aback. It is such an interesting and important perspective and concern, and I greatly appreciated it. It isn't anything that had ever occurred to me, but I will share with you that that dad is not alone. Many fathers report that they believe that they are actually replaceable. Mindy addressed that when she was talking about fathers who are incarcerated, and that's true for fathers in the community too. And sometimes mothers may agree with fathers about that. In one study about how moms and dads view this particular issue of how dads fit into their children's lives, here are some of the responses that were given. When mothers were asked, 64% said they believed that they can replace the father. 68% of mothers said that they believe another man could replace that father. 56% of men said that they believe that they can be replaced by mom. And 58% of men said that they can be replaced by another man. I just find those statistics very sobering. We recognize that the cultural lens and the lived experiences of those in a fathering role are often different than those of mothers and women who are caregivers, yet they are both super critical roles. This program honors the experiences that are shared and those that are unique to those in a fathering role, and it provides opportunities to explore what fatherhood means, as well as the valuable role that these caregivers have in contributing to their own children's development. In this program, to give you a sense of some of the topics that are addressed, we explore the roots of fathering, nurturing children and self, positive discipline methods, managing emotions, resolving conflict, teamwork with a partner, balancing work and fathering, and much more. Of course, one of the most formative influence on fathers or those in a fathering role is their relationship with their own fathers. And in some cases, that may actually be the absence of that relationship. And they also, one of the most important things, of course, is the way that they were fathered. So briefly, Denise, thank you for putting up this slide. I love this. I want to share one activity that actually occurs at the beginning of the program, and it is consistently referenced throughout the program. That segment is called The Roots of Fathering, and participants actually create their own his story. So that is 2 words, and it's a play on the word history. And that is titled My Father and Me. Many dads struggle with their sense of loyalty and the idea that they can both love and respect their father and still in some cases choose a different approach. So here's a cartoon that is part of the Nurturing Fathers Journal. So you've got a couple of men in a room full of boxes. They're examining the boxes and they are trying to figure out what the sorting process is going to be. And the caption at the bottom of the cartoon is, "It's a bunch of stuff my dad gave me. I'm going to go through it and save some, throw away some, and add some that is entirely mine." So this cartoon, I think, beautifully illustrates the important work that many in a fathering role are doing in their own lives, and certainly as they're working with us in the program. So I have had the pleasure of co-facilitating with John. Women can and do co-facilitate or facilitate this program, yet as you can imagine, it is incredibly powerful to have someone who has a shared life experience, that shared experience being a father. John's fabulous at facilitating this particular program, and he is now going to share some of his experiences with the program. Hi, John. Thanks so much for being here.
Hi, everyone, and thank you, Dawn and Denise, for inviting me to participate and share a few thoughts about something that I love very much. And I don't have slides, but there are a few anecdotes that I think I could come up with in my experience. And yeah, I was kind of surprised that it's 25. I recently found that information out. And so doing 25 classes, a few things really kind of stick out for me. And I almost developed like our own theory, but it actually has a basis in the curriculum. So the topics that Dawn just mentioned, she went through a list of, I believe, if memory serves, I even know the page that you found those topics off of in the book. There's about 12 topics, and it's actually, they're listed as part of what's called the visualization exercise that's in the curriculum. And what it asks the guys to do is to go back in time. And it's always kind of funny to see guys go through the visualization process because it's very, not something typically that they do. But over the years, they've really seemed to have gathered around it. But one of the things, and this is the concept that I said that I've kind of developed through the curriculum, is it asks you at one point to close your eyes and imagine yourself in the presence of your father. And asking the person doing the visualization to say, how does his presence make you feel? And that to me is really, when I look back at all of the classes that I've done, what the curriculum means to me, and I really think means to the guys, and I've talked about this with Dawn, is a concept of having presence and being present in a child's life. And really, those are two different things. And, being present in a child's life, to me and to a lot of guys, means, physically being in the location of your child, where presence in my mind is, having an effect on your child's life. And what I think that one of the great things that this curriculum does, and it brings guys to this conclusion, is that they can have a presence in their child's life more than they've ever expected. Especially because a lot of the guys that find this class tend to be in some really tough circumstances. And so one of the stories that I just wanted to quickly share was a guy that I had, and I also facilitate classes for KVCAP, which is a Head Start agency in the Kennebec County area. And I had a dad that came to the class, and he was a particularly shy guy that took a little while to warm up and contribute. And then finally, it just boiled out of him. He said, how can I have presence in my child's life? This is a gentleman who had a daughter that was a couple years old, and he had not seen his daughter at any point in his life. And so he was coming to the class in order to get that opportunity. And so what is he supposed to do? And he goes, how can I be, how can I have presence when I'm not even present in my child's life? And so, we found out that this guy, had a truck driving route from Skowhegan to Farmington. And I said, tell me when you drive. And he says, real early in the morning. I says, do you see like beautiful sunrises? Or when you're coming home, do you see beautiful sunsets? And he says, all the time. And I said, do you, think of your daughter in that moment? And he goes, absolutely. I said, this is what I'd like you to do, because in this day and age, everybody has a camera. They just pull out their phone and they have a camera. I said, pull your truck over, take a picture of that, and write a note about what you were feeling about your daughter in that moment. And a few weeks went by, and you really sometimes you don't get to know, teaching these classes, you don't get the feedback or the idea of the effect that it has in their lives. But he comes into the conference room where he does the class, and he slid some pictures across that, and he said, here's some pictures of some things I saw. And he wrote little notes to his daughter, and he says, I might not have the opportunity to give this to her right now, but someday I will. And I think that, and I could go on and on for this class, and really I could do a full 8-hour session to talk about the benefits. But I think that a lot of guys struggle with the concept of how can I have presence when I'm in my child's life, when I'm not even present in their life. And they really can. And if there's one conclusion that I think, and one result that I think that the curriculum really enlightens these guys to become aware of, is that they have an incredible presence in their child's life. They have the ability to have that, and they should have that, honestly. So yeah, and it's funny. There's a lot of guys, and I just it's one of the best things I've ever done. Like Denise said, this is my second job, so it's kind of a labor of love. I've traveled through snowstorms to get the Dawn Flag to teach the class in Bath, and but I think that it just gives guys an opportunity, it opens their eyes to be more involved in ways that they never have. I mean, there's a lot of guys that hand off responsibility to the mother figure in their child's life, and but the curriculum talks about feelings, and guys can do that too, and it's really important, and especially the single dads, because when I love talking to the single guys who really classify some things as what the female does or what the male does, and then I said, okay, so you're raising this child on your own, so who's going to do the female part? Well, I guess I have to. And so I really encourage anybody that has the opportunity to offer this curriculum to your catchment areas to really to give it a chance. And even in my personal experience, these guys will teach you a lot. I started this class as a single man. I became a married man while facilitating classes. I became a divorced husband and single father while doing these classes. And it's just a really awe-inspiring experience to see what guys will go through and to see what they'll tap into themselves, just to have an opportunity to be a part of the kid's life, what they really should have anyway. So, I could go on and on. I don't have any slides, but I just really am grateful for this opportunity to talk a little bit about something that I love very much. And I wrote a little note to Denise when I did my introduction. I have to give my son a shout out. This is Ian. He's 12 years old. He's the best guy ever. If you see Ian Martin in Augusta, tell him that he's got a great dad. And so I really appreciate the opportunity to speak to you all, and give dads a chance. We want to be involved in our kids' lives, and we want to do everything. Just I did, and I know that there's hundreds of guys out there that are just aching for that chance. So thank you.
John, I just want to share that there is a note of appreciation that's coming through the chat for you as well, and the massive amount of men that you've touched in Kennebec, Somerset counties. So some acknowledgements are coming through.
Well, I really appreciate that. I think that, and honestly, it's a little slight bit of soapboxing that, if Dawn can testify to this, I think that there are a lot of guys out there that are part of a system that really doesn't expect them to have huge amounts of involvement in their child's life, like every other weekend or, a few days a week. And there are a lot of capable fathers out there that are learning that they have the right, and they also have the will and the means to take care of their children. So give them an opportunity. And thank you so much, everybody.
And thank you, John. Oh my goodness, I couldn't agree more that in each and every single program that we facilitate, we learn too. And sometimes that's just a different perspective or way of looking at things that is so important. So I'm going to shift gears a little bit and tell you a little bit more about the other programs that the councils offer. Denise mentioned this, and I just wanted to kind of reinforce the fact that all of our programs are evidence-based, and they're offered at no cost to any parent or caregiver. We are currently holding these programs virtually, and ache for a time when we can return to in-person delivery. Maybe it will actually end up being a hybrid format, because Zoom works really well for some people, but certainly not everyone. We definitely try to seek to foster non-judgmental environments, and environments that include humor and laughter, so important, and environments that also build trust and camaraderie. We try to dispel the notion of perfection when that comes to parenting, because no one is perfect, and there's certainly no such thing as a perfect parent. And whenever I talk about this notion of perfection, I'm reminded of a quote that's actually in the curriculum for one of our active parenting programs. And that particular quote, just really seems to resonate with parents. It's the quote goes something along the lines of, children can often learn more from an imperfect parent who can show or model what it looks like to learn from mistakes than they'll ever learn from perfection. And just another related quote that I came across recently was, there's not one thing that we can do to be a perfect parent, and there are a million things that we can do to be a better parent or caregiver. So in terms of the format of all of our programs, they all utilize videos, guided discussions, individual and small group activities, and they provide opportunities for skill practice too. The program's publishers and we as facilitators don't attempt to define family. That's unique and deeply personal for everyone involved. We recognize that there are many differences among parents and within family relationships. And that may be cultural differences. It could be shorter or longer term relationships for parents. They may be married or not. They may be opposite or same sex, etc. All kinds of differences. Families look very different. And all of our programs are similar in that very inclusive definition of family. It's really important. So I would like to shift gears a little bit and tell you about our cooperative parenting program. This particular program is intended for parents or caregivers who find themselves in a co-parenting relationship. And a co-parenting relationship is defined as parenting with someone else who lives in a different house. So that can apply to people who are married, people who've never been married. It could be grandparents, it could be kin caregiving, and other types of caregivers as well. This program really helps parents become aware of how their actions affect their child, and it provides them with the skills that are necessary to maintain a child-focused relationship with their co-parent. Cooperative parenting is based on actually 5 simple steps. They are simple to outline, definitely easier to talk about than to put into practice. So step 1 is to keep your child out of the middle. And that really involves being sensitive to children's needs and having that child-focused, child-centered focus that I mentioned earlier. And one example of that may be, how can we shield children from loyalty binds that can cause children to feel like they have to choose between parents, or like they need to defend one parent to another. Step 2, allow your child to love both parents. Children have a bond with both parents, so it's important to demonstrate that there is value for the other parent and for that extended family as well. Step 3, work on your own recovery. Emotional recovery and the grief process will impact children's adjustment. Again, easier said than done, but this includes being willing to let go of the past and considering the concept of forgiveness. Step number 4 is develop new communication skills and a new means of communicating between homes. That includes conflict resolution skills and figuring out how can we get on the same page and stay there. Step number 5, create a positive new relationship as co-parents, one that is present focus versus past. And as part of that, we try, and as facilitators, we help parents shift and realign their role from partners to co-parents. And part of that has to do with recognizing the importance of clarifying boundaries. and also clarifying boundaries within that new relationship. The bottom line is co-parenting is forever, and the quality of that new relationship will have a significant impact on that child for a long time to come. A little bit of feedback that we recently received from our last program. Participants reported that they enjoyed the non-judgmental environment and the conversation that took place during the training. They also reported that they learned a lot about how separation impacts children in different ways, and oftentimes in ways that they never imagined. Several parents said that they were going to stop speaking poorly about their ex in front of their children, and that they now knew ways and methods and had skill sets that they could use to try to improve their relationship with the other parent. Couple of quotes. I liked learning that I wasn't alone, that other parents have the same challenges that I have. And I really appreciate the ability to connect with families and to be honest about my family in a safe and non-judgmental place. So that is what I wanted to share with you about cooperative parenting. And Wendy is now going to wrap the description of programs up with one more.
Thank you, Dawn. Yes, I am Wendy Pace. I am here representing the Prevention Council for Penobscot-Piscataquis County, and am very happy to talk about the nurturing program for families in substance abuse treatment and recovery. I know there's a lot of different curriculums, and we within our agency provide all of the classes that you've heard so far. However, this one for me is the one that's closest to my heart and that I personally get the most excited about and enjoy. I think one of the reasons for me is that this is a class that is really long in its sessions. It's a minimum of 17 weeks or 17 sessions. And typically by the end, we've maybe added a few more in, or sometimes they've really come together as a group and have asked to continue getting together afterwards. I think the intensity and the depth that and the way that this is laid out, building upon week after week, really kind of sets everybody in motion for really kind of growing and kind of expanding week to week. I think we spend a lot of time in that first class just kind of talking a lot about how this is really different than probably other parenting classes that maybe they've been in. And it's really an opportunity to be as vulnerable as they feel comfortable with, and really try to develop some good group cohesion and some very clear group goals and boundaries so that that can happen. Kind of talk about built into this curriculum and classes is a whole sense of creativity, and pulls in and plays on using that creativity to allow people to go deeper into their learning and their thinking, whether that's through painting or drawing or model clay or whatever that activity might be, to allow somebody to kind of be in the moment. And I find in classes that's where a lot of the learning and a lot of the sharing can naturally happen. It tends to also be a group that's very artistic and creative, and I'm typically blown away by the things that they create. The first class is all about hope, and that really sets the stage for me, I think, and sets the stage for what to expect during the classes. And I'll back up just a little bit. I think one of the other things, we all know it's hard to not know somebody that's impacted by substance use at this point. And typically classes can have partners involved, and it's a great opportunity for other perspectives to be realized, or an opportunity for some growth sometimes within couples and partners to kind of see different points of view. It can also be an opportunity for some couples who maybe got together during a time of using and have never gotten to know each other aside from using together, to really learn a little bit more about each other. And I think there have been times that some ahas have happened in class, some real personal sharing where all of a sudden the other partner is like, oh my gosh, I never knew that. How come you had never shared that? Or how is it we've been together for 4 years and we've never really talked about some of these things before? It's really, I have goosebumps just kind of talking about that. But I think for me, the hope activity, there's an activity in most of the classes, and the hope is really, lots of times people are coming to the class and dads are coming to class, or partners are coming, feeling rather defeated and rather hopeless, and, have burned so many bridges in their time, to be able to just kind of sit in that and talk about, like, what does hope look like, and what does repair look like, and what does restoration look like? So much of that is about themselves individually. How is that for their relationship, and how does that impact their parenting? So it's a pretty parallel process that kind of just flows between all of those three pieces throughout the whole curriculum. We spend a lot of time in the second class. The first four are my favorite. The second class around growth and trust, because recovery is such a dynamic process. There's so much time spent around, what does rebuilding that sense of trust look like? How do you kind of redefine who your identity is as a person, as a father, as a couple, as a mom, as a grandmother who's taking care of your grandchild? And how do you start figuring out how to reestablish your relationship within your family, or within your community, or within your environment? What does that really kind of look like? I think that usually by the fourth week, I know that Mindy had shared about the feelings activity. By the fourth week, the group typically has come together pretty well. They've really started to kind of know each other. Their guard's coming a little bit down. We do that similar activity in this class, and it is one of the favorites. And I think sometimes for some, it's the beginning of, they've never really stopped and thought about what their feelings are. And then it really generates a lot of conversation around big feelings that their children might be experiencing. And sometimes they have a harder time talking about their own feelings, but can go to talking about their children's feelings. And it's an opportunity to just pause for a moment. And I think one of the things I really love about this class is that it's less about helping provide answers to some of those tough parenting questions, but it's about pausing and helping them understand why the question is important. Like, what is it that you want to figure out with your child? What is it you want to figure out with you? And what do those big feelings kind of mean when they're happening in the moment? I just think as it builds and grows, you can see that communication starts to open up, and it builds as it's going on. We've had, within our community, we have had the pleasure of partnering with several of our medical treatment facilities, and some of those have been programs that are specific for in the dad's house or the women's house, or and I think that when they are also opened up to the community and allow everybody to come in, having all of those different options available can just benefit everybody to be able to have as many opportunities to participate and gather that information as possible. I think, I love that picture, Janice, thank you. I think that one of the things that we hear the most is piece of the work that happens in a thread throughout is that there's guided meditation that's built into the curriculums, and an opportunity to just kind of pause and refocus on themselves when they're starting to feel a little stressed or a little overwhelmed, and feel like they're regrounding and that they've kind of have a purpose and have like a refocus on their children and on themselves. I definitely would love to, I could talk more about this all day long. I just want to be sensitive of time too. Denise, I see the time. But I think, for me, this is one of the ones that I think we see the biggest difference with, and the commitment over time. I think sometimes parents can kind of fall in and out of classes. Life gets busy, life gets hectic. For us, if someone has made it past that third class for this curriculum, they're in it for the 17 weeks. They've called before and asked for help with transportation issues, or any challenges that might come up because they really want to be there. They're coming early, they're staying late, they're making some solid connections with some other people within the class. And you can really, over that 17 weeks or 18, 19, if we've added a couple extra ones into that, you can really kind of see that difference. And we've had a few classes where people have signed back up and done them again in like a year or two later, when they're in a different place in their recovery process, because they're in a different place with their development and really want to kind of rework and refocus on some of those areas.
Thank you. So I recognize we're very close for time. I will take a few minutes and respond to some of the questions that are in the chat. And if we have time for that, I'm looking for the thumbs up if we do or not. One of the questions specifically was around the nurturing program for families in recovery. It is listed, or the question is that considered a treatment? So it is considered a tertiary prevention program. However, many of our families that we are working with, in partnerships with and in collaborations with, it's an important component to respond to the needs in our community. So on the technical end of that, through nurturing, that curriculum is listed as tertiary. We do offer that in partnership as a way to respond to the community needs that are going on in each community. So it looks different. What councils offer look different from county to county. So that's one of the bigger questions. And I'll respond to some of the other ones as we go. Thank you very much for participating, and this conference has been phenomenal. So we appreciate everybody joining and being able to participate. I think some of the panel members also spoke about the different programs that the councils offer and the different aspects that are included in all the evidence-based curricula and programmings, bringing families together, looking at their unique circumstances and how diverse families are. Once families come into some of our programs, they really don't want to leave for the most part. They feel connected and uplifted to the other parents in their community. So just the connection serves as a wonderful opportunity. So.
I graduated high school. Nothing changed. It got a lot worse. I I tried to work. I had jobs. I lost them. I quit. I just ran the gamut. I in and out of jail, and it got worse. My drug use just continually got worse. In 2009, my daughter, she was just born, my daughter Brianna. Sorry, guys.
Hello, my name's Abby, and I'm a person in recovery.
And I'm Brian. I'm a person in long-term recovery, a father, and a businessman.
And we're a family in recovery. There were many times throughout my substance use that I yearned for things to be different, and certainly during my pregnancy, I carried just such immense guilt and shame with that. It drove me deeper into the only thing and the only way that I knew how to subside that emotional pain, which at the time was substances. It was within a jail cell here in Washington County where I was able to reflect on the extent and the harm that had been done to myself and those around me. My son was 11 months old at the time, and his 1-year birthday was quick approaching. You can imagine, as a mom and as a first-time mom, sitting in a jail cell in very early days in my recovery, considering that I might not be there for my son's first birthday, how that really compelled me to say, it's okay to ask for help, and there are people that are here to help you, and really recognize that I didn't know what I needed to begin this journey. I knew I wanted it, but I didn't know what I needed or how to get it. And that's where my journey began. And I'm so grateful for everyone that was part of those very early days and weeks and months in my journey of recovery. As my recovery progressed and time in recovery progressed, Brian and I met within the recovery community, and through our commitment to recovery and our engagement in recovery efforts for ourselves and for our community. And so that's really how my journey began, and how I came to know Brian was within that very community that we both found.
It was not an easy thing by any means. It's not easy, but I, much like Abby, I was introduced to the Washington County Drug Adult Treatment Court, and that gave me structure. I was given an ultimatum: you could go to prison, or you could do this, and I was ready. I was like, all right, I'm going to do this, and I'm going to stick around for my daughter and see her grow up.
So one of the things that I can remember so vividly early on in my recovery was the first time I ever was involved in a community event that included my son, our oldest now. And it was a children's parade, and I was about 3 months into my recovery, and I had never been involved in any sort of community event like that. And we were able to get him dressed up and get him in a wagon and walk down Main Street with other families and just really enjoy the moment and have fun and the feeling of enthusiasm wrapped around that. And it was the first time since my son had been born that I felt a sense of gratitude for being able to be present and be part of that moment. And ever since, there have been so many milestones and so many moments, being able to show up, being able to be a part of their Boy Scouts and their music concerts and the parent-teacher conferences and the sporting events.
For me, I knew that if I continued down the path that I was going, I wouldn't see those things. I wouldn't see those milestones, and I wouldn't be a part of it. So if you continue down the path of sobriety and staying sober, you will see those milestones. You'll be a part of those things. You'll get to hear about your boy's first crush. You'll see those things, and you'll see them you'll see them grow into the people that they will become.
There are so many men and women, moms and dads, pregnant and parenting, that are impacted by substance use disorder across our communities, across our state, and there is help. There's so much care and compassion out there, and breaking through that guilt and shame that I carried for so long and saying, I'm not alone in this. I know that there's others. I know there's people willing to help me through this, was just the open door that I needed to walk through to begin this journey of recovery. And so today, really recognizing that substance use disorder does not discriminate, whether it's a woman, a pregnant or parenting woman, or a father. It does not discriminate, and really recognizing that that substance use disorder needs to be treated equally, regardless of our roles as parents. But give yourself grace and be gentle with yourself.
Thank you so much. Yeah. Bye, guys.
Hi, everyone. Welcome back. That was an amazing 2 days. I cannot believe all that we were able to pack into that. I just wanted to say a quick thank you to all of our presenters, our folks who told their recovery stories, and of course, our planning committee. And I wanted to send a special thanks to Dara for pulling this all together for us. This was an amazing conference. I'm very proud of the work that the group has done to put this together. That being said, be looking in your email for the evaluations coming. And I also wanted to give a big, huge thank you to AdCare for the work that they've done to pull all this together. We couldn't have done this without you guys. So AdCare will be sending you the evaluations. And make sure when you go home tonight or turn off your computer tonight, you take a few minutes to reflect on what you saw today and yesterday and do some self-care activities. So until next year, I wanted to say thank you to everybody, and we will talk to you soon.